Do you also know how to pronounce?
Good morning. Hey there.
Gotta get my mini cup of coffee.
Yeah. Tight squeeze.
Sure about that.
No, I'm not.
Okay.
Great. And is the microphone working? Good. Terrific. Good morning. I'm Deborah DeVoe, Chair of the Massachusetts Health Policy Commission. On behalf of my fellow commissioners and the team at the HPC, welcome to the 11th Annual Cost Trends Hearing. Thank you also to representatives from CHIA, the Center for Health Information and Analysis, and from the Office of the Attorney General for participating today. And we're very honored to welcome Governor Maura Healey and Attorney General Andrea Campbell, who will speak shortly. I want to open by introducing the themes that are our focus today: affordability and equity. The HPC is recommending that the Commonwealth modernize the state's policy to focus on affordability and equity, in addition to our decade-long focus on cost trends. The HPC's 2023 Cost Trends Report documents the facts concerning affordability for residents, for businesses, and for providers. All who are paying for care and all providing it face tremendous challenges. Healthcare costs for families now are more than $25,000 annually. Many residents must choose between healthcare and other necessities. 50% of adults in Massachusetts report needing to forego or postpone necessary care in order to make ends meet. And there's an unequal burden of healthcare costs as disparities persist across income, race, and ethnicity groups. For those providing care, workforce shortages and broad inflationary headwinds challenge affordability, and providers are considering significant changes that have profound implications for care in our state: care delivery, care access, and costs. Closures, partnerships, expansions, and other investments are increasing and being proposed at a rapid pace. Today's hearing will focus on the underlying drivers of healthcare costs, and we will now add a focus on understanding affordability, how those costs are experienced by residents, employers, and providers. So today we'll look to discuss policy solutions needed to make progress on affordability and equity, in addition to our longtime focus on cost. Talk about both diagnosis, what's causing this, and treatment. What can we do? I want to thank all of those who are participating today for your consideration of the data and evidence, and for the dialogue to identify and discuss the actions that will enable us to make progress together. Now I'd like to introduce our Executive Director for the Health Policy Commission, David Sells, who's going to walk us through our agenda for today. David?
Great. Good morning. Good morning, commissioners. Good morning, Madam Chair. Thank you all for being with us today. I am David Seltz, the Executive Director of the Massachusetts Health Policy Commission, and it is really my pleasure to welcome you to the 11th Healthcare Cost Trends hearing. In addition to welcoming all of you here in person, we are also live streaming this event on our YouTube page. Thank you for attending and tuning in. Commissioners, state leaders, legislators, stakeholders, advocates, esteemed guests, and members of the public from here in Massachusetts and from across the country and the world. It is your participation and engagement in the work of the HPC that makes this annual hearing a truly unique, some may even say super event. I want to take a brief minute to acknowledge some of the leaders who are with us in person today. The chair of the Joint Committee on Healthcare Financing, Senator Friedman, and Representative Christine Barber, a member of the Joint Committee on Healthcare Financing. And I know that there are a number of staff from the State House here today and watching online, including from Speaker Mariano's office, Chair John Lawn's office, and Senate President Spoko's office. Thank you so much for being with us during this very busy time on Beacon Hill. We hope that this hearing aids you in your ongoing deliberation on potential legislative reforms to evolve and strengthen the nation-leading Massachusetts cost containment framework. And as always, the HPC stands ready as an objective, data-driven health policy resource. I also want to acknowledge our colleagues from the Center for Health Information and Analysis, or CHIA, and the Attorney General's office here with us today, Lauren Peters and Sandy Litsky. I also want to thank Suffolk University Law for hosting us again. We are so happy to be back here, and we appreciate the staff who help pull this event together every year. HPC has hosted this cost trends hearing every year since 2012. Our first hearing was at UMass Boston, a full 2-day event. Today, we just have one very packed day. And as required by Massachusetts law, the hearing is really an opportunity in which healthcare experts, public officials, private leaders come together to discuss the challenges facing our healthcare system, identify policy solutions, and commit to shared action and accountability. As Chair DeVoe said, this year marks an inflection point in the Commonwealth's journey, ambitious journey of healthcare reform, which has made it a national leader. The HPC's recently released report documented a number of alarming trends which left unaddressed would result in a healthcare system that is increasingly unaffordable for Massachusetts residents and businesses. We have already begun to see the impact of these trends in the avoidance of necessary care, increasing medical debt, widening disparities in health outcomes based on race, ethnicity, and income, and other important factors. So today's agenda was carefully crafted to spur dialogue about these complex dynamics, particularly the challenge of steadying a healthcare system still reeling from the after effects of a years-long pandemic, and at the same time when premium growth is exceeding wage growth for most Massachusetts residents. Achieving affordability and health equity must be a priority. This morning, in addition to hearing from the Honorable Attorney General and Governor, we will hear directly from community members, consumers, employers, and advocates with lived experience on their perspectives on the everyday impact of high and rising healthcare costs and persistent racial disparities in care and outcomes. We hope that by featuring these voices at the beginning of the day, their stories will provide the moral context and imperative for the day's discussion about how best to advance these shared goals. The morning session will also include a data presentation from the Health Policy Commission and CHIA on cost drivers and affordability trends, and a discussion with policy leaders on a range of solutions necessary to make progress. This afternoon, similar to past years, we will hear a presentation from the Attorney General's office on their annual healthcare cost trends special examination. This year, the AGO staff will be presenting findings from their new and very exciting comprehensive report on ground ambulance services in Massachusetts. This afternoon's agenda will also focus on 3 witness panels of healthcare leaders representing health plans, healthcare providers, hospitals, community health centers, and health systems who will be questioned under oath by the HPC commissioners on the role of health plans, the impact of a dynamic and rapidly changing provider market, and the outlook for the future. Throughout this day, we hope to examine both the challenges facing our system, but also the opportunities to move together with a renewed commitment to chart a path forward for healthcare reform in Massachusetts. Materials for today's events, including the full agenda of the day, the program book with bios of all the panelists and speakers, and the presentation slides are all available on our website right now. There's a direct link to those in the YouTube video if you are live streaming. Finally, I want to mention an important part of the hearing that happens ahead of time. In advance of the hearing each year, we solicit written testimony from a number of healthcare organizations. This year, we asked 31 organizations about their top strategies for reducing healthcare cost growth, promoting affordability, and advancing equity, among many other topics. A summary of those responses is included in your program book. And the full responses are posted online on our website. Thank you to all those organizations who thoughtfully responded to the HPC's questions this year. We also invite all interested members of the public to submit testimony into this hearing. If you would like to submit written testimony, please go to our website, and we ask that you submit that testimony by Friday, December 1st. And finally, we are live tweeting or Xing this event and encourage our viewers to get involved with us on our hashtag pound CTH23. So thank you, Chair DeVoe and HPC commissioners for leading today's discussion. I'm pleased to turn it over to HPC Vice Chair Marty Cohen to introduce our first esteemed guest.
Thank you, David. It is my pleasure to introduce our first honored speaker of the 2023 Cost Trends hearing, Attorney General Andrea Campbell. The Attorney General is not only one of the 3 appointing authorities to the Commission's board, excuse me, but her office holds a key role in the oversight and enforcement of healthcare organizations here in the Commonwealth. As such, the Attorney General plays a key role in ensuring that all residents have access to quality and cost-effective health care services. Prior to taking office in January, Attorney General Campbell served as General Counsel at the Metropolitan Area Planning Commission, legal counsel to former Governor Deval Patrick, and was the first Black woman to serve as Boston City Council President. Since taking office, she has prioritized efforts to tackle healthcare access and inequality. She established a new reproductive justice unit in the Attorney General's office, which is focused on protecting access to reproductive and gender-affirming care and working across state lines to respond to the national attacks on reproductive rights. Attorney General Campbell also established the Maternal Health Equity Grant Program, which has provided $1.5 million to nonprofit organizations providing cultural competent maternal health support services to Massachusetts residents. The work of her office frequently complements that of the HPC, as we will hear later today, and we appreciate the ongoing collaboration with the Attorney General and her team. It is my great pleasure to welcome and introduce Attorney General Andrea Campbell.
Thank you, Marty. Thank you, Marty, for that kind introduction. And of course, thank you for your leadership as one of our appointees. I also want to thank the chairwoman. Thank you for your leadership and your work. And of course, the executive director, David, just thank you for your energy, your passion, and of course, your entire staff for the work you do every single day. I also want to acknowledge, of course, Professor Alicia McGregor, who is one of our appointees, as well as David Cutler, who's also one of our appointees. Thank you for your work and leadership every single day. I know the governor will also be here, so I have to acknowledge her. I don't know if I'll see her, but we work in partnership on many issues, including these issues. And so I know that creating a more equitable health system is a priority for her and her team, as well as, of course, Secretary Walsh. So we look forward to working in partnership with her as well as her administration. I am pleased to appear before you for the first time, of course, as Attorney General, and I'm absolutely grateful to all of the healthcare leaders, community members, advocates, and state officials who have gathered here today. All of us have an important role to play in shaping and implementing a more affordable and accessible healthcare system. In the Attorney General's office, we will continue, of course, to work to promote healthcare affordability and access. We know a lot of folks are talking about the Supreme Court, but the number one issue and concern we're hearing from constituents is affordability. Everything is just too expensive, including the cost of healthcare. So what are we doing? First, we use our authority, of course, of the Consumer Protection and Behavioral Health Parity and False Claims laws to investigate and pursue unlawful conduct that makes it harder or more expensive to access healthcare. We will continue to use these important tools to hold bad actors accountable. It is significant work. Frankly, at moments, it's growing work within the office. Second, as you know, we review significant proposed healthcare market changes to ensure compliance with our antitrust, charities, and consumer protection laws. This is really important. And our goal is to do this work, this transactional work, making sure that we're including everyone in the conversation and having conversations that are robust, thoughtful, and not just reactive, but also proactive. We also, of course, have our Cost Trends Examination Authority, which is significant, and the average person doesn't know about it, but it is significant. And as many of you know, this authority allows our office to access documents, take testimony from healthcare market participants to inform our study of topics related to healthcare cost trends and its drivers. The AGO staff, past and present, have been doing this work and presenting their findings and recommendations from this work at different hearings for the last decade. Later this afternoon, you will hear, of course, from our team about our findings and recommendations as it relates to our new report on ambulance billing. I'm excited for that presentation and grateful to the leadership of AGA Lisa, who is sitting right here. Can you stand up, actually? Thank you. You can give her a round of applause. Lisa Gollin she works really hard. I always get the praise, but I don't do this work by myself, so I'm excited for her presentation. It was thoughtfully and well done. We have other tools in the office as well. This includes our helpline and mediation services dedicated, of course, to assisting people as they navigate working with insurance companies and so many others, which you know can be very daunting, especially if you don't speak English as a first language or have other disabilities. Our healthcare helpline handled over 2,000 calls last year. That will probably go up this year. We've also created, as Marty mentioned, new units. Our reproductive justice unit is new, as well as our elder justice unit. And all of these units are designed to make sure that as we do this work, that we are being collaborative across all divisions and bureaus and not siloed in the office. And these units will be critical, especially the reproductive justice unit, given the local and national conversations on these issues, and the elder justice unit. Every scam or every fraud or anything we are looking at, when we break it apart in terms of demographics, it is the elders that seem to be suffering the most. So this unit would be critical to working on these issues. Finally, I want to mention our AGO's grant work. We have our litigation tools, we have our policy and government tools, but folks don't understand we also have a grant-making tool, which is significant. Millions of dollars at our disposal to almost do whatever we want with them. So I'm proud to have worked with my incredible team in the office to launch in August a $1.5 million maternal health grant to organizations that are community-based to help those organizations address these disparities. And we were proud to award not only organizations on the ground, but every single county, except for Franklin County, and we are working on Franklin County. But every single county was a recipient of an award from this grant. In addition to all the tools I just mentioned in the ongoing work, there are some priority areas that we want to focus on. And we're going to have a strategic plan that we release very soon that will be public facing. One of those themes in the strategic plan will be everything having to do with the well-being of our kids. We often talk about our kids are suffering, a mental health crisis epidemic in Massachusetts, in this country. It is an epidemic. And we can't just talk about it. We have to prioritize it and take action steps. So I'm really proud that our strategic plan will include a lot of things that we can do in that regard. And as you know, we held Juul accountable, for example, for the company's role in the nationwide youth vaping epidemic. We're suing Meta for its contributions to the youth mental health crisis, for purposely designing applications they knew would be addictive and harmful to our kids. This is not just a priority for me as AG. I'm a mother of two young, and I will say beautiful young boys. I know many of us who do this work are parents, guardians, foster parents. And so this is significant for all of us. And we have a real opportunity to do some meaningful work in this space. We're also looking at emerging industries, mobile sports, gaming, and making sure we're advocating for our young people in those spaces. Maternal health and reproductive justice will also be a priority. Black birthing people in Massachusetts continue to experience the highest rates of labor and delivery complications compared to other races and ethnicities. And some of these numbers have actually gotten worse. This is a public health crisis. It's a top priority for the healthcare division and the reproductive justice unit in the office. And I've tasked actually our reproductive justice unit director, who we just announced, with looking at the full spectrum of reproductive care. It's not just about access to abortion. It's about maternal health. It's about comprehensive sex ed and so much more. As the Chief Law Enforcement Officer of the Commonwealth, my office deals with many issues related to public safety as well. And we believe that public safety is public health and public health is public safety. So we'll continue to tackle the issues related to the opioid crisis, monitoring all of the settlements we're getting and making sure that municipalities not only have access to those resources in a timely manner, but also have technical assistance working with the administration to deliver some real meaningful change to address the opioid crisis. We will also continue to get guns off the street, drugs off the street. That work sadly has not slowed down. And we pride ourselves on doing that work well, but also doing it from a regional perspective and working with other states and stakeholders across the Commonwealth and in other states, of course. And then lastly, I want to mention, because it's really important, I understand that there is a workforce development provider shortage issue in healthcare. And we want to show up, maybe it's not our specific lane, but we want to show up working with the administration and all of you on addressing those major issues, including with our union leaders and labor leaders. And we want to be at the table and continue to be at the table to address those issues. These are just some of the priorities that we envision taking on with all of you. And then the other piece that I think is really important is economics. Affordability, I mentioned, is a major issue. You will also see that reflected in our strategic plan. Every day, we're putting money back into the pockets of workers. We're taking on scams and fraud. Most folks don't necessarily know that, but it is significant work. But how can we do that work in a proactive way, not just in a reactive way? This, if we get at poverty, if we get at economics, if we get at the housing crisis, which we can do, we can really, of course, affect the social determinants of health. And we want to have a lane in sort of a pathway to helping you work on those issues as well. You will also see that reflected in our strategic plan. Before I close, I, of course, want to return to the office's cost trends report, which we released earlier this week on ambulance billing. You will hear, frankly, a great and robust presentation from Lisa on that. But the AGO, just so you know, has received hundreds of complaints from consumers related to ambulance billing. Many of these consumers have received unexpected bills, sometimes for thousands of dollars from ambulance providers. In emergency situations, patients, of course, do not get to choose which ambulance comes to provide them transportation. Patients don't know if their ambulance will be in their network or in their healthcare plan, or if it will be covered. Patients don't know if they will have their balance billed or face thousands of dollars in the form of payments towards their deductible. Some patients, of course, are afraid to accept needed emergency ambulance transportation out of fear it will lead to medical debt and bankruptcy. And this status quo should be unacceptable, of course, to everyone. So I'm excited for the work that will come out of this report and the recommendations, and look forward to working to implement some of those with each and every one of you. This work is a passion, of course, of all of you, and of course, the folks who are sitting behind me, but it's a passion for the folks in the office. I'm really proud to lead the best public law firm in the country. I see Mary over here, and she knows that to be true. The best public law firm in the country. Lawyers and staff who are overworked and underpaid, but who are dedicated and in this work for all the right reasons. And so we will do our part to make sure that patients, consumers who have a healthcare card can actually access affordable healthcare, and those who don't, that they get a healthcare card and access affordable healthcare. So thank you all so very much. Again, thank you to my specific appointees for the work you do. I know how busy you are. And thank you to all of you. And Chairwoman, good to see you, Deb. Thank you for everything. Thank you, David.
Thank you so much, Attorney General Campbell. And to your team, A-Team recruits A-Team, and we agree with you. They are phenomenal. Thank you for the clarity of your vision and also for your actions. We feel them, and we look forward to continued partnership with you. And now I'd like to introduce Commissioners McGregor and Blakeney, who will introduce our first panel.
All right. Thank you very much, Chair DeVoe. Good morning, everyone, and thanks so much for being here with us today. My name is Alicia McGregor, recently appointed member of the Board of Commissioners of the Health Policy Commission. Now, before I briefly introduce myself and our first panel, I'd like to take this opportunity to offer a tremendous thanks to the Attorney General for her remarks just now, which resonated with so many of us, and for her outstanding leadership and authentic commitment to centering equity in the work of the AG's office and across the health system in general. So thank you very much. And of course, personally, my deep gratitude, she just walked out the door, but my deep gratitude, of course, for appointing me to the board of the Health Policy Commission. It's truly an honor to serve the diverse constituencies of the Commonwealth of Massachusetts. Now, in my capacity as a board member, I serve as a member with expertise in consumer healthcare advocacy. And in that role, I not only look forward to speaking on behalf of the interests of the diverse communities of Massachusetts, but especially to speaking to and lifting up the issues that affect the most marginalized communities across the state. Now, I come to the HPC board with a background in healthcare politics, community health, health systems, and health equity. During my day job, which is actually also a night job and a weekend job, if you know anything about academia, I'm a faculty member at the Harvard Chan School in the Department of Health Policy and Management. And much of my current research focus is on trying to explain the causes and consequences of maternity ward closures and the loss of critical hospital service lines. Because we know that across the country where these closures occur are often in our most vulnerable communities. And speaking with respect to Massachusetts in particular, and the nation as a whole, we're facing a maternal health crisis that's characterized by vast racial and ethnic inequities in maternal mortality and morbidity, as the Attorney General just highlighted. And it's my hope that the evidence base that my research team and I and so many others are engaged in developing can really come to bear on helping to solve some of the issues that face the Commonwealth today, namely facility closures and the increasing rates of severe maternal morbidity, as well as large racial disparities in severe maternal morbidity that the most recent report out of the DPH just showed us so clearly. And when it comes to creating an evidence base, I'm a firm believer that we must start by going straight to the communities most affected. And with that, I'm excited to kick off today's discussion in the lived experiences of the members of communities right here in the Commonwealth. And I'd like to start by introducing our first group of panelists. Now, the first panel, called Community Voices on Health. Oh, am I still on?
Yeah.
So our first panel, called Community Voices on Healthcare Affordability and Equity, is intended to provide a platform for community members, employers, and advocates to share their experiences on the impact of our high and rising healthcare costs and persistent racial disparities in health. So without further ado, I'd like to introduce the panelists. I think at this moment, can you please come up to the front? So our four panelists will each provide their own testimonials, followed by a brief Q&A if time permits, or a brief moment to engage with the commissioners. So our first panelist is Pastor Florissant of the True Alliance Center. He's the president and the executive director there. Next, we will have Damaris Velasquez, the co-founder and director of programs at Agencia ALPHA, followed by Sheila Och, the chief engagement and equity officer at the Lowell Community Health Center, and also a member of the Health Equity Compact. And finally, we'll hear from Jose De La Rosa, who's the co-founder and CEO of Guardian Healthcare, and also a member of the Health Equity Compact. So I think first, we will start with Pastor Florissant. Thank you very much for being here.
Good morning. Thank you for having me. As Dr. Alicia just alluded. My name is Pastor Jufo Florissa. I'm commonly known by Pastor Kiki in my community, Executive Director of the True Alliance Center, a faith-based nonprofit created to promote advocacy in the Haitian community related to education, housing, immigration, health, and economic development. Thank you to the HPC for the opportunity to offer my insights into the healthcare affordability challenges and equity issues that I see in my community. I often engage at various wellness clinics, community resources, outreach events within the Haitian community, and also as some cultural celebrations and church celebrations as a pastor. And what I frequently hear from people is that they cannot afford the healthcare they need the most. As you know, healthcare is a necessity. Working family faces several barriers when paying for health insurance. The monthly premium for health insurance represents a significant portion of their disposable income, making it very difficult to afford. The high and rising premium and affordable copays at the pharmacy and doctor's offices are causing Haitian communities basically financial stress and creating barriers to access quality care. For many in my community, because healthcare is so expensive, they would rather wait until the last minute to seek care and treatments, which, as we know, often leads to more expensive emergency care down the line, both for patients as well as also for the system. Even with insurance, high deductibles and co-payments can be prohibitive, especially for plans with lower premiums. Families may have to pay thousands of dollars out of pocket before the insurance covers a significant portion of care. Additionally, many Haitian families have to work 2 or 3 jobs to support families here, Haiti, and as well in DR because of the unsafe conditions in Haiti. The high cost of living makes it extremely difficult for them to come up with the high copays, therefore reducing drastically the number of times they can take such vital medications they need. Premiums are another barrier to healthcare, as I said. Frequently, people are facing premiums so high they are going without health insurance altogether, and they prefer to fall under the hefty penalties based on the individual Massachusetts mandate. Or they are paying such high monthly premium, causing them hardships that they are struggling to meet other payments like rent, groceries, childcare, and bills. Other barriers include high deductible, as I said. And I'm here today with the hope that the Health Policy Commission, as well as the stakeholders here, understand how critical it is, healthcare it is for all residents, including working families. And my question, what will you do to help families alleviate the heavy burden of high cost that is becoming heavier yearly? Thank you so very much.
Thank you, Pastor. Good morning. I'm Damaris Velasquez, Director of Programs of Agencia Alpha. I'm originally from Guatemala. I lived in Massachusetts for 33 years. I was undocumented for 22. And when I became a citizen of this beautiful nation, I realized that my identity has not changed at all. I was who I am since I was born. And through that, I was able to understand that people's identity are greater than what a system can try to make them believe. And being undocumented, my friend and I co-founded Agencia Alpha 22 years ago, an agency that works providing legalization assistance to immigrants. But because of COVID, we realized how dangerous it was that our community did not have the right healthcare, and they didn't have the right information. They were so confused. They were afraid that looking for a good healthcare system would end up being a problem if they wanted to become a legalized or a resident or a citizen of the United States. So because of that, Agencia Alpha got involved in the healthcare field. So I have to admit that probably from this room, I'm the one that is in diapers when it comes to talking about these issues. But I had learned really quickly what's going on in our communities when in terms of healthcare. As Pastor Florissant said before, Agencia Alpha and True Alliance Center became together with other two organization sisters, and we created Equity Now and Beyond. And through that, we were able to bring information about COVID to our communities. We provided vaccines against COVID and a lot of education. And it is through that I have learned and I have heard what our communities are saying about the healthcare system. Number one, I want to thank the board for allowing us to do this. I want to thank everybody in this room for allowing us to bring this information. And I also want you to know that there are a lot of good things going on with the healthcare system. People are thankful. And we understand that if we compare with other states, we shouldn't compare with other states. We are fine to a point. But there are also a lot of things that we can improve and we can make better. And there is where I just want to bring the voices of my community. As Pastor Florissant was saying, how many of us woke up this morning thinking, do I pay the rent? Or do I pay the heat because it's getting cold? Or do I stop buying this at the grocery store? Forget healthcare. The premiums are just too high. How many of us wake up thinking like that? How many of us wake up thinking, if I want to have a coffee, I better make it at home because those $5 are going to help me to buy groceries for my children instead of buying one from Starbucks or Dunkin' Donuts that now is so expensive as well. So when we talk about health equity for all, I want to believe that there is where we want to get, where our parents don't have to worry about choosing between paying the premiums so they can be healthy and their children can be healthy, or having the money to pay the rent, which is ridiculous. Did you know that a family that lives in an apartment of one room, it's the two parents and the two children, they have to pay $3,000? I can't believe that. And so when you have to pay that and you add the fact that groceries are so expensive, when it comes to healthcare and the premiums, we know a lot of parents who just prefer not to enroll in Mass Health because they know that because they are working, they're going to be enrolled in the Healthcare Connector, and they're not going to be able to pay not even those premiums. And we know these parents, and they wait, as Pastor Florissant said, until they have to go to the emergency room. And then I think, what's going to happen to those kids if these parents get so sick? Who's going to take care of those kids? So the cost of the emergency room added to the fact that if these parents are not in the lives of these kids, who is going to pay for those kids? So this is what we are hearing in the community. And when it comes to oral health, oral care, that's not even a theme in their minds. I have met families who come to the office and their children or the parents are in pain because they have an infection in their mouth, and they were told at the clinic that only if they wait until they go to the emergency room, then maybe they can be seen. If we're talking about health care for all, we need to start realizing what is it that we need to do to make sure that if I feel comfortable going to work, knowing that if I have an accident, I am going to end up in the hospital and my health care will be covered. I want the same thing for my neighbor, even if my neighbor lives in a very low income town. So I do appreciate this opportunity because there are families, immigrant families that are working really hard. They've been working for many, many years. They're paying their taxes. And I feel like we're punishing them because we're asking them to work and succeed. But then when it comes to healthcare, they can't afford it. So they have to pay more at the end when they pay their taxes because they have to pay a penalty. So let's help these families to feel comfortable. It's okay if they can buy a coffee from a Starbucks, but at least it's better for them to know that their kids and their health are going to be fine. Thank you.
Good morning. everyone. I'm reflecting on what was just said, and the community health worker in me, I will say that I want to come help all those families navigate the system. But first, I want to start with expressing my gratitude for inviting us to this panel and to the organizers for making it so. I also want to say a special thanks to the Attorney General who just spoke for really setting an inspirational tone for our discussions throughout the day today. I know she's not here, but thank you to her. I'm Sheila Och, and I serve as the Chief Engagement and Equity Officer at Lowell Community Health Center. I'm also a community health worker. I'm a Spanish-speaking medical interpreter in our organization and in our community. I'm also a very proud member of the Health Equity Compact. I'm wearing my pin today. And we're a coalition of over 80 leaders of color across the state in various sectors, united in our pursuit to advance health equity. I'm here today to share my community perspective on the Commission's recommendations, the report that keeps getting mentioned, on addressing specifically social determinants of health investments, and our support for community-led initiatives and the importance of having a culturally proficient workforce in this discussion. As a community health worker in Lowell for over 20 years at this point, I can attest to the impact of the initiatives that I'm about to speak about. And Lowell, we are home to the second largest Cambodian population in the United States, and about half of our residents identify as being from the global majority. That's about 55,000 people. Coexisting with that incredible strength and richness are community health disparities across multiple categories. Systemic racism and the historical disinvestment in our community have exacerbated what we know as social vulnerabilities. And these things have made our health outcomes much worse. The CDC, Centers for Disease Control, the Social Vulnerability Index, sheds light on these key disparities on social determinants of health, particularly what Damaris just talked about, and the pastor on housing, transportation, and poverty. Our health center is located on a census tract that places us on the highest quartile for the index on social vulnerability at a 0.82. And we know that higher index scores are directly correlated with increased healthcare spending as well as poorer outcomes. Now, community health centers across the state of Massachusetts are innovating to tackle health disparities, and we are creating inclusive and integrated care models, all while balancing and tackling our workforce shortages that we're facing. As an example, we have a very special program at our health center called the Meta Health Center, and Meta is Buddhist Sanskrit for loving kindness and compassion. And that center offers holistic care to refugees and immigrants who have experienced trauma, including that of war and political unrest. As an example, we blend a global healthcare approach, providing primary care, behavioral health services, acupuncture, meditation, and community outreach. And our Meta patients demonstrate significant improvements in things like diabetes, depression, and PTSD. Now, the success of such program emphasized the crucial role of not only community health centers in this conversation, but also of our expanding of our care models, as well as fostering cultural proficiency, not only in healthcare, but within our workforce. Now, the Commission's report emphasizes the significance of supporting and investing in the healthcare workforce, and I happen to notice that there was a specific mention for community health workers in that CHWs, and also the promotion of workforce diversity. So I will say this, that as a community health worker, we play an essential role due to our strong community ties, our unwavering empathy, resilience, our skills, our knowledge, and our profound respect for the communities in which we work. Building trust with our community, particularly with communities of color, involving them in the decision-making, as well as fostering a culturally proficient workforce are paramount in addressing the health disparities that we're talking about and ensuring the success of all of our initiatives and interventions. National studies have demonstrated that CHW programs yield an average savings of $2,245 per patient. These programs not only improve health outcomes, but have significant financial benefit. As an example, our asthma project at the health center that I've been very involved in with a cadre of different community health workers helps to improve living conditions for low-income families and asthmatic children. resulting in an 81% reduction in emergency room visits for all 239 kids in that program. The same is true for the older adults in our program, and I would like to share a story of Savannah. Savannah in 2017 came to us. He's a 71-year-old patient who joined our program, was struggling with uncontrolled asthma that frequently necessitated multiple urgent care visits and emergency room visits. The community health worker that was working with this patient recognized his own commitment to his health, but noticed that needed a little bit more in terms of an integrated approach. So the CHW provided him with a spacer for his inhaler, which made an immediate difference. And then from there, practical tools like a HEPA vacuum cleaner, allergen-proof bedding, and a very personalized asthma action plan. Now, years later, in this past month, actually, in October, the CHW and the patient reunited, and the patient was able to acknowledge the impact that this program had had on his quality of life, reporting that he now is enjoying time with his grandkids, is free from asthma attacks. And all of this truly demonstrated the lasting impact that equity-centered interventions have on our patients and our communities. The project's success, however, is due to our dedicated community health workers who conducted home assessments, educational visits, and provided these resources. Now, if we look at this one single intervention, this one asthma program, this could have net a savings to the healthcare system of over $500,000, $500,000. Now, despite all this evidence that we have, securing adequate funding remains a challenge due to the historical lack of reimbursement and investments in this space, which means that for us, consistent financial backing is needed, and our current support relies truly on a patchwork of grants from various sources to keep these programs afloat. So the Commission's report, to me, offers really actionable solutions for strengthening the workforce, connecting with communities, and restoring trust in healthcare, plus promoting thriving communities. And to me, it emphasizes in addressing social determinants of health, promoting innovative strategies, and investing in our healthcare workforce. The Health Equity Compact that I'm a part of and very proud of, the priorities also echo these recommendations, emphasizing investments in public health, in the workforce infrastructure, and our health equity zones, which really are meant to empower community-led initiatives in our communities. In closing, I will say, as one of our patients stated, she says, "I've had depression all my life, but thanks to the help and support I received at Lowell Community Health Center, I've been able to raise my children and live a normal life. I consider myself one of the lucky ones." So now it's 2023, and getting access to care like this shouldn't be about luck, especially in a state like ours that have led the way in advancing healthcare for so long. So I feel we have a moral obligation to address these disparities and inequities in health, and our state has the opportunity to lead once again. Our objective is to give everyone an opportunity at a healthy life, and I think everyone in this room would agree with that. And to make this happen, I do feel that we need to let go of traditional healthcare funding models and invest in doing things slightly different. And David, you had said earlier, and I echo what you said, that it's time to turn our awareness into impactful action. And to echo our community, we now need the courage really to make the necessary decisions to doing so. Thank you so much for inviting me to speak today.
That was powerful. Thank you so much for the invitation. My name is Jose de la Rosa. I am a co-founder of Guardian Healthcare. It's a home care organization in Massachusetts with just a little bit over 500 employees. The majority of them are home health aides, nurses, as you know the title. As an immigrant, I have seen firsthand how difficult it is to work through the complexity of the healthcare system in the U.S. I was born in the Dominican Republic, but I call Boston home since 1989. I was invited to speak as an employer, but I have a small personal story to talk about. A couple of years ago, I started getting this pain in my back, and I complained to my doctor, my PCP. I told him that, I wanted to know more about what's going on. It's been over 2 years now, so can you please tell me what's going on? So my PCP said, okay, well, I think let's do a CT scan, find out what's going on. I mean, we want to make sure that, you have nothing going on in your chest and so on and so. So back in April, we set up the appointment. So I show up for my appointment, and just to find out that the insurance company rejected the service, no authorization, because they needed peer, forget what the terminology was. So they needed more information about my condition, what was going on. I was given the option, sign a waiver, $5,000 if the insurance company didn't pay for it. I was not stupid. Obviously, I didn't sign that form. So instead, what I did, I called a friend in the Dominican Republic, a doctor, and he was able to get me an appointment at a reputable hospital in DR. I flew in, took my daughters with me. For $300, I was able to get the same scan that, an abdominal CT scan that the insurance company in Boston rejected. I am sorry, but that is not fair. That is ridiculous. And although I could probably afford to pay the $5,000, I'm not that stupid to pay for it. And so shouldn't be none of my 500 employees. I think that was important to say on a personal level, because I believe that a lot of people do go through the same situation right here. And like Pastor said at the beginning, a lot of people forego getting, any type of healthcare, anything at this point, because for the same reason that they cannot afford it. As an employer, 500 employees, I hear stories about many of them, again, home health aides, that they have to pay about $200, $300 per paycheck to have insurance and coverage. That is, I'm sorry, but these are people that make $21, $22 an hour. I don't think it's affordable. It's impossible for them to pay $300 per paycheck. So as the CEO of the company, I decided to pay 75% of that cost. And it's a way not just to show appreciation for the employees, but I believe that it's an unfair system for them. But I believe it's a fair system for them to stay loyal to the company in a way, as they don't have to go to Medicaid or try to go, like the pastor said earlier, go without treatment because they cannot afford it. It is a very complex system. Immigrants face an uphill battle, especially for language, culture. I mean, they don't understand the culture. I didn't understand it at the beginning when I came in, very little English. But I got an education and I was able to navigate to the system and be able to understand it right now. But again, $5,000 for a waiver for a CT scan that, by the way, never got done. I think is outrageous. I think it's really not the United States of America. I'm sorry, I apologize for that, but it shouldn't be a system that we should all go through. So I really appreciate the time for you to listen to our stories. I think it was very powerful, to talk about how immigrants actually go through what they go through. I am one of them, and I could tell the story, just like I said. Right? Thank you so much.
Thank you so much for sharing your powerful stories and for all of the work that you do in your communities. Thank you very much. At this time, I'm going to pass it off to Commissioner Blakeney, who will pick up the rest of this discussion.
Thank you so much, Commissioner. And first of all, thank each and every one of you for very powerful testimony today. What I'm hearing, I think, from you, what I'm hearing from you each, I think individually and collectively, is our system is unsustainable for people of low income, for people struggling. It's mind-boggling to hear how expensive things are, basic health care are for anybody, but to especially hear from each of you the percentage cost that is pulled out of people's meager salaries and expecting them to, quote, do the right thing, to get preventive care before they get too sick when they can't, to be healthcare advocates when the system is so complex. Each one of you in your own way has expressed a component of that. While none of you specifically talked about your outrage, I think I feel it. I think you're being very polite. It's okay to be outraged. I think everyone in this room needs to be outraged, because outrage can lead us to action. Your comments today have a profound impact not only on the commissioners here, but on the staff, to try and continue to push for better solutions, to push for less costly care. Care denied, care delayed is essentially care denied. You've reminded us of that with tremendous precision and with heartfelt stories. You make the policy issues real. We can talk policy, we can talk numbers, and we do at the Commission. We do a lot of that. What you help us to do is to drive home the impact of that data with these stories. And from the bottom of my heart, I thank each and every one of you for being here today and for sharing so clearly and so basically your lived experience as well as the lived experience of the people whom you represent. So thank you all very much on behalf of the Commission. I wish we had time for questions. We have time for one? Okay, one question. Let's make it a very good one. Shall we make it a reflection? A reflection. Time for one commissioner to offer a profoundly important reflection. No pressure, ladies and gentlemen.
Just did, Barbara.
It's not gonna be profound, it's gonna be specific. I'm, as the resident regulator here, I'm very interested in the opportunities we have to both convene, cajole, but also compensate for community health workers. And I think it's way too episodic. And I wrote down the study that you referenced, and I'll chat with the staff about it. But trying to think about ways to mainstream that capability into care delivery, because I think many of us do that work for elderly parents. I mean, it's not just new arrivals, it's not people of color. This system requires navigation, even for people who've worked in it their entire career. And so wondering about the way to do that. And what I worry about is, we tend to sort of overregulate requirements for roles. We tend to, we're very degree happy in our state, lots of great universities. Like if we could do one thing to further development of community health workers across the range of organizations you guys represent, what would you ask us to do?
Secretary Walsh, thank you so much, and for the question. And I think it's really investing differently. We know what the savings are, and we really just need to have the courage to say this is how we're going to invest our dollars, and really focusing in whether it's a navigation and on the upstream of what we're working on. We like I mentioned, it's a patchwork of grants for many of us. So we have excellent programs, incredible evidence, and then funding ends. And then there's no continuity. And then what happens is for many of our, and I can say for our health center, sometimes we have to invest into those interventions, but we're not getting reimbursement for any of that. So I think it's really looking at ways that we can shift the investment, that we can broaden that so that we can offer that. Now, I will say for community health workers in the state of Massachusetts, there's a board of certification of community health workers, so there's certification at a state level that requires 10 different core competencies for CHWs, accompanied with education that they go through a certificate program in certified training centers, if you would. So they already come with that to the organization. And you're absolutely correct that it is not only communities of color, but all communities, because the navigation that needs to happen and the education is incredible. And then what also happens is, as we're thinking of the workforce shortages in the clinical sector, whether it's providers or nurses or medical assistants, when we have community health workers be able to assist within their scope in areas around patient education and the navigation, it really frees up our other members of our team to do what is within their scope as well. So the savings it comes in as all inclusive of all of that. So my recommendation is really shifting how we invest those dollars.
I want to thank the panel very much. I wish we had time for more dialogue. It seems that we never do. But thank you all very much. You've been heard. I want you to know you have been heard. Thank you.
I'll add my thanks to the panelists, and thank you also for creating the pH balance and the context for the rest of our discussions today at the hearings. Much appreciated. I am now very honored to welcome the Honorable Maura Healey, who will provide the keynote at today's hearing. Welcome, Governor. Since taking office as Attorney General in 2015 and now as our governor, Governor Healey has focused on tackling escalating healthcare costs and fighting to ensure that patients across Massachusetts are receiving the best possible care. She's a strong advocate for Massachusetts consumers and understands the importance of community engagement and policy action to improve healthcare affordability and equity. As governor, she's ordered a statewide maternal health review focused on equitable, accessible care, and is making critical investments to bolster the state's behavioral health workforce. We very much appreciate the working relationship that the HPC has had with Governor Healey and her team over the past 8 years as both Attorney General and now Governor. Thank you, Governor, and we look forward to hearing your thoughts on healthcare in the Commonwealth and the outlook for the future.
Well, good morning, Madam Chair. Great to be with you. Great to see all of you, some familiar faces and former colleagues and present colleagues and new faces. So it's an honor for me to be able to testify here, albeit in a different capacity as governor. I want to begin also by acknowledging and thanking in particular our fabulous Secretary of Health and Human Services, Kate Walsh. I want to thank you, Kate, and the work of the HHS team represented here on so many fronts. So thank you, team, for all the work that you do. And also thank you to our administration and finance team, Secretary Matt Gorkaritz, represented here today by Martha Gwozniak, our General Counsel of ANF. Thank you, Martha. It's been a pleasure for me to be able to appear as Attorney General in the past, and I am grateful for this opportunity. I want to recognize in particular your Executive Director, David Seltz. It's good to see you this morning, David, and members of the team of the HPC, as well as members of the HPC Advisory Council. My colleague in government and our fantastic Attorney General, Andrea Campbell, I want to thank for her partnership and the work that she and her team are doing on consumer costs. I just briefly read the report and look forward to hearing more about what the AG's office has studied and uncovered. Our partners who are here from the legislature, in particular, Chair Friedman, Chair Lon, thank you for the continued work and focus and attention on healthcare. Leaders from our Health Equity Compact who work across so many sectors to make our systems and outcomes more equitable, and all of the healthcare providers and policy experts who are here today working to improve systems every day. I want to start by acknowledging and thank you for having the first panel this morning be focused on lifting up voices from community. I want to thank the community members who spoke. They represent the experiences of so many people in Massachusetts, and it's so important that we all remember and focus on those experiences as we think through decisions around policy, because we never want to become desensitized to the complexities of the system when we talk about healthcare policy. We always must remember we're talking about real people with real needs. Numbers and graphs, tables, all of that is really, really important. And also it's really important that we remind ourselves about what it's like to be unable to see a doctor for a chronic condition, what that's going to mean in terms of having you miss work, what it's like for parents right now who are struggling to get behavioral health services for their kids, services abruptly closing in communities, what that means, what that looks like, what that results in. Families right now, particularly as we face a cold winter, having to think about cutting budgets for food, small businesses, having to lay off people because of rising costs and increased premiums. So, all of that is important. And I appreciate the opportunity you gave for people to tell their stories. I think collectively it is these experiences, these people who bring us together, who drive our work and lead us into the various realms that we occupy. They're the reason also that we can't afford to perpetuate the status quo. And what we rightly celebrate as our world-leading health system in Massachusetts, it's something that must be a lived reality for every single resident every single day. Lived experience is also at the heart of each of the themes I want to briefly touch on today around affordability, competitiveness, and equity. Those are the touchstones of our administration, and you have heard us list those time and time again, and I really believe in them. When I think about affordability, I think about the fact that for households in Massachusetts, healthcare costs are part of a broad cost of living increase. It is one of the most pressing challenges we face as a state. It's why we've advanced a comprehensive affordability agenda out of our office, working with our partners in the legislature. We were able to do a few things already, making school meals, both breakfast and lunch, free for every public school kid in the Commonwealth, making community college free for students aged 25 years and older, making the investment of $500 million to expand affordable childcare and better pay our early education workforce, paying off student loans for nearly 3,000 workers in primary care and behavioral health care, with another round of awards on the way through mass repay programming. And we passed the first major tax cuts in Massachusetts in over 20 years, saving money, real money, for households and businesses across the state. Thanks to these tax cuts, Massachusetts now has the most generous universal child tax credit of any state in the country. Moving forward, we recently announced a proposed historic $4.1 billion Affordable Homes Act, a housing bond bill that's working to increase production and lower the cost of housing statewide, which we know and all recognize is a social determinant of health and absolutely a fundamental health issue. These steps taken together will work to take pressure off of families who are being squeezed by healthcare premiums and help to address social determinants of health. At the same time, healthcare costs themselves are integral to our affordability challenge. In 2021, 41% of Massachusetts residents reported affordability issues ranging from family medical debt to high out-of-pocket spending. That's almost half of families are reporting a direct tie their affordability to health-related issues. And it's clear that rising costs in our system are impacting, of course, families who can least afford another hit to their household budgets. Currently, there are nearly 200,000 residents who benefit from expanded ACA subsidies through the American Rescue Plan and the Inflation Reduction Act, and congressional action is needed to sustain these important federal supports past 2025. I'm proud to have signed the historic 2-year pilot expansion of the Connector Care program into law in our FY24 budget. It shapes the affordability landscape for low and moderate income residents, and it represents the first expansion of state-funded affordability supports at the Connector since Chapter 58 was enacted in 2006. I touched on affordability. I also want to focus on competitiveness because rising healthcare costs are also very much a competitiveness issue. We're focusing on making Massachusetts a great place to live, to work, to grow a business, to raise a family. And I spent a lot of time saying those words as the cheerleader that I am for this great state. And I believe it. But I believe making life more affordable for folks is essential, and making us more competitive as a state is essential. We're rightly proud of our first in the nation universal healthcare system. You know, we pioneered it here. So many in this room worked so hard for that end. It's a big deal. And look at what it has made possible and led to around this country. We also need to make sure that we're taking stock and providing real value for every family and business in our state. I know small businesses are looking for relief, and we're proud to partner with the Connector on initiatives like the Health Connector for Business. The HCB provides unique shopping opportunities for employers that have resulted in significantly lower average premiums than the rest of the Massachusetts small group market. We also have new help in the pipeline. The Connector has been partnering with the Health Policy Commission to explore higher value plan options for small businesses and individuals. These are plans that meet affordability targets and are branded to help highlight their competitiveness premiums. We look forward to working with our small business leaders to develop this option into a meaningful solution that delivers real results. My third and perhaps most important theme today is equity. Disparities in health outcomes stem from inequities in the healthcare access system. And as you will hear again and again today, affordability and equity are two sides, of course, of the same coin. I mentioned that 41% of folks report their family struggles with affordability issues. For Black, multiracial, and Hispanic communities, that figure rises to over half of all individuals surveyed. Residents of color, we know, are more likely to be uninsured. And those who are insured are increasingly only able to afford health plans with high cost sharing. Sometimes this means that you can afford the plan, but you can't afford to use it. That's a systemic flaw, disproportionately, of course, impacting residents of color, and we need to fix it. We also know that Massachusetts, like other parts of the country, we have a situation where commercial healthcare spending is flowing disproportionately to the highest income, most well-resourced communities. Providers like our community health centers that care for lower income, more diverse populations are consistently at the low end of provider payment differentials. That means that fewer resources are available for care in those communities. We know our community-based providers are the backbone of access in our state, especially for underserved populations. Their stability and their sustainability is critical. We're fortunate to have Connector Care in the ACA, and we will continue to build on these strengths. However, we know we can't subsidize our way out of healthcare costs that are too high and rising too fast. We have to address the root causes of cost increases. We need to recognize the real financial stress among many of our healthcare providers, from our community hospitals to nursing homes. We need structural solutions to bring greater stability and value across the board for everyone. It's vital for the economy and for the competitiveness of our state. For these reasons, I support HPC's recommendation and the legislature's efforts to update our state's healthcare benchmark framework, to update that framework to prioritize affordability and equity. I support addressing gaps in transparency among the drivers of healthcare costs. That means leveling the playing field regarding transparency for major components of premiums and sharpening tools at the HPC and the DOI for understanding and addressing key drivers of premium growth. Ultimately, I support the long-term prioritization of how we're spending by investing in behavioral health, primary care, and the social determinants of health. And one important way and essential way, necessary thing we need to do to advance these goals is to work to diversify the healthcare workforce and create new pipelines from the very communities we seek to better serve. Early this summer, we launched a development portal called Mass Talent to create access to and expand career training in partnership with employers. We started with healthcare, the life sciences, clean energy, and advanced manufacturing. Rooting these pipelines in underserved communities will address well-documented labor needs, real labor needs in the healthcare sector. It will also create much-needed access to good-paying jobs and careers. And importantly, it will help us provide care that is more effective because it is more culturally competent and patient-centered. In conclusion, I'd offer that we know that only equity can unlock systemic success. And the truth is we have shown what that looks like in Massachusetts. Our focus on equity in the distribution of COVID vaccines, for example, put us near the top for vaccine uptake nationwide. The community-based partnerships which enabled that success also contributed to the NIH decision this fall to name us as one of 3 ARPA-H hubs in the country. This, of course, being the federal government's Moonshot program to transform healthcare. We are, Massachusetts, a national model. We have the best healthcare system in the country in many ways, but we hold our system, as we must, to a higher standard than what other states are doing. Our standard must be healthcare that's affordable, accessible, and equitable for everybody across the state. That's the goal of our administration and team, and it's a goal so many of us share. So I'm here today to keep listening and learning, to roll up our sleeves, and today and every day work with our team in partnering with you in our healthcare community on solutions. Thank you again for the important work you do to inform policy conversations and keep cost containment, affordability, and health equity at the center of our state's commitment to excellence in health. I'd be happy to take questions and continue the conversation. And again, thank you for convening.
Thank you so much, Governor. Do we have questions for the governor? Anyone?
I have a question and also a comment. First of all, thank you so much, Governor, for your remarks and for your work. My first point is actually just a comment. So thank you for highlighting the vast disparities that we see across communities, with our low-income communities being much more likely to have no dollars being spent on their behalf, particularly for primary care and preventative care. And this is something that was highlighted in the cost trends report, and really something that's been kind of etched in my memory, just the graph itself. And then, of course, the testimonials shared by our first panel really kind of brought that to light, the kinds of trade-offs that individuals and families make when deciding whether to go and seek primary care. So my question, just with my background in maternal health and maternity wards, is around your administration's commitment to review maternal health and maternity care access in the state. Could you speak a bit to what that would look like? Thank you.
No, thank you so much, Dr. McGregor. And I appreciate the question. As you know, this is something that has been the focus of our team under Secretary Walsh's leadership. And earlier this year, we announced that we were undertaking a study of what's happening with maternal health in the state. There's another study we're looking at in terms of what's happening with healthcare sort of regionally. And obviously, this follows in the wake of certain closures and activity within the healthcare space across the Commonwealth. So, this is an area that our team is very much focused on and identifying what we need to do to address the very disparities that you mentioned. Part of it is also a look at some of the things that are present, not just with a birthing person in regards to their pregnancy, but things like hypertension and other, comorbidities that are present. And this, I think, gets to the important emphasis that we need to place on primary care, access to primary care. It certainly gets to the social determinants of health and something that we focus on. I know the Attorney General's office focuses on that. This administration focuses on that. What are the drivers there? So, those are some things, hypertension, obesity, substance use disorder, all factors here when we're having discussions about maternal health and disparities and access to care and ultimately the outcomes, right, that you speak of. So those are some of the things that we're focused on. What are the earlier interventions that we can identify? So it's not limited, of course, to labor and delivery. It's everything along the way in terms of access to prenatal care. That's how our team sees it. And we need also to have the workforce there to be able to provide that care. So it's not just physical plant, it's the workforce able to provide that care in a culturally competent way, and to address the many needs that people have along the spectrum of any pregnancy, and dealing with the indicators that people present with in terms of some of the things I mentioned. So that's really what we're focused on right now. We hope to be out with that shortly, thanks to the work of our team, the Department of Public Health, in consultation with experts and stakeholders around the state. But, my view is, I want to do everything we can to address health disparities generally, of course, but we just should not have disparities when it comes to maternal health in this state.
Thank you very much.
Thank you.
Questions? Can I? Please. Governor, thank you for being here. I wanted to ask, and I know this is a lot of the work that you've been doing regarding the migrant situation, but certainly I'm from Worcester, and homelessness is a huge issue, as it is throughout Massachusetts. Our family shelters are to the brim, and certainly our overall individual homelessness is continues to rise. And so what are some of the plans? And I know you talked about them, but we feel like we're sort of stagnant in the sense that we don't know what the next step will be, and where do we put people, and trying to figure that out. If you can just give some advice on that.
Sure. And maybe I'd separate it. There's the issue with respect to emergency shelter and the advent of just this exponential increase, driven really through the arrival of new families into Massachusetts who've come over the border of the United States. And then there's the issue of houselessness and housing insecurity generally. And one of the reasons I went big with the housing bond bill is because this is a challenge. It's a challenge. We need better public housing, which is state funded. Not all states fund public housing. We've got 43,000 units right now, public housing, state public housing, that we need to modernize and make sure is populated, is used. We also need more affordable housing. We need more market rate housing. We need more supportive housing. But the reason I mention this is because the fact of the matter is, across the state, it's Worcester, Central Mass, it's everywhere in this state. We don't have enough housing. Okay. And that's why we need action on the Affordable Homes Act. it's also why we have prioritized affordability as an agenda out of this administration. There's a reason why we did free school meals, and thank you to the legislature for their partnership. But, parents this morning, it means something that they don't have to think about the cost of breakfast and lunch for their children. These things add up. Free community college, paying off student loans. So driving that affordability agenda is so, so important. With respect to the current situation, I commend the teams, both in our administration, in HHS, but across many cabinets within the Secretariat who've worked on this issue, importantly in partnership with our service providers, with our healthcare providers, with others in community, faith community, to do really heroic work. The fact is right now we've got we're coming up on 7,500 families. We did something different in this state that other states have not done. We opened up welcoming centers. We continue to make sure, even though as capacity is really being reached, that everyone who comes into the system is given food, is given diapers, is given a thorough medical assessment. So there's triaging. As folks may know, half the population in emergency shelter right now are children. We're very, very attentive to that. And so I am proud of the work that has been done to make sure that we are giving people clothing with winter. We have cold 37 degrees this morning. So these things are happening. They will continue to happen. It's also the case I continue to ask for federal funding and support for the Biden administration, and also for Congress to act on the proposed appropriation for interior states like Massachusetts for funding to support these extraordinary numbers. Yesterday, I announced that the United Way was going to help us out by administering $5 million that we were able to get from the federal government through HUD that will be distributed now to other providers who may be able to step forward and create more housing in the meantime. The final piece on this, I'd say, is the exit is very important. We have families. This has been an overburdened system for a long time, and we've had families who've been stuck in shelter for months, for a year and a half. So how do we work to get them the supports, to get them exited? Part of this is increasing the vouchers, which we have done. It's also the case that we need more housing because we need to lower the cost for rent so that those vouchers can be used. But we did increase housing voucher rates. We increased funds for home base. These are programs to help relocate, resituate families. It's also why we've invested a lot in work, giving people work opportunities, and particularly for new arrivals. One of the reasons I've been demanding of the Biden administration work authorizations is because people want to work. And in response, the Biden administration is having Department of Homeland Security members here on the ground in Massachusetts next week. They will help us to expedite the processing of work authorizations. That is good. We've also set up other programs, which we announced a couple weeks ago, that will get more people working, again, helping them build that resilience and helping to exit from shelter and free up capacity. It is a challenging situation. And again, I appreciate the partnership of so many who have stepped forward, and we will do everything we can to make sure that people are cared for in this state while acknowledging, the reality of what we're seeing on the ground. And, I hope to have, we will continue to brief people through General Rice as we go forward.
Thank you.
Can you take one last question, Governor? Do you have
Of
time?
course, it's
One more question from any commissioner? Thank you so much. Thank you for your deep knowledge and understanding and priorities in healthcare, but also for putting our conversation into the broader context of competitiveness for our state and how key affordability in healthcare is to families being able to live and work and stay here. Thank you so much.
Great.
So honored to have you as our
well,
governor.
Thank you, Chair. Thank you, members of the commission, and big time thank you to members of our administration, Health and Human Services, and others, A&F, but especially the HHS team who stand ready to work in partnership with all of you. There's a lot we got to do. I know we can do it, working together, inside, outside of government, but we want to bring a laser focus and intentionality because our residents deserve it, and I know it's what our state has always been about. So thank you.
Wonderful. Thank you. And let me just comment that as people need to get up, stretch your legs, grab coffee, please do so. We decided not to build in a break this morning, so we'll go right through until a lunch break at 12. But please don't hesitate to take a mini break yourselves. Now I'm delighted to turn our agenda over to David Seltz, David Auerbach, and Caitlin Sullivan to present our HPC policy recommendations and reporting.
Great. Thank you, Madam Chair. And first, let me just, again, a note of gratitude and thanks to both the Attorney General and to the Governor for being here and sharing your really inspiring remarks and perspectives and your priorities about moving forward. I think both the Attorney General and the Governor spoke around that we can't perpetuate the status quo. And I think this next presentation will continue to underline some of those themes we've already heard this morning. I also want to acknowledge and build off of something the Governor said, which is to the great partnership that the Health Policy Commission has forged with the Executive Office of Health and Human Services. And I'm so grateful for the partnership and friendship with you, Secretary Walsh, and your leadership over the past 8 months, and especially your incredible team, many of whom are here today. And it's been fun. It's been really, it's been a real honor to work with such inspiring,
You really have to get out more.
incredible public servants, all really working hard to do the right thing by the residents of the Commonwealth. It's what inspires me in my job, and I'm grateful to have such incredible colleagues. I also want to recognize Chair John Lawn from the Healthcare Financing Committee, who is here with us today. Thank you so much for being here, and I know you have a busy day on the Hill. So one of the hallmarks of the successful Massachusetts healthcare policy experiment is the collective ability to use objective healthcare data as a foundation for policymaking. Very few states in the country have the data assets available to them that we are able to leverage here in Massachusetts. A credit to a nearly decade plus efforts by our state legislature, our healthcare providers and health plans, of course, the Center for Health Information and Analysis, EOHHS, DPH, the Attorney General's Office, and the Health Policy Commission all contribute to the data that helps inform all of our work. This data helps us identify what are the drivers of healthcare spending, the opportunities for savings, and the persistent inequities that underlie our system. So it is now my pleasure to introduce my friend and yours, Dr. David Auerbach, Senior Director of the Research and Cost Trends team at the HPC, to review the latest data on healthcare spending and affordability trends in our state. We are also grateful to be joined by Caitlin Sullivan, Deputy Executive Director at SHIA, who will share more about the shared focus among our two agencies on the topic of affordability. And then finally, I will join the panel at the end to discuss the HPC's 2023 policy recommendations released this fall, which provide a comprehensive roadmap for future reforms. So with that, I will turn it over to you, David.
Okay, thank you very much. Good morning, commissioners. I'm happy to give this presentation today with a focus on affordability. And I'm also thrilled that so many of the same themes that I'll be showing with data have already been talked about by the panel, by the governor, by the attorney general. You'll see the same things. Okay. How does it advance?
Big
Okay.
green button.
The big green button. Thank you.
David,
Okay, a
would you pull the microphone closer, please?
little bit closer, yep.
Thank you.
Okay. Okay, let's start with our record of performance against the benchmark to date up through 2021. You can see here the benchmark is that line in the orange at 3.6% and then 3.1% for the last several years. And you see that our spending growth has been above the benchmark for the last 4 years. And I'm averaging 2020 and 2021 together to smooth out that COVID pattern that you see. But our spending growth averaged 3.2% from 2019 to 2021, just slightly above the benchmark. But you see on this trend that in the commercial market, we really were far above that. Here we're showing annual growth in commercial health spending in Massachusetts in the orange and in the rest of the country in the blue. And you see that our trend was below the US average, our growth from 2013 to 2018. But that has not been the case for the last several years. We shot up and really our commercial spending growth was almost double the US average from 2019 to 2021 at about 5.8% annual growth. This slide from CHIA's annual report is showing that commercial health spending growth, and you see in the blue for self-insured employers and in the orange for fully insured employers, premiums, that growth from 2019 to 2021 was faster than wages and salaries, faster than inflation. That's important. That means more of our income is going to healthcare, a higher proportion. And putting that in the context of this longer run trend, which we can extend out to 2022, you see the growth in total family premiums was 218% over this long time series. That's twice as fast as the growth in household income and 3 times as fast as inflation. And that premium growth has come even as deductibles have grown. When deductibles grow, that should subtract from the premium because we are shifting the costs from covered spending to out-of-pocket spending. So this is going on simultaneously. You see from 2019 to 21, the percent of individuals with high deductible plans continued to grow, reaching 43% by 2021 overall. And it's much higher for smaller employees. For our smaller businesses, you can see the small group up there, 72% have high deductible plans. That's the majority. So taking all these trends, where does that leave us in terms of healthcare spending and healthcare costs? So by 2022, that amounts to combining the $23,000 average family premium and average out-of-pocket spending you see there of $2,680. The total cost of healthcare for a family in Massachusetts is over $26,000 last year. That's 2022. It's even higher today, of course. Nationally, premiums rose 7% more in 2023, so we're probably up to $27,000, $28,000 today. That's a monthly cost of over $2,000 per family. And that's just the average. We should also be thinking about some people face premiums and cost sharing that are much higher than that. This is showing the range of some of those premiums in Massachusetts for those with employer insurance. The median premium was $23,000, but 10% of families have a premium of more than $31,000, some as high as $40,000. The median deductible is $2,900 for a family, but 10% of families face a deductible of more than $7,000 per year. And out-of-pocket maximums can be as high as $14,000 or more. That's a tremendous amount of cost sharing. So back to this average of $26,000, which is almost as high as some people's full-time earnings. Where is that money coming from for an average family? You see the biggest portion is that blue. That's the employer contribution. We heard about that this morning. That is money that is paid by the employer, but it is all coming out of the same funds that pay our salaries and wages. And researchers have found that $1 paid in employer premium is $1 we don't get in wages. It's the same pot of money. So we are all paying that money. The orange is the employee premium portion, which is also quite high, as we heard this morning, for a lot of employees and a lot of small businesses. That's about 25% of the total premium cost, and you see that there. And it's deducted from the paychecks when people buy insurance from their employer. And then you see the cost sharing, the out-of-pocket, the deductibles, the co-pays, in that orange portion on the right, the yellow portion. Okay, there's the $26,000 that each family is paying on average per year. And where's that money going? Throughout the healthcare system, and this is data from CHIA, about $10,000 of that $26,000 goes to hospitals, combining both inpatient and outpatient. So again, that's $10,000 per family per year going to hospitals, about $840 per month. And then you see the other parts of the healthcare system, physicians, prescription drugs, other professionals, other healthcare costs, and then the insurer administrative costs and commissions in that green portion on the right. And let's look at this amount, this spending in the context of a family budget, which we've heard a lot about today. This is a tough equation. What I'm showing is the income of 4 representative families of 4 in the blue, and then a typical average budget of the cost of living for a Boston area family. Again, a family of 4 on the right. And you see the stacked up costs, average cost of housing, food, childcare, transportation, other necessities. And this is just the cost of living. This is not discretionary stuff. And then healthcare is stacked on the top there in the green and the orange. And you see that you have to be at about 5 times the federal poverty level to afford this cost of living. If you're a 2-income family comprised of a nursing assistant and a construction worker, you're below that. A medical assistant and a janitor, you're far below that. And if you're living at 300% of the federal poverty level, it is really hard to make ends meet and do those jobs that we rely on and live in the Boston metro area. Very hard. And healthcare costs add to that, of course. And another consequence of these healthcare costs we saw in a national survey in 2023 by the Commonwealth Fund. And we heard about this morning as well. Some families are considering dropping health insurance altogether. It's just too much. 15% of families said that they considered that, and 4% in this national survey said they actually did drop insurance. You have about 30% of such families carrying medical debt. And of those in the lower income range, it's 35%. 29% said they skipped care because of cost, and about half of those who did so said their health problems got worse because of that skipped care. In focusing on those with medical debt on the bottom, where's the debt coming from? More than half said it's from hospital care. How much debt are people holding? 1/5 said it was more than $5,000. And some of the consequences of that debt, 39% cut back on basic necessities, food, heat, and rent. We heard about that this morning. 25% took another job or worked more to make ends meet because of that medical debt. And this affordability scenario hits the small businesses the hardest. I'm showing some data on the right. The smaller firms, employees of those firms are more likely to be living below 300% of the federal poverty level. And most of those businesses just don't have the resources to offer more than one health plan. There might be more affordable choices out there. There are on the connector, and the businesses struggle to offer those options. They just don't have the resources to. I would love to make it easier, we all would, for folks to find and access the connector. And the combination of that more difficult affordability situation, and on the left, the growth in premiums for these small firms, the growth in out-of-pocket cost sharing for these firms, and you can see what's happening. Total enrollment among small businesses has dropped for the last 11 years in a row, every single year. This market is going away with faster premiums growing faster than wages. And we asked this year in our cost trends report, where are folks getting their coverage? Part of it is through Mass Health. The growth in these small business employees covered by Mass Health, they grew from 11% to 21% over this time period. Just 9% of large firm employees have coverage through Mass Health. So that is one place that they're going. And others Some are going to be coming uninsured. Okay. So after showing some of these trends, it's clear that growth in commercial spending erodes take-home pay, increases avoidance of care, worsens health outcomes, and requires residents to choose between healthcare and other basic needs. And given that context, that was really what we set out to explore in this cost trends report of there's got to be spending that we can eliminate. There has to be areas where we can grow more slowly, because not only do we have to lower this cost, but we have to spend more in other areas. We want to invest in primary care, as we've heard. We want to invest in behavioral health care. We want to invest in the workforce. We have to spend less somewhere. And so what we did was try to identify where is there spending without value? Where can we spend less without harming access, without harming quality? And I'll just give some highlights of some of what we found. Several in the areas of unnecessary care, overutilization. We had the 4th highest rate in the country of avoidable hospitalization in 2021. We had the 5th highest rate in readmissions in 2021. A lot of this is unnecessary care. The poster child of unnecessary care is low-value care, care that evidence shows has no benefit to patients. And even in just 15 specific low-value services, we spent over $30 million in our commercial market in 2021 on these. 250,000 patients was exposed to some unnecessary low-value care in 2021. And here I'm contrasting high-value care, primary care that we want to spend more on. The growth in primary care spending over the last 5 years was 7% total growth, compared to 3 times that, 23% growth for everything else. So as a result, primary care as a proportion of all spending is shrinking because it's growing much more slowly. What is growing more quickly? Prescription drug spending, 7% growth per year for the last 2 years. Hospital outpatient services, and mostly the hospital portion of that, not the portion that goes to the clinicians. Hospital inpatient, and then at the bottom, much slower growth for office-based care, urgent care, retail clinic care. Okay, so that's where the growth is coming from. And then we always talk about, is it utilization, is it prices? And it's mostly prices, as always. This is showing price growth in those sectors, average annual price growth for the last 3 years, in hospital outpatient in the middle and inpatient on the right. And it's in the 3, 4, 5% range. That's the biggest driver of spending growth, is price growth. And here we see price growth in prescription drugs. Each year, the average branded prescription price over $1,000 in 2021, with 6% of these prescriptions over $5,000 per prescription. So these are some of the high-level findings on prices. Now, what we did in this year's cost trends report, and you can see that in some of your tables, is we wanted to go a step further and identify areas where we are overpaying for services. What is the range of prices, and where can we say we are paying unreasonably, excessively too much in some cases? And so to help illustrate that work, we prepared for you this 4-minute brief, and I hope you enjoy it.
Healthcare spending per person in the United States is more than double what it is in most other high-income countries. Why is this? Researchers usually come to the same conclusion. It's not that we use more healthcare in the United States, it's that we pay more for it. That is, the price of care is higher. What do we mean by the price? The price for a healthcare service, such as an MRI or an office visit, is the total amount healthcare providers receive for providing the service. This includes what is paid to them by the patient's insurer and what is paid by the patient themselves in the form of a copay, coinsurance, or deductible. The price that a provider is paid can be very different depending on what kind of insurance the patient has. For example, for patients covered by Medicare, Medicare sets prices based on what it estimates it should cost an efficient provider to deliver that service. But for patients with private insurance, prices are determined very differently. Each health insurer negotiates the price separately with each provider, and the price often depends on who has more leverage. This negotiation system gives an advantage to providers that the insurer can't live without, such as large hospital systems or physicians with rare specialties, which can lead to high prices. It also puts hospitals serving a high proportion of publicly insured patients at a disadvantage because they lack the negotiating leverage of hospitals that mostly serve privately insured patients. Knowing the cause of high prices, the HPC next wanted to understand how high is too high and how much of our healthcare spending is due to unreasonably high prices. To answer these questions, HPC researchers started with how much Medicare would have paid for a service, because the Medicare price is approximately what it should cost to provide the care. Then the Medicare price was doubled, and excessive spending was defined as only the portion of spending beyond double what Medicare would have paid. This is a very conservative definition. If it costs an efficient care provider about $1,000 to provide the service, then a price of double what Medicare would pay implies the provider is earning a profit margin of 100%, and only the additional $500 was considered excessive. Inpatient hospital stays are an example of care that can have excessive pricing. The HPC found that 1/3 of inpatient hospital stays were paid more than double what Medicare would have paid for the same care. Lab services, such as blood tests, are another example. Not only do lab services often have excessive pricing, but their pricing also varies depending on where the service takes place. The HPC explored lab services provided at doctors' offices, hospitals' outpatient departments, and independent standalone labs, and found that while more than half of lab services in 2021 did not have excessive pricing, 39% did, almost 3/4 of which were provided at hospital outpatient departments. For this study, the HPC examined excessive pricing for 7 categories of care. These categories of care represent nearly half of all healthcare spending that makes up an average health insurance premium, which was more than $22,000 annually for Massachusetts families in 2021. The HPC found that in 2021, 27% of spending on all of these categories of care combined was excessive due to high prices. This amounts to $3 billion of excessive spending in total in Massachusetts in 2021, which translates to $3,000 per family each year for families who have health insurance through their employers. In this way, high healthcare prices are burdensome for Massachusetts families, especially those with lower incomes. Instead of adding to healthcare providers' bottom lines, that money could be added back into families' budgets, where it could go a long way to meet other basic needs like housing, food, transportation, and childcare.
That was wonderful. And thank you to the graphics team for preparing that. You can read more about that in the cost trends report, which is at your tables in the 3rd chapter, I believe. And so now I want to just turn back to one final slide and then hand off to David. So to kind of hit home the imperative and the implication of commercial spending growing at the current trajectory of 5.8% versus just getting that growth back to the benchmark rate of 3.6%. The difference, the implication of that would be $23 billion less spending over the next 6 years if we could manage that change. Premiums would be 14% lower, still a high $35,000 versus more than $40,000 a year if we continue to grow at the current rate by 2030. This would mean more money in the pockets and take-home pay for workers and less money spent in out-of-pocket spending, less avoided care, fewer financial consequences. So with that goal in mind, we're going to talk about some ways that we can achieve that.
So reflecting on these troubling trends in healthcare affordability for Massachusetts residents and employers, this year the HPC shared a new policy recommendation to complement and bolster the state's healthcare cost containment growth benchmark, which focuses on the total growth in healthcare expenditures, with a new focus on affordability and the share of healthcare costs that are borne by employers and residents. While we believe this effort can be strengthened with some legislative changes, which we'll discuss in a minute, examining affordability is clearly within the existing scope and mandate of both the HBC and CHIA, and is clearly in the public interest. And so with that in mind, I'm really pleased to be able to turn it over to Caitlin Sullivan from CHIA to talk about how CHIA is planning to incorporate a stronger focus on affordability in their next annual report.
Thank you, David. And thank you to the Commission for the opportunity today to share CHIA's plans for measuring affordability. We're planning to include a new chapter in our annual report on the performance of the Massachusetts healthcare system, which is forthcoming in March 2024. So David Auerbach just outlined for us the many affordability challenges facing Massachusetts residents. In recognition of the importance of elevating these affordability and health equity challenges facing our state, for CHIA's data and measurement initiatives, our forthcoming annual report will have this new chapter on affordability that will be centered on equity. I'm going to walk through just a couple of slides to illustrate some of the new ways CHIA plans to report on affordability. As you well know, CHIA is responsible for calculating total healthcare expenditures per Massachusetts resident each year and comparing that growth in these expenditures to the cost growth benchmark set by this commission. The total healthcare expenditure measurement reflects payments made by Mass residents in their health plans to providers for services covered by insurance, in addition to the cost of administering private health insurance, which is what we call NCPHI on this slide. While these numbers include what individuals pay in deductibles, copays, or coinsurance, the overall spending figure, this total healthcare expenditure number, and in the trends combine what health plans, public insurance, and members pay to provide that system level overview. However, these aggregate trends do not always reflect the experience of the individual consumer or employer, which we heard about earlier today. To address this, in the upcoming CHIA report, we plan to answer a key outstanding question. Of the total healthcare expenditure levels that we monitor each year and compare to the benchmark, how much of that healthcare spending and the growth is borne directly by residents through copays, coinsurance, and deductibles? In future years, we'll be able to parse out how much of the growth was attributed to member cost sharing compared to health plan expenditures. In addition, this year's report will use various data sources to not only identify trends in affordability, such as how many residents are enrolled in high deductible health plans and how that's changing over time, but also who is impacted. This slide highlights some of the different data sources that we'll be using, combining for the first time some of our aggregate data submitted by payers, premiums data, and then our survey of Massachusetts residents and families, and US Census American Community Survey data to give us a little closer lens into the who is experiencing these issues in the where from a geographic perspective. These final two slides highlight some of the measures we plan to feature in this new affordability chapter. I already discussed examining copays, coinsurance, and deductibles and how much they contribute to total healthcare expenditure growth. CHIA will also continue to monitor premium trends within various market sectors, enrollment in high deductible health plans, and trends in premiums. New in this report, using CHIA's survey of Massachusetts families, we'll be highlighting who in 2023 is experiencing affordability issues from the perspective of income, race and ethnicity, health status, geography, and other socio-demographic variables. For example, we'll be able to report on the race and ethnicity of survey respondents identifying unmet healthcare needs due to cost and other affordability challenges such as problems paying medical bills. We also hope to include additional insight into cost and spending trends for services that individuals have to obtain outside of their insurance, often paying out of pocket, and commonly seen for behavioral health services. Beyond the annual report, CHIA is planning future reporting with deeper dives into these topic areas, particularly in the areas of primary care and prescription drug use and spending. I want to thank you again for the opportunity to present today, and we look forward to collaborating with the Commission, our other state agency partners, and the payer and provider community, ensuring that CHIA is enhancing our data and measurement capabilities to support the informed policy, decision-making, and programmatic work that everyone in this room is a part of. Thank you.
Great. Thank you, Caitlin. And just staying on the theme of the measures we would want and the aspects that are important in an affordability index, I will just run down a few of these additional thoughts as we work together with CHIA with this reporting. Number one, it's important to include not just the employee portion of the premium, but as we've talked about, the employer portion of the premium as well. Again, these dollars are subtracted from what would otherwise be paid out as wages. And it's often a hidden part of the healthcare payment system. We never see these wages in the first place, and we often don't understand the earnings that we don't get. It's important. Also, we have to include the total amount of the deductible, not just what's actually paid, but the deductible level itself, because people often avoid using care because of that fear of spending that money and the inability to spend that money. I have some family members who exactly are faced with high deductibles and just will say, the insurance is not useful to me. I'm just going to pay out of pocket for the things I need outside of insurance and just not use it. And that's a very common scenario, especially for people with chronic health conditions who are often going to spend that deductible and have little ability to avoid it. As I've shown before, the averages are important, but also folks at the extremes are important. We have to consider those paying 90 percentile premiums, the premiums that are almost double as much as the average, sometimes just because they have health problems or they're pooled with other people who do, not because of anything that they're doing voluntarily. And finally, we have to consider these costs in the context of what people's wages are and what they can afford at the same time. Okay. And David's going to go over some of our activities towards developing this affordability broader index. Great.
Thank you, David. We believe that this is an opportunity, an idea worth pursuing with CHIA. So we're going to continue to collaborate with CHIA on designing what are those affordability metrics that we think are worthy of tracking over time. As part of that development process, we think it's important to solicit the input of those impacted by healthcare costs. And we want to be able to understand the differential impacts of affordability on different populations and different groups based on a variety of factors. We're committed to moving forward with including and expanding our focus on affordability in our healthcare cost trends report, as well as today, obviously, a huge theme of this hearing is affordability, and will continue to be a theme in years to come. These activities, though, could be bolstered with some legislative action that would really install this idea of complementing the healthcare cost growth benchmark with an affordability index or an affordability benchmark. This would enable us to design an accountability mechanism to hold health plans and providers in the healthcare system accountable to meeting certain affordability targets and goals. And there's a variety of different processes that may be leveraged, including the HPC's performance improvement plans, the Division of Insurance Rate Review, the Department of Public Health's review, that could incorporate and more firmly establish affordability as important factors in these review processes. So before I turn to a review of the remainder of the HPC's policy recommendations to lead us into our next panel, I want to pause here and be able to open it up for questions and comments from commissioners on both David and Caitlin's presentations.
Thank you, David. And I want to congratulate the panel for the very clear way that you presented how data impacts individuals and families. I think the biggest challenge we have is helping communities and individuals understand why they're hurting so much. They know they're hurting. They know that. Helping policymakers understand the impact of an outrageously complex healthcare system, where in order to solve problems, we add another layer to the system, thus increasing the complexity. It is no wonder that those of us who live in the world are confused by what's going on and by how to pick a health insurance plan. Imagine the individual out there with no experience, not embedded in the work that we do. It is outrageous. It is not sustainable. The work that you're doing right now and the way in which you're presenting that work is helping drive home that point. And I'm, quite frankly, today very proud to be part of the process. Thank you.
Yeah. I was very curious about the affordability metrics that you're going to be publishing. And one of the things that sticks in my mind, because I come at this from the employee benefits perspective, is most employers are offering medical care. Many are offering dental care, not all. People seem to think that the mouth isn't part of their body. It's not part of your overall health. It's optional or cosmetic, but we know that oral care is an important part of general health care. So people, if they avoid the doctor, they avoid the dentist even more. And so I would love to see a question incorporated into your affordability index here or reporting on specifically on dental. I think we're missing the ball on that, and I think it's important. You don't really have a choice if you have to have a root canal or something of that nature. And I know David Auerbach, we did some reporting earlier on about the number of ER visits that were dental related. So it's care postponed or delayed, resulting in a terribly high cost of service.
I just want to quickly thank you for that feedback and just comment that our one of the biggest and best data assets that CHIA and the HPC have is the all-payer claims database. And CHIA is doing some work now to enhance the dental claims. So we have a better view into oral health care from the dental coverage perspective, as well as from the medical coverage side, like ED visits, as you mentioned. So that is definitely something we're looking at. And I think your feedback about incorporating that from an affordability standpoint is well taken. Thank you.
Thank you.
No, go ahead.
We're very curious.
David, I just want to second the idea of going beyond averages. Every year you've presented averages, and every year I respond that the premiums I pay as a very small employer are always double that. And I think looking at both sides of the range is extremely important to really understand why, particularly for very small employers, premiums are so high. So I just encourage that.
Thank you. I did have you in mind when I put up those distributions.
Thank you. Good morning, everyone. Hope everyone's doing well. I just want to say three quick things. One, to the comment made earlier about oral health, and that being a big part of what we need to look at. And just reflecting to the earlier panel when Sheila commented that oral health is out of a lot of people's minds collectively because they can't afford and they're delaying care anyway to even think about oral health. She said it's not even in people's minds. And so I think that's a good benchmark for us to track because it tracks affordability in a really clear way. The second piece, just on slide 15, where we talk about the trajectory of commercial spending and how it will impact and erode take-home pay. I just think it's important to keep emphasizing that it also impacts people working more than one job. That's what's going to continue to happen is when you look at how much it costs and not take-home pay based upon different job classifications, what I wrote down is just means you need 2, 3, 4 jobs, which has an impact on quality of life and every other indicator of social determinants of health. So I think we just got to keep that focus. And then thirdly, I just want to commend the HPC and CHIA for pushing forward on the affordability indices and the conversation that we're having today, but also state right. I don't think that takes the pressure off the legislature and others to do the benchmark itself because it's where you're pushing to your ability within the current framework There needs to be more tools around setting what that standard should look like so we can measure, and the PIP process, everything else that David Seltz, you went through. I just want to reinforce that this is not the end because CHIA took the authority to do this, but it's the beginning of setting a larger benchmark and a framework to enforce the affordability standards going forward.
Right. Thank you so much. And also just to echo the commissioner's remarks on enforceability, the metrics and the ideas for affordability metrics that you both presented today were, I thought, really terrific and really thoughtfully done, and really utilized many of the different data sources available to shed light on inequities across affordability, on geography, race, ethnicity, and others. So my question is, if we find, according to one of these metrics, that say individuals living in a certain neighborhood are experiencing a loss in affordability, or affordability is deteriorating kind of more quickly among the Cambodian population or among the Haitian American population than others, how do we respond to that? And I guess this is more of an invitation to think through the various ways that we can enforce these metrics, not even just within the health system, but in other sectors. So for instance, do we decide to pass cash transfers, unconditional cash transfers, or conditional cash transfers for those individuals for whom affordability is worsening? Just some thoughts.
I think these are the right questions to ask some of our panels today. As we think about an affordability index or benchmark, what would be an accountability structure? I think we are coming to this day hoping to hear from other stakeholders about what some of those ideas may be, and to continue that conversation after today. I will note that Rhode Island has affordability standards that they have in place as part of the insurance review process, and so their Division of Health Insurance has standards that is part of their review process and can deny health insurance premium rates that are being filed based on on affordability. And so that is one example of how another state has embedded affordability into regulatory structures. But I think there are other options we could think about, and look forward to that conversation.
So first of all, very happy to see. I often think about some of the slides we present as the tyranny of the mean. So the fact that we're going to break past that is terrific. I'm also really happy to see the comprehensive view of all payers, Medicare, Medicaid. Obviously, we're very interested in Medicaid because the push and pull in the system is obvious to all of us. The third comment I wanted to make, I think, drafts a little bit off of Dr. McGregor's, which is the interplay of affordability and access, particularly when you think about far-flung parts of the state, rural access, the challenges we're seeing in maternity care. And I want to make sure that in the pursuit of affordability, that I would like to know how the index keeps an eye on access, and particularly for the services that are most apt to close because they are less profitable. And so don't know quite how to thread that needle, and maybe I'm looking for a 4-dimensional graph you guys will show us someday. But I think if we can keep that in mind, because it's, there's disparities within geographic areas by zip code and neighborhood, but there's also broader disparities across the state that the more I learn about them in this role, the remedies to address them are really challenging. And then finally, those affordability, I guess the fourth dimension is inflation. And so cost pressures are real. So, clearly my provider roots are showing in that sentence, but that's one thing I think we should be thinking about. And the last point I wanted to make is maybe challenge you a little bit, David Auerbach, on the notion that if health insurance costs come down, that's going to go into wages. And as we see the growing wage gap in our country, it's in fact the opposite. So I realize those funds could be available for wages, but the notion that if healthcare costs come down, employers will put this back in their employees' pocket is a testable hypothesis. Would love to see it happen, but particularly as we think about social determinants in low-income communities. So
Thank you so much for those comments, Madam Secretary. And I completely agree. And I think your comments around both thinking about the interplay between access and affordability is really important. And to the point of, if we are able to moderate spending growth, how do we ensure that those savings are truly passed on to residents? And I think some of our recommendations, our set of 9 recommendations at the HPC are really kind of a comprehensive set that are aimed to fit together and to work together to try to do that. So absolutely take that challenge on and those points. Maybe I can switch now and turn to just walk through those recommendations as we lead into our next panel, which we'll be discussing both this idea of an affordability index, which we've talked about, but a number of our other recommendations as well. So the next, bear with me, 9 slides summarize the policy recommendations included in our most recent report. These are very abridged versions of the text. Please seek out the full text in the reports on your tables and online. So first is around modernizing the Commonwealth's benchmark framework. We talked already today about the idea of an affordability index or an affordability benchmark. But similarly, the HPC has identified an opportunity to establish a framework in state law through a coordinated effort across state agencies and stakeholders to identify high priority areas of health inequities and to set measurable goals for improvement and to develop an accountability structure and report progress annually on health equity. In addition to strengthening our existing healthcare cost growth benchmark, we think that these 3 concepts can fit together by moderating the growth in healthcare costs, by ensuring that we're tracking affordability, and also setting goals on reducing disparities in health outcomes, that we can have a comprehensive view, a benchmark view that goes beyond just tracking annual healthcare spending growth. Secondly, the HPC recommends policy action to address excessive provider pricing. As demonstrated in the video you just viewed, there is an opportunity to realize savings in our healthcare system by addressing prices that are above a reasonable amount to cover those costs. Such limits could reduce unwarranted price variation and promote equity by ensuring that future price increases can accrue appropriately to lower price providers, including many community hospitals, community health centers, and other providers that care for populations with the greatest health inequities or a high proportion of public payer patients. Additionally, the HPC recommends action to address unwarranted hospital facility fees, and in order to protect patients and reduce administrative complexity, to set a reasonable default payment rate for out-of-network care. Thirdly, the HPC continues to recommend that policymakers take steps to address the rapid rise in retail drug spending in Massachusetts with policy action to enhance oversight and transparency. The specific policy actions we recommend include including the pharmaceutical manufacturers and pharmacy benefit managers, or PBMs, under the HPC's authority, enabling CHIA to collect comprehensive drug pricing data, requiring the licensure of PBMs, expanding the HPC's drug review authority, and establishing monthly caps on out-of-pocket costs for high-value prescription drugs. Fourth, the HPC recommends greater accountability of health plans for delivering value to their consumers and ensuring, as we were just talking about, that any savings that accrue to health plans from other policy solutions are passed on to consumers and employers, and from employers back onto their workers. The Division of Insurance should closely monitor premium growth factors and can utilize affordability targets for evaluating health plan filings, similar to Rhode Island. Policymakers should also promote enrollment of small businesses into the plans vis-a-vis the Massachusetts Health Connector for Business platform, which has competitive plan options. Fifth, the HPC recommends additional reforms to advance health equity for all, including echoing statements from earlier today, an enhanced emphasis on social determinants of health, more payer incentive contracts, building off of the leadership of incentives to encourage and reward providers that take action to reduce health inequities, We need better data collection, and we need to make investments in areas of known health disparities, such as maternal care. Sixth, the HPC recommends efforts to reduce unnecessary administrative complexity in the healthcare system, particularly those processes that are burdensome for providers and can result in patient challenges and delayed care and otherwise provide no value. Standardization and automation of some of these processes, for example, prior authorization, can ease the administrative burden for providers, payers, and patients, and allow for the reallocation of healthcare resources to higher value tasks and improve equity. Seventh, the HPC recommends policy action to enhance the current regulatory framework to ensure the equitable distribution of healthcare resources to address need, especially in the context of a rapidly changing healthcare provider market and landscape. We'll hear later today about closures and consolidations, mergers and acquisitions, joint ventures, expansions. This is a very dynamic time. And there's an opportunity for the Commonwealth to conduct more focused, data-driven assessments of supply and distribution of services based on identified needs and disparities in outcomes, similar to the great work the Secretary is leading on maternal health that the Governor spoke about earlier today. Such targeted assessments could identify specific provider types or service lines that warrant examination, such as obstetrics, outpatient substance use disorder, maternity care, inpatient pediatric care, oncology, and the relevant regions, and incorporate other factors in the public interest, such as the population served. Finally, on this recommendation, the HPC also recommends that the requirement that providers and payers, or provider organizations, file notices of material change before engaging in certain transactions at the HPC, that should be updated to reflect the increasing role of private equity and for-profit investment in healthcare. Eighth, the HPC recommends that the state and healthcare organizations should build on recent state investments to stabilize and strengthen the healthcare workforce. The Commonwealth should offer financial assistance to ease the cost of education and training, minimize entry barriers, explore policy adjustments for improved wages in underserved sectors, and should adopt the Nurse Licensure Compact to simplify hiring from other states. And finally, there's considerable evidence that healthcare delivery systems oriented towards primary care with integrated behavioral health tend to have lower costs, higher quality, and a more equitable distribution of healthcare resources. The HPC's ninth and final recommendation is to strengthen primary and behavioral care, including through investment that will improve access to these services. In sum, we believe that these 9 recommendations reflect a comprehensive approach to reduce healthcare cost growth, promote affordability, and equity. And I am very excited to turn to the next panel to discuss these policy solutions more. Thank you very much for the opportunity.
Thank you. Thanks so much. And I also look forward to the next panels that will give us more feedback on the idea of an affordability index. So now turning to our last panel before we'll break for lunch, I'd like to ask Vice Chair Cohen to introduce the next panel.
Thank you, and I'd like for the panelists to come on up. Great. So Chair DeVoe started our hearing this morning by saying that we needed to understand the diagnosis and treatment of affordability and equity in healthcare in the Commonwealth. This morning, we heard loud and clear the diagnosis. Our healthcare system is unaffordable, and that unaffordability is resulting in poor access. It's resulting in inequities, and it's resulting in poor health outcomes. We need to now focus on the treatment side, how to correct the affordability and equity problem that we have here. We need to help us look at those solutions. We have a set of panelists that are really on the front line of advocacy and policy development for residents of the Commonwealth when it comes to healthcare. We look to them to understand what actions this commission, as well as others in the Commonwealth, can advance to address both affordability and equity. Joining us are Fellaine Duranette, Vice President at Large at 1199 SEIU and a member of the Health Equity Compact. Colin Killick, Executive Director of the Disability Policy Consortium. Juan Fernando Lapera, Chief DEI Officer at Beth Israel Lahey Health and co-founder of the Health Equity Compact. And Amy Rosenthal, the Executive Director of Healthcare for All. And I want to start with really, you've heard from our community panel this morning. You've heard the data as presented by Dr. Auerbach. You've heard our policy recommendations. What would you recommend the Commonwealth do to approach setting measurable goals for improvement and developing an accountability framework that deals with affordability in healthcare and deals with the equity question that was so well presented throughout the morning? And Fellaine, I'll start with you.
Good morning, members of the Health Policy Commission, Secretary Walsh, Executive Director Seltz. My name is Fellaine Duranette, and as our chair mentioned, I'm Vice President at Large at 1199 SEIU, the labor union representing over 80,000 healthcare and home care workers across our Massachusetts Commonwealth. And I'm also on the leadership team of the Health Equity Compact. And we have worked really hard to really make equity a verb. And it's a verb that has wheels, and that those wheels need to be on the go. When we think about health equity, it's not only the actions of the healthcare institutions or the systems, it's also about the people that receive the care and those providing the care. What COVID exposed and what we're living in today is unprecedented staffing shortages, which lead to unnecessary bottlenecks within the system, which then leads to further interruptions of care, which then leads to the limited access to affordable care. Multi issues. And our healthcare workers at 1199, by way of a poll, lifted up sentiments that I'd like to share today. And those three issues ranged in 74% of our healthcare workers believe that healthcare is on the wrong track. These are on the ground frontline workers on the wrong track. 61% have looked for jobs elsewhere. And 92% reported that the staffing shortage at their own facilities are at critical range, 92%. And so if there was ever a time to adopt in large part the recommendations that was just shared by the panel before, and the recommendations that the Health Equity Compact has comprehensively lifted up through the bill, that time was yesterday. Absolutely yesterday. And so I look forward to the continued conversation around centering equity and affordability and digging into the structural racism that pushes against progress. Thank you.
Thanks. Colin.
Thank you so much, chairs, members of the commission, to my fellow panelists, many of whom I've done a lot of work with before. Yeah, I I have in the past, and speaking to this commission and in other contexts, talked about the disability community as being in something of a double bind on this issue, because we desperately need more affordable healthcare, right? We are the lowest income, least employed, highest poverty, most homeless minority group in the country. But also many of the solutions that have historically been advanced to address affordability have been targeted at reducing care towards our community, because caring for many of us is expensive, right? Whether it's personal care attendant services, whether it's new drugs for severe health conditions, et cetera. In fact, I first got involved with the Health Policy Commission after being in the audience for a prior version of this hearing and hearing some proposals advanced that alarmed me. But I am hopeful. Despite everything going on, I am cautiously optimistic. I think particularly because of the increased focus on equity and intersectionality, and recognizing that in fact, you do not have to choose between equity and affordability. You in fact need to do both together, and that you do not need to choose between affordable care and appropriate, adequate, accessible care for people with disabilities. You get to have both, and in fact, you need to have both. So a few areas, I'm proud of the fact that we've made substantial progress on equitable value assessment. Our organization, through extensive negotiation with folks like Institute for Clinical and Economic Review, have come to consensus on language. That language is reflected in the PACT Act, as well as our own act to address discrimination against persons with disabilities in the provision of healthcare. It's also reflected in the new proposed Section 504 regulations at the federal level. Recognizes that there are alternatives to metrics like QALYs that discriminate against people with disabilities that have been developed, that have come out of academia, that can be used to lower prices without endangering vulnerable patients. And I think that the recommendations put forth here are exciting. I think I would just make the point that, for instance, when we talk about workforce diversity in the recommendations, that's excellent. That includes providers with disabilities. And I would urge you to do work to make medical education more accessible, to make doctors' offices not only more accessible for disabled patients, because especially in specialties like OBGYN, oral health, psychiatry, opiate treatment, the facilities are often inaccessible for disabled patients. They are also inaccessible for disabled doctors. And that is a major driver of the massive discrimination against people with disabilities that still exists in the healthcare system, as reported by the work of local researchers like Lisa Iazzoni, for instance. So I think that needs to be part of it. In general, the focus on health equity is excellent and long overdue, and I'm proud to say that early in the process, the folks from the Health Equity Compact reached out to us and said, how can disability be part of this? We have worked with them on language that's going to be inserted into the bill that will make sure that disability is part of health equity, as it should be in this Commonwealth, and I would urge you to throw your full support behind that legislation. And then I would say, add to the placing standards on providers that was discussed today. I think standards, requirements, benchmarks around affordability is excellent. I would just urge you to also consider network adequacy in those, particularly for people with rare diseases, chronic conditions. It is too easy to get to affordability by slicing off the people who it costs the most to care for. And I think that on the contrary, if you ensure that people have access to specialists that understand their conditions, that would be tremendously impactful. And then I don't want to take up too much time, but very briefly, as head of a small business that has never been able to offer a health plan because of the disabilities of our employees, we reimburse people for their own expenditures through the connector, which is a clunky workaround. I would love it to be more possible for organizations like mine to do that in a systematic way. I would just urge you, some people are on Mass Health not because there is nothing adequate available through their employer, but because care for their conditions is only provided by Mass Health. No private insurer in the state provides those services. That is a problem in the longer term. In the shorter term, ensuring that those programs do not inadvertently force employers like us to either not offer a plan or force our own employees who need Mass Health off of it. And lastly, I would say we have the best Medicaid buy-in program in the country, Common Health. It is bafflingly underutilized. And it means that there are people with disabilities in the state who want to work, more than they are, who want to earn more income, who want to pay more taxes, who can't because they cannot get onto that program. I would urge the state to do everything possible to simplify it, to address the serious problem of incorrect denials that have to be reversed on appeals. That would go a long way towards ensuring healthcare access in our community.
Great, Colin, thank you. Juan.
Good morning still, I guess, standing between lunchtime for all of us. But thank you for having us. Great to be amongst friends here. We've been at this for a while. Again, my name is Juan Fernando Lopera. I'm the Chief Diversity, Equity, and Inclusion Officer at Beth Israeli Health. I'm also a proud member, co-founder of the Health Equity Compact. I want to just take a few minutes to reflect on today and what we've heard so far. And I also want to commend the Health Policy Commission for what I think is a turning point in the narrative and in the inclusion of the conversation. It is remarkable to see representation at the Health Policy Commission that, quite frankly, didn't exist a year ago. I counted 6 Compact members among the presenters today, and thank you for including our Compact additional title, because we do that as a volunteer and as a labor of love, that work, because we all have that lived experience and we come from the community, and we don't forget the communities that we come from. But we heard from Jose and Sheila earlier, along with other remarkable community voices. And obviously you're hearing from Philaine and I as Compact members. Later on, you'll hear from Michael Curry, Kane Hayes, and then we have our very own Commissioner Castile. So it is remarkable. I think it is a turning point in the conversation, and the fact that you are putting equal weight to the equity conversation as you are to the affordability conversation just marks the incredible progress in the continued recognition that those two are inextricably linked. And because they are inextricably linked, just reflecting on recommendations, you saw that the Compact in co-authorship with the Blue Cross Foundation put out a report, first of its kind, that actually put a dollar figure to cost inequalities in the Commonwealth, and that number is $5.9 billion. And because those same communities are the fastest growing, that number will be $11.2 billion by 2050 if we don't do anything. So as you'll hear many times, and you heard it from Michael, pay now or pay more later, as the data shows. I'm proud of the work that we're doing at Beth Israeli Health and the role that I have. And the reason I chose to join Beth Israeli Health is because, quite frankly, I felt that we could, with a system of that size, make an impact, and knowing how high a priority, a strategic priority, equity is, and also a system that we know brings value to the Commonwealth in terms of care delivery. I'm proud of the work that we're doing in centering equity in everything we do, every decision we make. We also acknowledge that we have a long ways to go, and we are committed to both affordability and equity. And I'll end with reflecting on the immigrant voices. As an immigrant myself, originally from Colombia, Damaris actually beat me because she mentioned 22 years as an undocumented immigrant, 17 years for me, really hiding behind the shadows and having a system that didn't work for me and my family as a 12-year-old, being the interpreter for the family as a 13-year-old, which is not good quality healthcare when you have to interpret as you're just learning English. And then seeing the many barriers, having to live through all those barriers, and it is why for so many of us it was not a surprise when COVID disproportionately impacted certain zip codes, because we live in those circumstances. So we shouldn't. I think this is what we're doing today, centering equity and affordability, is a way of us saying we don't have short-term memory. 3 years ago, we saw what COVID did, and we are ready to act on that. And so I commend the commission And thank you for including so many voices in this conversation.
Thank you, Juan. Amy.
Good morning. Thank you for inviting me once again to participate in this important discussion and for providing two of Healthcare for All's partner organizations with the opportunity to share their insights earlier this morning. Both Pastor Kiki and Damaris are true community leaders with tremendous wisdom as to what this board and all of us can be doing to make healthcare more affordable for the people of the Commonwealth. I also want to pause and acknowledge that over the past few years, I have been quite explicit about my concerns regarding the lack of diversity on this commission, in particular, the lack of gender and racial diversity. And while there remains important progress to be made, the view from my seat today is certainly different than it has been in past years. I believe it is important for me to call out a lack of diversity when I see it, and I also believe it is important for me to acknowledge progress when I see it. So thank you, and I encourage everyone to keep up the good work. There are 2 points I want to make and focus on today. The first is the connection between making healthcare more affordable and more equitable. In many ways, these goals are inextricably linked. Making care more affordable is one important way to make care more equitable, since cost barriers do not fall equally. Black and Hispanic or Latinx residents are more likely to report challenges affording their care than their white counterparts. In addition, equity also requires that we specifically address additional barriers and poor outcomes experienced by people of color and individuals with disabilities, such as focusing on social determinants of health and addressing inequities in maternal health outcomes. Health Policy Commission's recommendation to institute both an affordability and equity benchmark is absolutely the direction the state should be moving in. For far too long, these factors have been raised here at the cost trends hearing, either because specific commissioners have raised them or people like me have in their testimony. Setting benchmarks that we can hold industry accountable to elevates these as priorities. The second key point is that we have to address the underlying drivers of healthcare costs in order to give people relief. Healthcare for All is proud to see the state take actions to improve immediate relief to individuals and families through expanded access to subsidized coverage, which the governor talked about earlier this morning. And we're really pleased that there is serious consideration in the legislature for eliminating or capping copays for certain medications used to treat chronic conditions that disproportionately impact people of color and low-income residents. However, to bring down costs in the long run, we must also tackle the underlying drivers of cost in the system, with all industry stakeholders having shared accountability. There is one sector that currently sits outside the current cost growth benchmark process, the prescription drug industry. That is a problem not only from a fairness perspective, but because no other commercial spending category has grown faster in recent years or represents more potential savings, according to the Health Policy Commission report. As is often the case, I want to make the connection between the larger cost trends we are talking about today and the experience of individuals that people are facing from a story from our helpline. Jacinta is a school nurse from Pembroke who buys private insurance on her own. For her family of 4, their premium costs $1,400 per month with a $5,700 family deductible. These costs make Jacinta think twice about going to the doctor and cause her family a lot of stress. She told our helpline counselors that her husband has a hernia he needs treated, but since they haven't met their deductible, he's decided to delay care because they are worried about the cost of treatment. So how do we help people like Jacinta? The Health Policy Commission has put forward a number of specific recommendations that are important, and I want to, again, just highlight these 3. Establishing new affordability and equity benchmarks, bringing the pharmaceutical industry, including manufacturers and PBMs, into the Health Policy Commission process, and increased investment in primary care, behavioral health, and thinking about maternal health, while still adhering to the cost growth benchmark. To quote from the Health Policy Commission's report, residents subsidize high prices through premium payments and increasing cost share. That's it in a nutshell. We've been saying this for 10 years. I think one of the commissioners earlier talked about our community members kind of containing their anger here. And I share that as someone who's been before this commission now 6 times and talked about these issues. Now really is the time to act. So I thank you for your attention to this and your thoughtful advice.
Thanks. I'd like to now open it up to any commissioners who would like to ask questions of our panelists. David?
So thank you to everyone. I want to pose a question, but do it with just a little bit of background. So if you look at our cost trends reports and you say, what are the areas in which we could save money? I think there are 3 of them, and the question is about two of them for you. So one is we should spend less for things that we're overpaying, and the classic example which has been raised is prescription drugs. And so that I want to leave that aside because I'm not sure there's any disagreement about that at all. The second one is our administrative costs in healthcare are well above what they ought to be. And amongst the reasons for that is because we use people when machines and IT could be used instead. So we use people on prior authorization and people on billing and people on wherever. And the question I'm getting to is, are you comfortable if we eliminate those people? So I just want to pose that. And then the third one is we provide care in settings where we don't need to provide care. We have too many people in emergency departments. We have too many people coming back, readmitted to hospitals. There, we probably need some switch of people, like we need more community health workers, but we need fewer imaging techs because we're doing too much imaging, and we need fewer hospital workers because we have too many people in hospitals and so on. So here's the question, and it's maybe particularly for Elaine and for Juan, which is at least 2 of those involve fewer people in healthcare, fewer clinical people, fewer administrative people, so on. Are you comfortable with that? Like, are you comfortable with the idea that we'll save money and we'll have less employment in healthcare?
Excellent question. Thank you. So absolutely comfortable with figuring out how do we reduce administrative burden so we can redeploy our staff in other much needed areas of our healthcare system. We have across hospital systems 20,000 vacancies. Within Beth Israeli Health, we've had steadily for the past several years 5,000 vacancies. So if we're able to reduce that administrative burden, take for example, and Mass Hospital Association just yesterday, I believe, released a report that actually put a price figure to the number of people, the amount of resources that are utilized on claim denials, just as an example. And the dollar figure is $1.75 billion. It's actually half of the total cost of resources that are used to essentially work through claim denials, about 80% plus of which are overturned. So imagine what we could do, or we could redeploy those individuals to become health navigators who are multilingual, who can help us address social determinants of health and health disparities. And certainly, the more we can automate, we're certainly way behind when it comes to healthcare in terms of leveraging technology. We can then, the more we can automate, the more we can redeploy resources to meet the needs, the many vacancies that we have across our system. So absolutely, I think we need to, in a state when we're at 2.6% unemployment, 240,000 vacancies across all industries, we got to figure out how to become better at automating, better at reducing administrative burden, so we can redeploy the limited resources that we have.
As a representative of 80,000 healthcare and home care workers, we know that there's an industry that's changing. But there's a workforce that, should there be investments, should there be intentional structures made up, they can meet those demands. There's a workforce that's ready for that. And so there are pieces of the recommendations, legislation that 1199 has worked on that really seeks to use those investments into career pipelines, apprenticeships. This is National Apprenticeship Week, by the way, that really look to eliminating those barriers that seem to kind of push what I see as occupational segregation. There is way too many low-wage workers, people of color, overrepresented in low-wage work. There's opportunity. Should investments be made? Should there be intentionality around filling hard to fill but really, really important, critical, I would say, needs? And so, I mean, I can go through whether it's, the career pipelines, whether it's modifying licenses and actually allowing some of our foreign trained health professionals to utilize their skills that they came with. My parents are immigrants from Haiti, and, many of my family members, they have left their nursing skills. They've left their, lawyers, like they've left those skills behind to create a new life. And so, funding higher compensation to address professions that are not traditionally invested in the same way. Nursing assistants, an extreme lack of nursing assistants. And then, and for those workers, if those investments are made for those workers, having a voice at the table for them to speak to what they see as critical, where their voices can be made most effectively. There are workers of color that see things every day, and their voices aren't respected enough to be brought to the table every day. And so there's multiple answers to that question, but there's a workforce ready to do it. And in fact, there's a lack of workers that it takes to do it.
I'd love to just jump in. Oh, sorry, Colin. Okay, thanks. Two things I want to say, and maybe there may be a universal agreement amongst this commission, but if there was agreement around how we handle prescription drugs, that work would be done at this point. And so I do want to say that for the many people who are able to impact this, I think there's a lot of positive activity happening in the legislature with Chairs Friedman and Chair Lawn, but I think if this was an easy to do thing, it would be done. And so it still needs all our attention and still needs all of our focus so that we can address prescription drug costs. The other thing I do want to just touch on is prior authorization. It is something we hear about multiple times a day on our helpline. I think automation is one piece of it, but if we're thinking about prior authorization and thinking about the goals of affordability and equity, we also need to be thinking about things like requiring prior authorization to be valid for the duration of a treatment, grace periods for people who are switching plans so that they don't have breaks, making sure that plans can't retroactively deny a prior authorization. There's a lot of other things that we also need to be thinking about if we're keeping those big goals of affordability and equity in mind. So just.
Yeah, echoing all of that. Briefly on the point about workforce, yes, I think there are that's the reallocation of people. For instance, if you had a more robust, better paid PCA workforce, it would be an excellent way of keeping a lot of people out of nursing homes, which would be good for all sorts of reasons. On the prior auth point, it's I think the view of just about everyone in our community that prior auth is massively overused and has hugely negative consequences for a lot of people with disabilities, ruinous, life-threatening ones in certain cases. And the My Ombudsman program that we operate, which is a free benefit for Mass Health enrollees, we work with a lot of people who are Mass Health managed care members who've been initially denied services. So the current status quo of prior auth isn't great, and it's entirely possible that an algorithmic one would be better or at least no worse while costing less money. But the devil really is in the details there. It is very easy to accidentally construct a biased algorithm, or to include factors that don't take into account anyone who isn't the sort of standard human being, right? I think back to the crisis standards of care that we had to work to overturn when, for instance, the short-term COVID survival measure included the Glasgow Coma Scale, which would tell you that I had suffered a brain injury because I have a neurological disorder, and it didn't know how to differentiate between a chronic condition and an acute COVID injury. And I think also there's the danger of, if those algorithms become proprietary, then that makes appeals considerably more difficult to say, oh, well, lawyer for this patient, appealing a prior auth decision, we can't tell you how that decision was arrived at because the algorithm is a trade secret. I would strongly urge not to go down that specific road.
Thanks. Other questions for our panel? Tim?
Thank you. Yeah. I think the question that was asked by the commissioner was really an important one. I think we've talked a little bit about it in the last HBC meeting about transitioning. If there's areas of savings that currently people are doing, I would challenge the provider community to work together to figure out what are the jobs that they're going to going into, what are the jobs you're going to lose, and what are the career pathways to get folks prepared for that. Because the folks that are currently doing that job too are also in these numbers of folks who can't afford the housing costs in Massachusetts. They can't afford their health insurance. So let's figure out a pathway to get them to good paying jobs where they're part of folks who can afford to live in our state. So I think that's a really important thing for the stakeholders to come together to figure out and work on together, because it's a challenge for all of us. And this, going back a little bit, the last presentation before this panel came on was about the potential of CHIA starting now, an affordability benchmark, and the commission pushing forward our recommendations for an equity benchmark and an affordability benchmark. Just wanted to get some thoughts, and Colin, you talked a little bit about it in your opening remarks, but happy to hear from you and others of what are those things that we should be looking at around setting an equity benchmark or an affordability benchmark that wasn't referenced before, or insight that you would have of how, if we're moving down that path, which it looks like we are, at least within the authority we currently have, what are some of the things we should be thinking about?
Yeah, thank you. I think it was said earlier, maybe in a different way, that there's no that we need to get below averages. I like to say that there's no equity in averages. So I'm glad that we are stratifying the data, that we are looking at how those two things, equity and affordability, are linked. I would urge us to continue the work that was started by the Compact with the Blue Cross Foundation report that actually put a dollar figure to health disparities across the Commonwealth. And we ought to monitor that societal burden, economic burden on an annual basis. Again, to get below the averages, to look at the inequities that exist, and begin to use that as a basis. As we do develop an equity index, when we think of an equity index, we may be thinking more of quality metrics, stratified, and that's important, and we should do that, and we should be able to take existing HEDIS measures, whatever measures are already well vetted, so we don't need to reinvent the wheel, and then begin to stratify more, and have both sort of a quality equity index as we continue to monitor the cost of inequalities. So it's not just a one-time report that we did and then it sort of begins to collect dust, but we maintain it every year. So that's just a thought I would have as the commission considers how to develop an index.
I think any measurable goal that focuses on areas that disproportionately lead to catastrophic death are all the areas that this equity index should be looking at. Should be measuring, should be remeasuring, and ultimately leading to solutions, programs, measures that honestly just stop the catastrophic death. I mean, that's what it is. I mean, the point being that when you think about the social determinants of health, education, workers, and their ability to live, it crosses so many metrics. Crosses so many different areas that I don't think it's one measure. I think it's many measures, and all centered with the disproportionate community at the center.
So one, I'm just very happy. I think Healthcare for All started working on legislation back in 2020 around this concept. We were calling it a consumer benchmark or an affordability benchmark. I think the idea of having a particular benchmark, even with lots of things that can feed into it, but ultimately coming up with something that, like the cost growth benchmark, that people can look at and point to and understand and comprehend, I think is an important piece of all of this. I think there also needs to be accountability measures with it. I think how you do that is hard. We have been talking to national experts trying to understand. We know there's lots of smart people at CHIA and HPC who are doing lots of thinking about this. I would say that when we think back about Chapter 58, I think part of the reason why things worked was because of this shared model of accountability. And I think I would argue that you would need it here as well. So I think it really needs to start with the insurers because they have the most direct interface with the consumer regarding premiums and out-of-pocket costs. So building the affordability benchmark into the rate review process is certainly a place to start. At the same time, we can't just stick this on insurers. It needs to be across the board. And so we need to think if a resident gets care at a particular hospital or health system where costs are higher, we need to then involve them in this accountability benchmark, as well as think about pharmaceuticals and even some employers is just understanding how all the pieces fit together and then bring all of the entities to the table in order to make sure that we're making progress towards that benchmark.
Absolutely. So I think the topic of quality measures is really important, but also can be really tricky to get right. My colleague Dennis Heafy, who I think some people in this room know and have worked with, I say that people with disabilities are a community, not a failed health outcome. And I think that often traditional approaches to quality are about preventing people from getting chronically sick. And once people get that way, people get to the way where they're not going to be cured, they are abandoned. And quality for their care is not necessarily considered. And so he's done a lot of work on that question of how do you assess quality for our community? And a lot of it has evolved around helping people meet their goals, helping people live the life that they want to live. And that's particularly critical because social determinants of health have come up multiple times. It was great to see it emphasized in the report. There needs to be investment in that. For people in our community, but not just in our community, there's also the reverse. There's health-determined socialization, right? Where access to high-quality healthcare is a necessary prerequisite for working, for living independently, for spending time with your family and, participating in your community. And I think the future of health, like value assessment, really is that. It's holding plans, providers, drug companies, what have you, accountable for how well are you helping people live their lives, achieve their goals, be as much as possible, be part of the world in the way that they would wish to be. Because ultimately all healthcare really is, beyond keeping people alive, is in the service of that.
Great. I think we have time for maybe one more question. If not, I'll turn it back over to David.
Well, I'll ask one. We have some policymakers in the room, and we know that the legislature is considering changes to the healthcare reform framework. I would love to hear, and it does not need to be specific to our recommendations, but what is the one recommendation that you would like to see legislative action on this session? Amy, we'll start with you.
One?
You can have sub-bullets.
I mean, I've talked about prescription drugs now multiple times here. I think that there are a lot of positive conversations that are happening right now. I think bringing PBMs and manufacturers into this process is something that is achievable and something that we should be thinking about now. But I have a whole bunch of other ones, but if you're making me just do one, I guess I'll say that.
Well, I mean, it's hard to pick one because obviously, very intentionally, the Health Equity Compact filed a comprehensive bill. Within that, I would probably second the provision within that bill that relates to out-of-pocket costs for families. Or is that maybe okay?
I
All right, there you go. So all right, there you go. Read your mind. I thought that's yeah. But so I would underscore that one. That I mean, we share the data. It is it is preventing people from getting care, and we know that it is important to have a way to monitor growth, and payers play a critical role in doing that. But specifically for certain conditions that disproportionately impact low-income communities, Black and Brown communities, we should seriously think about how do we remove those barriers from an out-of-pocket cost standpoint. So that would be the one that I would highlight.
I'm biased because it's our bill, but I think it is a deeply necessary one. An act relative to preventing discrimination against persons with disabilities and the provision of healthcare. But the reason it's sorely needed is, we don't have specific data from Massachusetts, but from national and international data, probably about 2/3 of people killed by COVID had disabilities. And they died not just because the virus was more likely to hit people with disabilities, but because the healthcare system cared less about keeping us alive. Massachusetts cared less about keeping us alive when it initially put in place crisis standards that sent us to the back of the line for ventilators and hospital beds. But this problem existed before the pandemic, and it continues to exist. I mentioned Dr. Iazzoni. She did a national study in 2021 that said 85% of the surveyed physicians said they believed patients with disabilities had an inherently lower quality of life than those without. And we are hearing constantly from patients who are, for instance, pressured by providers in deciding do not resuscitate orders. Said, you will not get more than basic nutrition and palliative care until you sign a DNR, because we think your quality of life is too low to warrant being kept alive. And we hear from people who have surgeries postponed because they have other disabilities, people who are at lower priority for organ transplants because they have other conditions. And this bill would simply put in place the presumption in state anti-discrimination law that you cannot deny or deprioritize someone for a healthcare service based on your presumption that their disability makes their life less worth living. So that's ours. This is personal, obviously, but I hope that this session that bill finally gets through.
Thank you, Amy. Ditto. Thank you, Juan. Yes. Thank you, Colin. I would say the future of care in this Commonwealth and the true next phase of reform cannot be made without the healthcare workforce. And we can't value the workforce that does it every day through minimum wage pay, through conditions that lead to things like mandatory overtime. And so I would say, in addition to the work that centers the workforce, the bills that center the workforce, and the bills that lead to equitable health, that leads to optimal health, we lift up the fact that equity, again, is a verb. It's all of it. It's all of it. If we only do one piece, we're already behind. That's what I share.
Let me thank our panelists. Great information. Thank you. And I'll turn it over to Chair DeVoe to wrap up this session.
Thank you. I'll add my thanks to our panelists. We hoped for this session to help us identify the issues which you've done. And honestly, it would be enough in many ways if you stopped there and stopped with giving us input on our recommendations. But you've gone much further to make recommendations about your own view on action. And I can tell you, as much as I respect people who accurately identify problems, I've now learned I even respect people more when they propose a solution. So on behalf of all of us, thank you so much for what you've given us today.
Thank you.
So we will now break for lunch. We do have lunch available for the attendees. Also, we realize some people may want to leave Suffolk and grab lunch elsewhere. We would ask that we reconvene at 1 o'clock, and we'll resume. Thanks so much.
We're going up.
Right.
Okay.
Having this after the day after election is especially very
Okay, tell me when you want me to stop, like I can
Yeah, let's
ramble.
let
or-
David sit down and then
That's
I'll
yours.
introduce.
And there's fresh
So
ones,
we
too.
have the presentation by the AG first, and then we'll go to you.
Was very happy about the Ohio abortion
Yes.
This is recording the handshake. Same. Great. Well, welcome back, everyone, and those who are joining us this afternoon. We're looking forward to the presentation from the Attorney General's Healthcare Division that we heard about this morning. And I will turn it over to Sandra to introduce our speaker.
Thank you so much, Chair DeVoe. Hi, everyone. I'm Sandy Wolitsky. I'm the Chief of the Healthcare Division at the Mass AG's office. As AG Campbell mentioned this morning, our office has some unique tools when it comes to transparency around healthcare cost trends and cost drivers. This year, our work in that area focuses on ambulance billing and related consumer issues. We picked this topic due to the very high volume of consumer complaints that have come to our office on this topic. Folks who take an ambulance ride and then face unaffordable and unexpected bills as a consequence. We're really excited to be able to use our cost trends authority to dig into this significant consumer issue. I'm really pleased to introduce Lisa Gollin, an Assistant Attorney General on our team, who has led this examination and is here to present our findings and recommendations. Thank you, Lisa.
Thank you, Sandy, and good afternoon. So pleased to be here.
So I'm going to start off this presentation with some context on the Office of the Attorney General's role on cost trends. So first, under Chapter 12, Section 11N, the AGO has been tasked with monitoring trends in the healthcare marketplace, including payer contracting and patient access.
Lisa, would you bring the microphone a little closer, please?
Yep.
Thank you.
Can you hear me now?
Yes. Perfect.
Great. And under Chapter 12C, Section 17, we have authority to issue subpoenas for documents, interrogatory responses, and testimony related to healthcare costs and cost trends. So Sandy just mentioned some powerful tools at our disposal. As you know, the AGO has used this authority to examine healthcare market trends and cost drivers and issue reports on our findings since 2010. Prior reports from our office have documented, for instance, price variation unrelated to quality and the impact of consumer-facing price transparency tools. And as Sandy just noted, and we discussed this morning, this year we are reporting on ground ambulance services in Massachusetts with a focus on emergency response. So as many in this room know, ground ambulance billing is a persistent consumer issue and one that is having a moment in the healthcare policy spotlight right now at both the federal and state level. Just last week, a committee convened under the No Surprises Act to study ground ambulance billing issues, including consumer protection measures, voted on a series of recommendations. Because of the timing, we have not had a chance to fully digest these recommendations, but we do know that many of the same issues and concerns discussed in our report were raised during the course of that committee's meetings. And at the state level, for example, an advisory group in Washington led by that state's Office of Insurance Commissioner just last month released recommendations to their legislature concerning balanced billing of ground ambulance patients. And of course, in Massachusetts, the Health Policy Commission has done some outstanding work on ground ambulance billing. We were at the beginning stages of this examination last March when HBC released its findings on ground ambulance reimbursement. And some of the questions that arose from that work and the discussion around it informed our report's content. And so we really were looking to use that report to build on that great foundation for our report. As a consumer protection agency, we conduct this examination through lenses of affordability and access. As the AG noted this morning and as Sandy just mentioned, consumers regularly contact our office's healthcare mediation unit seeking help with ambulance bills and out-of-pocket expenses that they cannot afford. We have received nearly 250 complaints related to ambulance billing since 2018, 30 in the time since we began this examination in the spring. Complaints encompass various contexts, including Medicare and Mass Health coverage issues, but most typically they involve consumers with commercial health insurance, particularly those that have been transported by an out-of-network ambulance provider. Sometimes the complaints involve large balance bills, sometimes expensive cost sharing, and sometimes both. And so our concern is twofold. Consumers are experiencing real financial struggle. They come to us when they've been sent to collections or on the verge of being sent. And we also have concerns that consumers with unaffordable bills will not seek out healthcare in the future. Consumers have said things like, I will think twice about calling 911 next time, or if I had known about this bill, I would have risked driving myself to the hospital. So we know healthcare consumers are hurting. But at the same time, we acknowledge that addressing the affordability piece is complex because of how ambulance services are provided. As reflected in our report, to a large extent, it is local municipalities that are providing 911 ambulance response. And many of those municipalities report that they're struggling to meet costs of providing services that we all expect to be available when we need them. So going into this examination, it was our office's goal was to provide a database contribution to the ongoing policy conversation in Massachusetts and at the federal level, and offer increased transparency around some of these competing issues. To achieve these objectives, we did a lot of work. We first sent out surveys to all 351 Massachusetts municipalities. So these are the local jurisdictions that are responsible for designating a primary ambulance service under Massachusetts law. We received 259 responses back. These responses reflect significant geographic diversity and size diversity. So we received surveys from small towns, large cities, and in between. We had a range of perspectives. Through the surveys, we were looking to understand at a local level who was providing ambulance services. Was it the municipality itself, or was it some outside provider? And to the extent ambulance service is provided by the municipality, the survey requested information related to billing and collection practices, utilization, and health plan contracting, among other things. The survey is appended to our report for those interested in the full set of questions. We also issued civil investigative demands, or subpoenas. Subpoenas were sent to 11 Massachusetts commercial health plans, as well as 4 private ambulance providers, so 15 subpoenas in total. So now I will share some findings regarding the Massachusetts ambulance landscape. I start with an answer to the question, what entities are providing ambulance services in Massachusetts? Through the subpoenas, survey responses, and other research, we were able to ID the primary ambulance service in 280 Massachusetts municipalities. We found that 55% of these municipalities provide their own ambulance service, either through a fire department or unit of local government. Approximately a third of municipalities outsource their ambulance service, typically to a private ambulance company, for instance, a service operating under a hospital system, a nonprofit company, or a for-profit company. And the remainder of municipalities operate under a hybrid model. The primary response in these municipalities may depend on the level of service. So maybe a fire department provider provides a lower level response, but a private ambulance provider handles responses that require a higher level of care. So as between private and municipal ambulance providers, our report notes various differences in how they operate. One important difference is the extent to which they contract with commercial health plans. Our survey asked municipal providers, do you participate in any commercial health plans in Massachusetts? 79% of our respondents said no. To the extent municipalities do participate, most frequently it is with just one health plan. And this aligns with what the health plans told us. Most plans responding to our subpoena did not identify more than 2 municipal providers in their network. We don't have a complete set of information, but we generally observed there is more health plan participation by private providers. For instance, with respect to the 4 private providers who responded to our subpoenas, the majority of their transports involving commercial members were in network. Overall, in the data set we examined, which was inclusive of both private and municipal providers, we found that in 2022, 67% of emergency transports involving commercial health plan members were with out-of-network ambulance providers. And so a natural follow-up question is, of course, why are ambulance providers out of network to this extent? Our survey included a list of reasons why we thought a municipality provider may not participate in health plan networks, and those are listed in the left-hand side of this graph. They include reasons like reimbursement rates, not having resources to negotiate, or not being able to contact a health plan. And we asked survey respondents to rank those reasons, 1 being the most significant reason they don't participate, 2 being the second most significant, etc. And I know some municipalities gave a 1 response to several of these reasons. We also included space to provide a narrative response. And the results are shown in the graph. The overall most significant reason is at the top, the less significant reasons displayed as you move towards the bottom. While some municipalities did rank things like lack of resources or expertise to negotiate as the most significant reason, this was a small number. The 2 most significant reasons respondents cited pertain to rates. Approximately 80% said in-network rates would be insufficient. Some respondents explicitly stated that there just was no benefit to contracting with commercial health plans. Approximately 70% of respondents cited the need to maximize commercial reimbursement because of low government rates. We were told repeatedly by providers that Medicare covers less than half of what the actual cost is for the delivery of EMS. Medicaid reimburses far less than Medicare, and patients with no insurance are typically unable to reimburse anything. Moreover, because of low government rates, many municipal providers told us that, quote, commercial health insurance plans need to reimburse EMS at a rate that keeps the system operating and sustainable. I do know that we did not make findings on issues related to ambulance operating costs. So we did not look at what are those costs or how do they differ between communities of different sizes or geographic locations. But our report does convey what we were told by numerous municipal providers. Supply costs have increased. An inadequate labor supply means that they're paying overtime. And in the COVID era, many ambulance providers are experiencing increased numbers of calls to which they need to respond. So in sum, it just costs more these days for providers to be able to respond to the need. I also note that we did not make findings on the adequacy of health plan reimbursement, but we do observe a widely held belief that the government payer reimbursement is too low in our report. And this is something that CMS is looking into right now. Potentially inadequate government reimbursement is significant because of who is utilizing ambulance services. We found that the vast majority of ambulance utilizers in Massachusetts are Mass Health or Medicare members. In narrative and database responses, we were repeatedly told that 75 to 85% of EMS patients are insured by Medicare, Medicaid, or to a lesser extent have no insurance. This graph presents utilization data provided by 8 municipalities with respect to transports in 2022. Municipalities of different sizes and geographic locations are represented. The blue bar represents the percent of 2022 transports relating to Medicare patients. The orange bar is Mass Health utilization, and the blue and orange together show public payer utilization in the 70 to 80% range for each of these municipalities. So as shown, the specific breakdown can vary by town or region. We had some respondents from Cape Cod tell us that over 80% of their transports are Medicare. And we had some of our gateway cities, for instance, say that their transports are over 25% Mass Health patients. So again, payer mix has important implications for funding and covering ambulance costs. In this graph, we can see how some issues in prior slides play out in reimbursement from commercial health plans. This chart shows average amounts allowed by 6 commercial health plans for basic life support emergency transports in 2022. These types of transports constitute half of the transports in our data set. And so to orient you, the gray bar represents Medicare transport rates for 2022 for areas outside of Metro Boston. The orange bar shows average contracted rates, so in other words, where there were contracts with providers, this is the average amount the plans were paying. And the blue bar shows average amounts allowed for out-of-network transports by each of these 6 plans. Perhaps as expected, in all instances, the plan's reimbursement for out-of-network transport is higher than in-network transports because there's no negotiated discount. Also importantly, there is significant variation in what these commercial health plans are reimbursing providers, meaning there's potentially different implications for plan members. So as you can see on the left, the 2 plans farthest to the left are paying almost 4 times Medicare. Often, these plans are allowing providers full charges. In fact, one plan says that this is its general methodology to determine reimbursement for out-of-network ambulance providers. In other words, it is allowing full charges as a general matter. Other plans reported allowing full charges under certain circumstances. For instance, if a member received a large balance bill, they may ask their plan to reprocess, and the plan may end up allowing the full amount. In the claims that we examined, health plans allowed full charges for emergency transport 68% of the time. So when this happens, there is no balance bill by definition. However, the data confirms concerns we have about cost sharing. It is not necessarily the health plan paying when the full charge is allowed. If there is a deductible, for instance, the bill can be significant. We found in a subset of claims where there was a deductible applied and the full charge was allowed, the average deductible responsibility was approximately $970, exclusive of what would be paid for mileage, which would be an additional charge. So looking back at the chart, going from the middle to the right, the health plans allowed amounts for out-of-network transports are decreasing, and this includes plans whose out-of-network default rate, we were told in one instance, is Mass Health rates, and another plan who uses Medicare rates. The members in the plans in the middle and to the right, the plans that are generally only allowing partial charges, are at risk of balance bills. So going into this examination, we had seen data and reporting, including from the HPC, on potential balance bills, but we did not know the extent to which, for instance, municipalities were actually sending these bills. So we asked about this practice in the survey. We found that 96% of survey respondents said that they send balance bills sometimes or always. Only 4% said that they never send balance bills. We also collected data and some records from private providers who were issued subpoenas. This provided insight into some potential outcomes after a balance bill is sent, as is shown in this flow chart. And it gave us a data snapshot that aligns with what we see in our consumer complaints. Consumers are struggling to pay balance bills. By way of example, one private provider sent out about 900 balance bills relating to ambulance services provided from September 2021 through 2022. Approximately 70 consumers had these bills reprocessed by their health plan. So this again typically happens when a consumer received a bill, asked their health plan to rethink what they would pay, plan did so, and then sometimes these consumers end up without any balance. This, of course, is great for the consumer, but at a system level raises concerns that only a select group with ample healthcare literacy are able to do this. And then looking again up at the data, half of the accounts with balance bills ended up in collections at some point. Approximately 1/3 of the patients paid balance bills, totaling approximately $217,000. Finally, we wanted to take a high-level look at medical debt relating to ambulance services. The 4 private providers receiving subpoenas were asked how many accounts and what was the total debt you sent to collections in relation to ground ambulance services provided in Massachusetts in 2021 and 2022. And the chart here reflects responses and shows not only a significant amount of debt, but that collection activity is trending upwards. For these 4 providers in 2021, $23.4 million in debt was sent to collections in relation to nearly 29,000 accounts. In 2022, this increased to $27.5 million in relation to nearly 31,000 accounts. So we don't have insight into the particulars as to who incurred the debt or for what services. But our data request was not limited to commercial health plan members. And in fact, some of these providers have relatively low out-of-network commercial health plan transports compared to total transports. So we believe that what we are seeing here is likely a mix of scenarios in which consumers cannot afford ambulance bills. It could be issues related to in-network cost sharing, it could be public plans coverage issues, and it likely includes some uninsured consumers, for instance. So based on these findings, we lay out 3 recommendations. Our first recommendation is based on the principle that while EMS in Massachusetts must be funded adequately, funding a sustainable EMS system should not fall disproportionately on commercially insured consumers. So in short, ambulance services cannot be cost prohibitive for this cohort. Accordingly, we recommend a policy response that includes a prohibition against balance billing, something that all stakeholders seem to be in agreement with, and no balance billing must be paired with an established reimbursement rate for out-of-network services. We don't opine on what that rate should be or how it should be established. It should, of course, be fair and reasonable, and importantly, it should factor in potential cost share. That is something that we wanted to emphasize. So in other words, any policy solution should not convert what are now high balance bills into large bills due to cost sharing. Our recommendation 2 pertains to operating costs. To state again, our report does not make findings on ambulance operating costs, but this is an area that needs to be understood. What are costs and how will these costs be met in order to sustain the EMS system? First, we believe that there is value in looking at what other states may be doing in terms of funding outside of health plan reimbursement. We also recommend consideration of structural changes, including more regionalization of services. This recommendation in particular lifts up what we've heard from our small communities that face budget constraints and may not have a sufficient tax base to support municipal level services. Some of our smaller communities emphasize that they are struggling to provide ambulance services and have suggested that regionalization and multi-community providers could help. And our final recommendation is to consider and facilitate other care models to ease the burden on ambulance services where appropriate. We have heard from providers through survey responses and conversations that EMS system may benefit from increased efficiencies. Specifically, we were told repeatedly that there has been a surge in mental health related ambulance responses. Other municipalities say that they're seeing a large increase in calls that are really non-emergent situations, including responses that require an assessment and some amount of care, but do not require ambulance transportation. In some instances where care is provided, a patient may refuse transport for whatever reason. But since health plan reimbursement is heavily tied to transport, if there is no transport, a provider is not often reimbursed. In other instances, Massachusetts residents, for whatever reason, perhaps a lack of alternatives, are using ambulance transports in situations where it may not be necessary to do so. And these individuals risk potentially large bills, of course. Accordingly, we recommend study and promotion of community paramedicine and care segmentation as appropriate. And on the mental health side, facilitation and support of mobile crisis intervention, which of course is a key part of the state's behavioral health roadmap with respect to ED diversion. We believe that both could be effective ways, where appropriate, to limit unnecessary ambulance response and transports and could result in cost savings to both the system and the patient. Thank you.
Thank you so much. Any questions from commissioners? Yeah.
So that was fascinating. I just want to pick up on one of your themes towards the end, which is there's absolutely no reason why this should be done the way it is now. And I, in my mind, the entire time I was thinking, well, suppose we did the same for fire services, right? Like when your house is on fire, you call, and most likely it's an out-of-network fire department. But of course you didn't know that. And then they show up and then they sort of send you a bill for like, putting out the fire in your house. And then you're afraid to call the fire department because if it's an out-of-network fire thing, you can't afford it anyways. And so our solution there was just to say, look, we're just going to tax you and we're going to pay for the fire department. And the same thing with police. Like if every time you called the police, you had to worry, was it the in-network police or the out-of-network police? Then you wouldn't call and so on. And so our solution there was just to tax people and pay for the police. So like all emergency services, we like tax people and we pay for them because like in an emergency setting, you don't have time to figure that out. So I don't understand why ambulance, I'm not blaming you, I don't understand why ambulance is the one emergency service in life where we say, no, that's okay, we'll actually do it this other way where you don't know what you're getting. And it's an emergency, so you don't have time to figure it out. So like, we really just ought to change the entire funding model here. Just say, look, I think the reason why we don't, if I understand it right, is that the towns make money off of this. And so then they kind of want to keep it that way. So they want to send the bills to collection so they can collect, which is just like a stupid tax. It's a really dumb tax because it says tax you when you're sick and stuff, which is just like an incredibly awful way to do it.
Yeah, I don't know. We didn't, again, look into costs or kind of, again, how much of those costs are being met. So I don't know that the towns are. I mean, I think the town's responses are that they're not making money off this. They're not able to sustain their services. But we do agree that there's perhaps better funding
And if it
models
has
or
to be at
additional
that
funding
level,
models.
just tax people to pay for it. Just it's a public service, so fine. That's what we pay taxes for.
So if I may add, David, I agree with you. And then working in a municipality, there was a 911 call, police goes, fire goes, and EMS goes. And so if it was all put in one, and that's those decisions of who needed to respond, we can also save a lot of money in that perspective.
questions?
Thank you so much for your presentation. This was very informative, very interesting research. I think one thing that I'm taking from this presentation is that we could potentially add ambulance costs to the costs of hospital closures or the costs of maternity ward closures, because, you know, just thinking of the most recent maternity ward closure in Leominster, now for folks who are pregnant and in active labor who live in the Leominster-Fitchburg region, they have to travel further. And for those who don't have access to their own means of transportation, they could end up calling an ambulance. And as you say, they're billed more for the distance that they travel. So their bill in that situation gets even larger and larger. And this is actually something that we're seeing in research that we're doing in Washington, D.C., where there are no longer any hospital maternity wards in Northeast or Southeast D.C. And so everyone who lives in those quadrants of the district, which are predominantly Black, by the way, have to deliver in Northwest. And oftentimes we hear of folks having to call an ambulance at the time of delivery. It's not an uncommon situation. And another question just around the sort of the municipality's role in providing ambulance services. In your research, did you find out anything about the origins of that? When did that become the municipality's responsibility? And does it have anything to do with sort of overlapping needs of the fire department and EMS? Where does that come from?
I don't know the origin. No, I don't.
Good. Thank you so much, and good to hear the next steps that you've proposed, and we'll look forward as this plays out. Thank you.
Thanks.
We'll now turn to our first witness panel, which will be focused on the role of health plans in driving affordability and equity. And I'd like to turn it over to Commissioner Haupt and Mastro Giovanni.
Wonderful. Thank you. Just want to invite our healthcare carrier leaders to the table. Well, good afternoon and welcome. Welcome to our Session 1 witness panel on the role of health plans in driving affordability and equity. My name is Patty Haupt, and I represent employer purchasers of healthcare here on the HPC board. I have over 4 decades of experience in this market and have worked both on the carrier side as well as the broker side of the business. It's a great place to start your career, by the way. Most recently, I served as executive director of the New England Employee Benefit Council, a 1,200-member organization of employers, their advisors and brokers, and carriers, where much of our focus was on improvements and innovations in the healthcare space. The purpose of the first panel this afternoon is to convene health insurance CEOs and the director of the Commonwealth's Insurance Exchange to discuss the role and responsibility of health insurance plans to advance affordability and equity in Massachusetts. The goal is to draw upon themes from this morning's sessions, including the need for policy action to make health insurance more affordable for residents and employers, particularly small businesses and their employees. So I'm just going to pick Tim because you're here at the end to begin our session.
Excuse me, alphabetical order, I guess.
Can you just move the mic?
Yep, sorry. How's that? That better? Yeah, thanks for having United Healthcare here today. We're happy to be part of the solution to see what we can do to help drive more affordable, simpler care in the state of Massachusetts. We look forward to the conversation and what we can share and talk about some of the topics that were shared earlier today. Again, our focus in all of our markets is to really bring forth simpler, more affordable, supportive care through the products that we distribute in the commercial market. That's it's something that we take great pride in, and we hope to continue to push that agenda here in the state with some of the ideas that we've brought forth that you may have seen announced earlier in the year that we can talk about as we go through the conversation today. So we have some real examples in the market that we think have tried to push things that are member centric, that have tried to leverage our technology agenda inside the company, and also reach across our whole enterprise and see how we can drive and meet the goals that we that I stated earlier. So look forward to the conversation.
Wonderful. Thank you. Audrey?
Good afternoon. Thanks so much for the opportunity to speak with you all today. Thank you to the Health Policy Commission for all the work and for this conversation. So I am wearing a bit of a different hat than my colleagues on the panel in the sense that I run the state's health insurance marketplace or exchange. We have relationships with all of the carriers who serve the merged market here in Massachusetts. And we have a number of tools that I think are worth mentioning here that we are bringing to bear, and I think bringing to bear well in terms of promoting affordability and equity with more work to do. So I would like to just highlight a few of those and then also talk about the tools we don't have, because I think that's a part of the conversation that we all want to have together. So as our marketplace, some of the tools we have that are proving to be particularly impactful at providing cost relief, affordability relief to both individuals and small businesses here in the Commonwealth are we have access to subsidies. We have access to federal and state subsidies, thanks to the Affordable Care Act. We are able to connect people with robust subsidies that lower the cost of care at both the premium and the cost sharing level. We're very fortunate to be in this particular state that has year over year made investments in what we call a state wrap program, where we're wrapping federal subsidies with additional state dollars to bring down the cost of care. We're very grateful to the governor and the legislature for the expansion of the Connector Care program on a pilot basis, which the governor spoke about this morning. That will raise the income limits of the help we provide through Connector Care from 300% of the federal poverty level up to 500% of the federal poverty level. So kind of scooping moderate income families who are really feeling the pinch of inaffordability into the protection of that program, which has lower premiums, low cost sharing, no deductibles, which is very relevant to a lot of the research that HPC has put forward. We expect that help to help tens of thousands of families newly this open enrollment period. So we're very excited to be rolling that out. We also have tools in the design of our program like Connector Care, where we're able to bring public investments forward to meet the state's affordability and equity goals. As an example, starting in 2023, we eliminated cost sharing for drugs and services associated with 4 chronic conditions disproportionately borne by communities of color: diabetes, coronary artery disease, hypertension, and diabetes and asthma. And so those are some of the ways we can use the public fisc to reach some of these goals that we know we need to around affordability and equity. And I would also note on the small business side, powerful competitive tools for small businesses to compare choices that results in very different decision-making and savings that small businesses are realizing on exchange as opposed to off, saving 20% for small businesses. And just briefly, we can talk more about this, but because the exchange and the marketplace is the state's interface with the commercial market across all payers, we have opportunities to think new about how we coordinate with other state payers, Mass Health, GIC, to think in a more coordinated way about how we pay for value, promote affordability, and advance the state's equity goals. So look forward to talking more about those tools that we have at our disposal. And then just last would note, the connector does not have the ability itself to touch the drivers of cost that have been shown time and time again by HPC and others around unit price, pharmaceutical costs. And that's really where we need to see a more empowered HPC, in line with the recommendations that they've put forth. So we welcome the opportunity to be a part of that conversation and that next frontier of cost containment and advancing affordability and equity together.
Wonderful. Thank you.
Good afternoon, Chairwoman DeVoe, Director Seltz, and members and commissioners on the Health Policy Commission. Thank you for inviting me again this year to participate in the cost trend hearings. Looking forward to the conversation that we'll have on how we can advance affordability and health equity, which in my view are inextricably linked, and looking forward to that conversation. I'm proud to serve as the leader of Point 32 Health, which is the parent company of Harvard Pilgrim Healthcare and Tufts Health Plan. We serve over 2 million members throughout New England, 5 states in New England, with over 1 million of those members being right here in the Commonwealth of Massachusetts. Our purpose is to guide and empower healthier lives for everyone. And when we say everyone, we mean everyone, which is why health equity is core to the work that we do within the organization. Proud to be the only health plan in Massachusetts that serves every segment of the population through our government and commercial products. We are the largest health plan on the connector, the largest health plan serving seniors through Medicare Advantage, and of course, actively participate in mass health. So we have a unique perspective on the needs of the population. And as we think about challenges that we face as a health plan, it's important to remember as we're having this conversation that we are required to spend 90 cents of every dollar on direct care for our members, 90 cents of every dollar. And clearly the drivers of that cost are the underlying cost of care, with provider prices and drug prices or pharmacy prices being at the top of the list. And of course, utilization. We spend quite a bit of time talking about the sort of 15 to 20% of one's health outcomes that are driven by care in a clinical setting. That's very important, particularly when you need that care. But there's another 80% of one's health outcomes that come from non-clinical factors, social determinants of health and others. And so really look forward to the conversation today on that 80% and how we can really address health equity. So thanks again for inviting me and looking forward to the discussion.
Thank you. Thank you, Sarah.
Great. Well, just such a pleasure to be here. I remember when this all started long, long ago. It's just great to be back. I'm 11 months back into this community, and it's wonderful to see some familiar faces and to get to see how all of this work has advanced. So enormous thanks to our chairwoman, Deb DeVoe, to Director Seltz, and to all of the commissioners. And it really is an incredible privilege to get to testify today. This hearing comes at, I think, a really crucial time as it relates to affordability, and just having listened to all of the feedback in terms of the impact and the struggles that both businesses and families in the Commonwealth are facing is pretty profound. And concerning. And I know so much of the data and the great work that's been done by the Health Policy Commission is actually looking back to 2 years ago. And so what my fellow panelists and I are seeing is more recent data, 2022, the year that we're in right now, and we're out negotiating contracts for the years, the next 3+ years ahead. And so if any of us are concerned looking back, I'm here to tell you we should be more concerned about what's ahead. But I remain incredibly encouraged by the fact that we're all here, that we've got representatives across almost the entire healthcare community and others representing the perspectives of consumers in the Commonwealth, that we can continue to lead, that we can continue to make progress on affordability and equity, which I agree are inextricably linked. And continue to be the model to inspire just what's possible, not just in this state, but for the nation overall. So I echo some of what you've heard from my fellow panelists around supporting many of the recommendations that are in the Health Policy Commission's report. The benchmark was a profoundly powerful tool when it first came out, and was literally in the room with us as we were negotiating contracts with providers. And I'm here to tell you it is not anymore. We are, as we negotiate contracts, we've got a trend, a unit price trend right now on the hospital system side that is double what it was just 5 or 6 years ago. We have providers asking us for multiples. They could be 3 to 5 times, if not more, of the benchmark right now. And so the recommendations to strengthen this tool, to strengthen the framework, the signal that it sends in this community is powerful and important. And we are also supportive of increasing the accountability and frankly, the teeth, so that it is sending a powerful signal that people really do believe will be enforced. And a whole other part of this that I know we're going to talk more about is making sure we're holding everyone accountable. So what I'm calling for right now, we welcome that same accountability we embrace it for ourselves in the same way we're asking for it from the rest of the healthcare system, from all of the participants. So I'm just really glad to be here and looking forward to this conversation.
Wonderful. Thank you. Just to begin with our first question, we'll get into a little bit more detail here on each of following up on your introductory remarks. What strategy is your organization pursuing to improve affordability of health insurance for your members? What are the most significant challenges to successfully moderating growth in premiums and member cost sharing? And what policies would support health plans to offer products with affordable premiums and cost sharing for individuals and businesses of all sizes, but with a particular focus on the small business marketplace? I know, Audrey, you're in a little different situation here, so chime in when you can and we'll move the questioning around. Thank you.
What do you want to start with?
Go
Me?
ahead.
All right, I'm happy to. So if there's one thing that I'd like to have you take away from my testimony today, it is how seriously we take our commitment to affordability. And if there is just one more thing, if I can get a little greedy, that I want you to take away, it is that our biggest challenge right now is hospital system prices. The 7 largest systems in the Commonwealth represent 80% of our medical spending. And it is our biggest challenge right now. And so we are using, given that affordability is job one for us, we're using every tool in our toolbox. So it is in our negotiations with providers, while we are trying to respect the pressures that they're feeling, it is showing up to really negotiate the best contract at the best price on behalf of our members and employers that we serve. It is getting the best prices on drugs. We have partnered with other Blue plans across the country, starting on the medical side of the prescription drug benefit, to use the collective purchasing power, not just of our plan, but of the entire Blue system, to get better prices on drugs on the medical side of the benefit. We've changed our pharmacy benefit manager as of the first of this year, which should yield a 10 to 15% savings on the retail side of our drug benefit. We continue to manage care and work to keep people out of the emergency room and to avoid unnecessary, wasteful or harmful care. And of course, we are focused on, again, back to that point of holding ourselves accountable for what we're asking the whole system to be accountable for, managing our own administrative expense, which I will note we manage well below the healthcare cost benchmark. So as Kane was describing earlier, we spend, like they do, less than 10% of premiums on administrative expense, at a trend that is not quite half, but approaching half the healthcare cost benchmark. But if we really want to get costs out of the system, we collectively need to do things differently. So we are thinking about the evolution of our value-based payments. We are right now negotiating most of those payments at the system level, and we have big systems in this state. And looking at David, because I can't even count the number of economists who've written papers talking about the more consolidated a system gets, the more leverage they have and the higher prices you see. So one of the things that we're mindful of is the modernization of our alternative quality contract and measuring provider performance at more granular levels inside of systems, so that we can try to get those economics down inside of the systems to reward and incent the kind of value that we want to create and access on behalf of our members. We're bringing new innovative providers into the market. So we brought new virtual first primary care providers into this market. $0 cost sharing for members who choose those providers. We're finding that they represent a total cost of care that's about 10% less than other providers that we contract with in this market. But the bottom line is that's still not enough, which gets me back to the comments I made a moment ago around we need a private-public partnership to do this. The private sector cannot do this alone. And so a strengthened benchmark and framework that includes really digging in even more deeply to other parts of the healthcare system that right now the Health Policy Commission may or may not have all the tools to monitor. So not just on the physician side, but on the health system side, including pharmaceuticals, which is, again, one of the fastest drivers, as your data has pointed out, and is a challenge that I don't see abating as we look out ahead.
Wonderful. Thank you.
Yeah, at the risk of just saying ditto to everything.
You can't steal her whole
Yeah,
show there.
But really, seriously echo all the comments that Sarah shared, and would just reinforce a couple points. One, our goal is to negotiate within the benchmark as we're negotiating unit cost increases with our provider partners. But the fact of the matter is, and Sarah mentioned this, it's an extremely difficult negotiating environment. There are pressures that health systems are facing in terms of inflation costs, labor costs, workforce shortages that we are certainly sensitive to. But it does create challenges as we're negotiating rates, where it's not uncommon for the request for unit cost increases to be 3 or 4 times that of the benchmark. So any efforts to address affordability has to start with rationalizing prices at the high end of the spectrum. The other area is around pharmacy cost. We too have partnered with a new pharmacy benefit manager to really drive down drug costs to the extent that we can as it relates to brand, mail order, and specialty drugs. So significant work there. But having said that, we are still seeing drug price trends, and it's in the report, increasing 7% over the last 2 or 3 years. In fact, it's the only segment of the market that actually saw increases, cost increases during the pandemic. So again, the 2 largest drivers there. And then the third, and I touched on this earlier, is addressing what I call the other 80% and efforts around social determinants of health, working with our members to close gaps in health equity. I know we're going to talk more about that in a bit. So those are 3 of the areas that we focus on. And of course, moving away from this construct of volume-based incentives, volume-based reimbursements, fee-for-service, and moving to more value-based constructs. We're making progress. 80% of our HMO members in the Commonwealth have PCPs that are in value-based arrangements. More work to do, but we're making progress there. And as we work with provider systems, they're at different stages of the spectrum in terms of willingness to participate in value-based arrangements. We know that coming out of the pandemic, more health systems are reluctant to participate in value-based arrangements because they want more revenue certainty. So again, just working to help solve some of those challenges.
Thank you. I'm going to skip to Tim next to keep in the carrier theme, and then Audrey, if you'd like to add some comments.
Double ditto. I guess not to repeat everything that was just well said, I'll take the tact of, there was a lot of ideas just shared there, right? And to me, what that underscores is the need for innovation, both along the traditional themes of product, provider relationships, provider contracting. I think it's also about, how can we bring new ideas to the market faster? So how do we partner and work through the regulatory agencies, on a more streamlined basis, right? To bring, products like we have Surest in the market, which is a copay only product that we're rolling out nationally that I think would be, well received in this state. So, how do we bring, those types of ideas to market sooner than later so that we can, impact, the members as soon as possible and help them on their healthcare journey. So, where we're focused, that I sort of weave that into our desire to see how policy could evolve in the coming, months and years.
So just to share sort of a different angle, and I would echo all of my co-panelists' points about kind of the structural needs here that we want to see addressed as well with respect to provider prices and pharmaceutical. I noted in my earlier comments that something is happening when small businesses shop through the Health Connector for their coverage. And I do just want to come back to that because I think it's not a silver bullet, but I think it could be one component of a solution when we're thinking about the shopping experience for small businesses that are looking for affordable options. So we noticed a few years ago, and actually the Health Policy Commission was very helpful in drawing attention to this, that on our individual market, which is considerably larger than our small group market, we cover about 250,000 people there. Even when we take Connector Care and put it aside, that's sort of its own individual program, that people shop very differently when they shop through a marketplace, and they can see all of their options controlled for actuarial value, generosity level, et cetera. And they gravitate towards lower cost options. Those usually come with a narrower network. There's all different kinds of reasons, cost structure, network, et cetera. And I'm not suggesting that narrower networks are the solution for everybody. They are a tool among others. But it is nevertheless the case that a very price-sensitive individual market gravitates towards some of these lower cost options. In the small group market, we have a much smaller footprint, about 13,000 lives, but growing faster than the off-exchange small group market. We see small employers doing something similar. We have different shopping models for small businesses where they can essentially break their group apart and let individuals shop from different carriers. So it's a different model. But what we're finding is that small employers and their employees are doing something similar to the individual market. And on average, for the same actuarial value or generosity level, they're spending 20% less on premium. So again, not a silver bullet, a tool among others, but as hopefully more structural solutions come into play, that model of kind of a curated competitive market that brings kind of easier access to choices where individuals and small businesses can find their way to cost competitive options, I think is an important tool in the toolkit. And it's something we're sort of testing as these other systemic solutions come into play. And we look forward to the connector continuing to play a big part of that in the small group market for affordability solutions.
Yeah, I think there's still not the same awareness of business opportunities to shop in the connector, and that's probably something we could work on promoting that as a really good option for people. That's great. My next question is, what is the health plan's perspective on the continued loss of primary care, behavioral health, and maternity services in the Commonwealth, particularly in smaller community-based settings, given that the closure of these services is usually related to reimbursement and lack of financial sustainability? I know we've talked a lot about maternity, but I also just want to refresh everyone's mind on the pediatric situation that's taking place. And a year ago, we had the RSV and flu and COVID all at the same time, and lack of accessibility or pediatric care in the marketplace. So I'd love to hear your thoughts on that and how we solve for equity in terms of access.
I guess we'll just keep going in this order. It's fine with
We
me.
can reverse order if you want, but.
Oh, no, I'm always happy to talk first, so jump in. So I think we should be concerned. And I think there's even a longer list of things that we should be concerned about. And so on my mind, since I've come back to the Commonwealth, has been where we are in terms of health planning, and really taking a step back and taking not just a 5-year view or a 10-year view, but a 20-year view, and asking ourselves, what do we expect? How do we expect the population to change? What's the distribution? Where are people going to live? What is the profile of the population, taking everything into consideration from age to race to preference in terms of how they want to get their health care, and develop a point of view then of, well, what do we need in terms of resources to serve that population, and where do we need those resources? And then if we can get alignment on some of those things, we can then shift into the mode of mapping the system that we have right now and the parts of the system that we also think are vulnerable, so that we're really doing that in a much more proactive way and not finding ourselves in the event of a closure, an emergency situation, or a transaction, trying to figure this out, or conducting a determination of need review. To me, this is about actually really having an assessment of what is the need with a longer term view in the Commonwealth. And so that's something that is very much on my mind, so that we can get ahead of this and think about, what should the workforce look like? How do we have a workforce and a distribution of providers that look like the patients that they're going to serve. We've got a lot of opportunities, I think, to be much more proactive about this. It's something that we'd love to find ways to lean in and be supportive, whether it's with the Health Policy Commission, whether it's with other parts of state government or other people who are testifying on these panels today.
Yeah. And what I would add is we too share deep concern over the loss of community-based services, particularly as it relates to primary care and behavioral health. We've made investments in a number of communities to help solve for that. But having said that, in order to drive down the cost of care and improve affordability, if we're going to make new investments in primary care and behavioral health, again, we have to address the underlying drivers of cost that we've talked quite a bit about. And so those are just, as we're thinking about it, certainly we want to, continue to make those investments, but we have to address those underlying issues.
I'm happy to add, just from our perspective, obviously those closures are alarming. And from a marketplace perspective, when we're thinking about multiple carriers across multiple regions of the state, we have to think carefully about network adequacy. So that's another dimension of this that I think deserves a careful look. And obviously that's within the Division of Insurance's domain. The connector has some of its own network adequacy standards for the connector care program. But it intersects with a lot of the thinking we need to be doing about making sure people have access not just to providers in their region, but that are culturally competent and provide the right language supports, et cetera, for folks in those regions. So that's on our mind from a program administration perspective, even separate from the payer space.
Audrey, just to follow up on that, when people enroll and they're in a more focused network and perhaps don't realize that they are you getting a lot of feedback about people not having access to primary care or culturally appropriate care in their community because of the narrowness of the network and maybe a misunderstanding there?
I wouldn't say we've heard specifically those concerns, but I would say those issues pop up in other data and feedback we see from people. So we can see in our regular survey data of our members that people often forego care. And I think that's a topic we can come back to in the equity conversation because it intersects very strongly. But we imagine, I think it's a safe connection to make that for people in regions where things are closing more, it is harder to get to care. And so it may be more likely that they're foregoing or putting off care. So even if we don't hear directly those sort of complaints, so to speak, I think it's showing up in it being harder for people to get the care they need as quickly as they really ought to.
Awesome.
Thanks. Yeah, I'll just add some, I guess, tactical observations, right? I think one thing that's tried to come into the market is the virtual side of things, right? There's, that's been a big success on the behavioral health side. We've seen, consistent usage of that, since the pandemic, which I think is a good thing. On the sort of the replacement of, primary care virtually, a lot of us offer that. And I think it's a good avenue for people to realize that they have, that it's an option to increase access when you need it, whether it's primary care or dermatology or something like that, just to really say, maybe I should start here as another avenue. It's not maybe the silver bullet to fix the whole problem, but certainly it's an option. And I think it's probably being underutilized right now, to be honest. And some of that may be, given the situation of the individual person, I get it. But broadly speaking, I think there's probably room for more access to go through there to at least maybe, close that time gap before they find a in-person event or in-person access somewhere down the road.
Absolutely.
Commissioner, can I redirect just on this topic?
Absolutely.
I appreciate the comments and the concern about some of the closures and services, and this is going to be a topic on the next question, on the next panel. But when we look at the data, and this is one of the unsolved challenges in our policy space, is the wide range, the wide variation in commercial pricing. And what we know about that commercial pricing, as we saw earlier in a presentation, is that it tends to be the providers that have the highest proportion of commercial payers that have the highest commercial pricing. And it's the providers who treat the highest proportion of public payers that have the lowest commercial pricing. And so you're getting a lot of requests for high commercial price increases right now. And the leverage that the big commercial plans have is more. And so they're able to get those price increases while the smaller providers, the providers that treat more government patients, who treat more non-white patients, are not able to get those price increases. I hear from both you, Kane and Sarah, that you would like to be able to have some more tools in your toolbox to be able to redirect those reimbursements and those price increases in the areas where they're actually needed. What's stopping you from redirecting those price increases, and what tools would you need from government?
So a couple thoughts. One, and it was mentioned earlier, that what we see is that the 6 largest provider systems in the Commonwealth drive over 50% of the commercial volume, right? So in the reimbursements to those providers, or really all providers, are not tied to necessarily quality or the demographics of the population that they serve. There were a number of recommendations that were in the Health Policy Commission in the sort of the 9 recommendations that we support to help, again, rationalize some of the challenges that we see at the largest end of the market. Again, we know that those 6 systems, on average, are 36% more expensive than the average. So there's a number of actions that the Health Policy Commission can take, like reviewing spending above the benchmark as one example, like more authority in the performance improvement plan process, and showing savings that are targeted, how it actually transfers and benefits the actual patients or members. Drug cost, we've talked about pharmaceutical prices, more authority by the Health Policy Commission on pharmaceutical companies and PBMs. As I was looking at the panelists, I didn't see anyone from the pharmaceutical industry testifying here. So that's one opportunity, perhaps, in holding that industry accountable for the trend benchmarks as well. So again, it just gets back to if we're going to drive down cost, we have to address spending at the high end of the spectrum.
Now it's my turn to say ditto. Ditto, ditto. The only things that I would add is, to me, a lot of this it comes back to, we need a benchmark that has teeth, that people really do believe is going to be enforced. Because if we look back at the early days of the benchmark in the market, and we've reviewed our data on relative price, we've actually made some progress. It may not be fast enough, it may not be big enough, but we have made progress when we had that out there as a tool that was being taken seriously by the market. And it enabled us, because we, like Kane, we want to be paying for value. Our payment contracts were in the same place. 80% of our payments are done in value-based arrangements. The intent of that is to be paying for value, is to incentivize providers who are getting both the affordable care that we're all talking about here, but great patient experience, great quality outcomes, who are focused on equity and reducing disparities. That's our intent, is to be able to actually give more to those parts of the systems. That's just really hard to do when we also have to balance that concern around affordability writ large, and what families and employers in the Commonwealth can't afford. So it's got to be about that thoughtful rebalancing over time.
Any other responses on that question? I'm going to turn things over to David Cutler.
So thank you, and thank you all. I'm going to shift gears, and so the topic I'm going to ask you about is administrative costs. So this, Audrey, this may leave you aside for a second, so I apologize on that. Over the past couple of years, the Commission has done several deep dives into administrative costs. And in our cost trends report, we have one of our 9 recommendations is about administrative costs. And so we made 3 recommendations to the legislature. So we made one recommendation that there should be greater standardization of billing and other policies across all the insurers, and thus, therefore, across the payers. Second, that there should be greater automation, so that we should work to put in more automation of processes, again, including on billing and on prior authorization, and so on. Third is that there should be quality measures which are aligned and commonly measured across different plans, so that instead of providers figuring out one quality measure for one plan, another for a second, another for the PPO of a third, and for the HMO of a fourth, and so on and so forth. And so we've recommended to the legislature that they enact legislation consistent with this. So my question for you is, do you endorse those recommendations? Do they go too far? Are there others that you would add? I'll just say by way of background, part of the reason why we're interested in this is administrative costs are estimated to be 1/4 of medical spending. And we've seen reports, some of which I've been involved in, so they're not totally independent, that a quarter of that quarter could be saved if we applied best practices from other industries to healthcare. So these are all about applying best practices from other industries to save several percent of healthcare, which would be a very meaningful amount.
Yeah, I would say that we do support those recommendations. And going back to what I said at the beginning, just as a reminder, 90 cents of every premium dollar that we bring in goes back out in the form of medical costs. Now, that 10 cents, there's opportunity there, and that's really what we're talking about
Just
here.
to be fair, sorry, just to interrupt you for 1 second. Most of the administrative costs are in the provider side, not on the plan side. So they're in the doctor's offices, in the hospitals, in the urgent care centers and so on.
No, fair enough. I understand that. I appreciate that clarification. I guess what I was saying is that from a payer perspective, for every dollar we bring in, 90 cents goes out for direct care from a health plan standpoint. Having said that, we support those recommendations, and we are active participants in the MASS Collaborative, which is a collection of 35 payers, providers, and other associations to really get at driving administrative simplicity. Many of the things that you recommended, having a common or single form as it relates to prior authorization, which is certainly a hot topic. Prior authorization is a valuable tool to ensure that the right care is delivered in the right setting at the right time. But there's things that we can do, whether it's automation or use of AI and other methods, to make it simpler and easier for providers, recognizing that that's a burden. Credentialing is another significant area and can be a burden. And the MASS Collaborative, we've collectively developed a single platform for credentialing, so that providers aren't having to fill out different forms and follow different processes for each payer. And then finally, provider directories, which is an area that we're constantly focused on in terms of improving efficiency. So the short answer is yes, we would support those recommendations. And then I guess lastly, I would just say on the quality measurement, sort of the aligned measurement set, when we're negotiating contract with providers, we first look at those aligned quality measurement sets to determine whether or not the provisions that are in the contract are consistent with adhering to that. So we're supportive.
Largely ditto. And at the risk, in order to not be repetitive, there's one thing that you did not raise that I just want to flag, which is, I think, something else that could get added to the recommendations that relates to data sharing. So in order to fully unlock the potential of simplification and automation, it would be really great if we had standardized ways of sharing data between payers and providers. And we don't right now. So we are living in a world in which when you want to do this, you're essentially building the pipes on a one-by-one basis, it's a very expensive and costly way to do this from just, frankly, not just dollars, but even a bandwidth perspective as it relates to both payers and providers. And so I think there's an opportunity here to really think about whatever you want to call it, but a data exchange of some kind that allows for real-time data sharing. That's what it's going to take to most efficiently unlock the power of automation. And we are all for automation. we did one pilot that I believe has been talked about here before with New England Baptist, where we were able to automate prior authorization, and was pretty profound, went from an average 9-day turnaround to basically instantaneous within a day. Interestingly, the company that we partnered with to do that, to actually do that building the pipes between the providers and us has subsequently shut down because building those pipes is so expensive and not a particularly sustainable business model for a startup trying to get into this space. So I think this is an opportunity and another place in which Massachusetts could lead. And I really do think it's going to be a precondition to unlock a lot of those administrative savings in the long term.
Yeah, I mean, excuse me. I would just underscore the technology side, the automation piece of it for sure. We've gone down the path of providing tools and capabilities that can embed themselves in EMRs for doctors that can help with that data exchange. Already back in 2023, around March, we announced, our program to remove 20% of prior authorization from, I guess, 20% of the codes that have it today, and look at a gold carding program in 2024. So we're not, blind to the fact that, the administrative side of the equation needs to be looked at continually. So I think we're I don't know if excited is the right word, but we're proud that we've started to take a step in that direction, and hoping that, the providers start to see some of the benefits, and then we can, see if there's more standardization or whatever, or more codes in the future that can emerge that'll help alleviate some of the burdens if the data, so justifies it. So, but agree that, in this day and age, given how everything really works today, that technology and better data exchange is really the foundation to making that process work better.
But you didn't say yes or no to do you support the recommendations?
I said what I what I think I wanted to say. I mean, I think, I definitely support the, that's sorry, that came out all wrong, but,
It was honest.
Yeah.
You are under testimony.
That's right,
You're at
exactly.
oath, MEO.
So, no,
The things people say to me usually are so much worse than that.
Yeah, I'll do that first. No, I think that's, I think what I said is really where United's position is today. And then we'll see, what we can evolve in the future. So.
You all set? Yeah. Okay. Okay, Barbara.
Thank you. Thank you for your comments so far. And I'm sure we all appreciate your support of the commission's broadening strength and ability to manage and recommend what we are already charged with, especially as we look at pharmacy. But I'd like to come back to Director Seltz's question of what can you do as insurance companies? What can you do today, tomorrow, Monday morning? What tools are available, or what creativity can you think about that would help reframe and decrease costs from your perspective as you negotiate your contracts, as you think about additional service models, and what can you do as part of the solution?
Yeah, so some of this we've talked about before, but just to sort of reinforce, value-based contracting, really moving away from volume-based incentive to outcome-based incentives. And as I mentioned before, providers are on different ends of the spectrum as it relates to their ability to engage in value-based constructs. So we've created a framework that provides flexibility ranging from sort of pay for performance all the way to full risk, and in some cases even joint ventures to sort of get at the volume issue in improving health outcomes. So that would be near the top of the list. And as I said before, although it is a challenging rate negotiation environment, we have to stick to our conviction around increases that are as close to the benchmark as possible. And then third, addressing improving the health of the population, which gets at utilization and investments, whether it's investments in healthy food or transportation, solving for language barriers, the social determinants of health, and driving areas there. And we haven't talked much about health equity yet today, but this really gets at the core of that, and identifying areas where we can work together across government and private to address areas that are concerns for all of us, like we talked about maternal health as an example. I'm happy to talk about a number of initiatives that we have there, but we can't do it alone. And if we can identify areas there to work together, it would be helpful.
Yeah, I mean, I'll just mention a few others. So just to go a little deeper on value-based care, I mentioned earlier that because we have so much consolidation, there really is an opportunity to modernize, and we're focused on that at Blue Cross, our value-based contract in a way that gets the economics lower down inside of these big systems. And so that's something we're working on right now. That will take some time to do. And, you know, part of Director Seltz's comment was also in that space of price variation. And so I think, as Kane said, we've got to hold the line on the providers that are at, you know, the highest end of that payment spectrum, while also recognizing the pressures that they're under. I know that's what you're going to hear about this afternoon, and they're real. Mm-hmm. And so it's, you know, in trying to balance that concern for the affordability of premiums for employers and consumers, trying to make progress also on supporting the parts of the delivery system that are on that lower end in terms of that, that continuum of payment levels. It's a really tricky balance. And so it's something that we are focused on day in and day out and are making progress on, but it's going to take time. And therefore having that strong signal from all of you about what is a reasonable expectation for healthcare cost growth is going to help us pretty profoundly. And so we'll keep doing all of these other innovative things. I talked about what we're doing as it relates to getting the best prices for pharmaceutical drugs, not just on the retail side, but also on the medical side for drugs that are provided in clinical settings that they're not getting through retail pharmacies. It relates to inviting new people into this market. So we're announcing new virtual first providers that are responsive to folks struggling with chronic conditions, whether those be musculoskeletal, whether that be near and dear to my heart. I'm really focused on women's health, folks that are supporting, thinking about starting families or navigating menopause. We're bringing new entrants into the market that have a different kind of value proposition, both in terms of price, but also in terms of member experience and getting people appointments in much shorter time windows. So we're thinking about it every day.
If I may, just one last follow-up, and then I'll.
We have a few more questions, so
I'm sorry.
We'll keep it moving. Are you all set?
I am.
You off.
Thank you.
Okay. Tim Foley's been waiting.
Oh, no problem. Thank you. And thanks for being here today. Appreciate the testimony. One of the things I've been thinking about when listening to this conversation, I think it's a really important one, clearly, is this notion of accountability. I think Sarah heard you say, you know, there's things that you want to hold folks accountable to and what we should hold you accountable to, and kind of want to dig into that a little bit more. Because we're talking a lot about the benchmarks, and we've had one policy recommendation to give the HPC more tools within the benchmarks. We've talked about the price disparity issue that Director Seltz just highlighted, and how that's kind of baked in the price disparities in the network, in the payer and the provider negotiations. We've had these hearings in the past and have heard from, you know, the Lawrence Generals of the world, and how you look through a health equity lens and the payment that they receive versus other providers is a significant issue. And I think that's a good conversation of one of our recommendations to really hone in that benchmark onto where we want to put more value, more spending versus areas we may not want to. But we've also talked a lot about affordability benchmark and a health equity benchmark. And I guess the question for this panel would be, when we think about the affordability benchmark and the equity benchmark, what are the things that you think should be included in that? And what should we hold you accountable to when looking at it through the lens of an affordability or a health equity benchmark?
So I'd love to start and just say, I think we need both. And I'm always mindful of that phrase, measure what matters. And so without targets and the signals it sends collectively to all of us as a community about, you know, what our expectations are, what we want on behalf of residents of this community, you tend to make progress faster when you've set out a goal, even when it's a goal that may feel like a real reach or a stretch in parts of the community. So we are supportive of it. And I just want to say a few words on equity, because I haven't talked about it yet either. It's a profound area of focus and concern for us. And so we've talked a little bit in a couple of answers around value-based contracting, we are now at a point where 25% of the value of our quality incentives in our value-based contracts are attached to health equity. We are now partnered with 5 of the largest health systems, some of whom you're going to hear in later panels today. And so I'd encourage you to ask them, how it's going in terms of their partnership with us and the work that they're doing. But it represents about half of our members are now with these systems that are working on everything from diabetes care and cancer screening and other areas all together. And we are putting dollars behind that. We've given more than $25 million worth of grants over the last few years to different parts of the healthcare system for equity-related work. But I think it would be an incredibly strong and powerful signal to the whole community about this is a priority for us as a Commonwealth, for that particular recommendation to move forward. And you've heard me already say multiple times that I'm on board for an affordability index. And I think we need to consider that holistically. It should not just be about premiums. It should also be considering the total cost of care, the burden on consumers. I think the more transparency and understanding we have as a community of the challenge, the better we're going to be able to have conversations like this one about what are the tactics that are going to help us make progress faster.
Yeah, I would agree with all of Sarah's comments. And what I would add is we are open to additional tools like a health equity benchmark or affordability benchmark, as you describe. My thought is that the more specific we could be in terms of, and the Health Policy Commission can help with this, setting the targets on areas of the gravest concern. So I use maternal health as an example. And we've heard from the Attorney General, and I know that this is a passion of hers, deep disparities as it relates to maternal health for Black and brown women in the Commonwealth. So what if the HPC were to set a target and a goal or a benchmark that all players in the healthcare ecosystem, whether you're a health plan or a payer, a health plan or a provider, is held accountable to, and tracking the progress on closing those gaps, which are well known and well documented. So the more specificity in the benchmark would be helpful.
So supportive of both the affordability metric and frame as well as equity. And I would just say from a tactical perspective, the connector would be glad to partner with HPC on thinking about that affordability benchmark. I know there's great examples out there with respect to Rhode Island and other models. I would also just note the connector itself has nearly 20 years of experience setting affordability benchmarks, as we need to do it for the individual mandate. We have to make decisions about what's an appropriate level of spending for someone to be sort of held to, under which the Commonwealth decides whether somebody ought to have to carry coverage or face a tax penalty. So not exactly the same, but I think there's some transferable concepts we would welcome the opportunity to work with the Health Policy Commission on. On equity, I also think this is critical. I think one interesting model that could be looked at in the Affordable Care Act, there's a really special, I think, underappreciated section called Section 1557, which deals with non-discrimination. And it asks health plans and others in the healthcare system to look at particular conditions, people who bear a disproportionate level of disease or healthcare spending, and make sure that health products are not overly burdensome to those individuals in some particular way that could be considered discriminatory. So that, for example, historically, people with HIV would be subject to higher cost sharing for the drugs and services they needed to stay alive. So I think there's interesting models out there for thinking about how equity could be looked at as is something we measure kind of inside of the benchmark writ large. And I think that's critical because we know that there are people living with conditions and health outcomes that are a direct result of structural racism, and essentially they're bearing a tax being levied on them for that history. And I would love to see the Health Policy Commission's benchmark acknowledge that, measure that, so that we can all be working towards addressing those head on.
Okay, I know we're coming right down to the wire, and next year we're going to need another half hour, David. But Ron, I know, had a question. He's going to close out the session as well.
Oh,
bring the mic.
No time for one question down here? If there's time, after you, Ron, go ahead.
Oh, okay. My background is in administering healthcare systems in small companies, and that's what I basically bring to the party. But at the same time, this relates to my question. I run a company, and what we do is we project healthcare costs in the future. And one of the things that we have to do is look at what's next year's cost going to be, right? And I'm really looking for some guidance on this because I was kind of surprised by the numbers that I've been seeing. And this is related to seniors. When we're looking at equity, you have people on fixed income and how are they going to handle things. And I don't know if this is related to the fact that in 2025, the maximum out of pocket on drugs on Part D is going to drop from $7,000 to $2,000, right? On the other hand, the responsibility of the insurer is no longer going to be 20%. It's going to go up to 60 to 80%, depending upon what the cost is for. And what I noticed is for next year, even though we're looking at 2025, and I'm looking at the increases, I'm not going to mention names, just in Massachusetts, I just looked at 5 insurers, and the range in price increase is anywhere from the low 20% to as high as over 50% on the high-end drug plans. On the low-end plans, it could be up to 100%. And I'm just trying to understand, is this related to the fall in the out-of-pocket costs? Like, what's driving that? And I'm just trying to understand it.
Are you looking at like a government plan specifically? Is that?
No,
or
I'm
just
looking,
on your
I'm looking
commercial?
at the carriers
Okay.
and I'm looking at what they charge for a particular plan in 2023
Yep.
versus 2024. Now, obviously, plans can change in
Right,
terms of coverage
right.
and stuff, but typically not by 100% in terms of premiums.
No.
I'm just trying to understand, is this related to this, to the 60 to 80% that now, that the insurers will now be responsible for? That's what's driving this?
Yeah, I mean, to me, it sounds like you might be looking at something outside of the commercial market. I mean, we don't have plans. I mean, just more broadly speaking, our increases, as Kane outlined earlier, right, are predominantly driven by, what is our unit cost going to be for the next coming couple of years? Where do we estimate utilization coming in? Where are services going to be procured? So that's all factored in. Certainly, drugs are a higher trending item within that construct or within that actuarial determination. So I'd have to look at the specifics of what you're seeing just to kind of give you a more direct answer. Because our pricing is obviously all in. It's not drugs versus medical per se.
I'm talking about Part D
Yeah,
specifically.
yeah,
That's what I was going to say. I was going to
to.
offer the same thing.
Yeah.
Happy to follow up and dig in with you, but it sounds like you're asking about Medicare Part D
Yes, Right.
and
yeah,
premiums
exactly.
and isolated standalone Medicare Part D premiums.
Standalone, not Medicare Advantage, standalone Part D.
Yep.
But the price increases, and I just assumed it was related to the fact that now the insurer will be responsible for 60 to 80%. I was not aware of that until recently. And I thought maybe that's what's driving this. I was just trying to understand it.
Okay.
So I mean, yeah. So just quickly, we have somebody on our side that does Medicare.
Yeah.
outside.
We have one
Last
quick
question. We talk about a lack of primary care providers. We talk about a lack of behavioral health providers. We also have a lack of wraparound services for somebody to visit people at home because reimbursement is low or not even exists. So why is reimbursement so low for a primary care provider and for behavioral health? Because I will guarantee you that if you increase the reimbursement on that and primary carers got paid more, the numbers would increase. Right now, you have primary carers who are working round the clock, and the reimbursement on that is little compared to a cardiologist, compared to a dermatologist. And we consider that the most important thing that we have is to have primary care and behavioral health and to be able to bring services to people's homes. If we're talking about equity and you're teaching somebody how to do diabetes, they're not going to get it from that visit. So somebody needs to visit and visit at a constant level. And that is not a reimbursable and things that are difficult to have.
Yeah, a couple thoughts. Clearly, to your point, there's been an underinvestment in primary care. If we look at the trends that are happening in the Commonwealth, the vast majority of primary care physicians are either A, affiliated or owned by a health system, or B, affiliated or owned by a large national payer. And so we don't have the opportunity to control incentives, payments, salaries for primary care physicians from where we sit as a payer here, not being one of those first two entities, but would be supportive of increasing resources and payments to create more capacity for primary care physicians and increasing the supply within medical schools of those clinicians that go down the path of primary care.
I'd say the same thing. And, you know, a lot of this it's all this tension of we're trying to manage the affordability of premiums and getting at the redistribution inside of the system is tricky work. And some of that does have to do with the consolidation. You heard me talk earlier about really we're negotiating at the system level, trying to realign how the economics flow inside of it. But that's something we're thinking about as we look to refresh our approach to value-based contracting. But you're still negotiating that in a private market environment. So you have to have somebody on the other side who wants to participate in figuring that out with you. And sometimes that's there in this market, and sometimes it isn't. But in general, I think your point and the point that Kay made around we need to invest more deeply in primary care, we need to invest more deeply in behavioral health is a point well taken. I will tell you, in the aggregate, we are investing much more deeply in behavioral health. So this is an area where our aggregate spending on behavioral health has increased significantly. We've increased our network. We've nearly doubled our network over the last 3 to 5 years. And our overall spending on behavioral health is significantly higher than it used to be, which kind of runs in contrast with everything else that we're saying around our focus on affordability. But it's a great example of an area where our conclusion was we're not spending enough, where we have an access problem and we're spending more is good.
I'll just summarize, and since we're running late, I think, Tim, you had the right one-word summary for what you recommended that we be doing, and that's innovation. And that seems to be the key to help manage costs. And in addition, each of you seem to support providing more clout to the HBC and that benchmark. And then Audrey brought up some good points, some of the tools that can really help people. And I think that makes a big difference. We've got to just make people aware that that's there. And thank you. Thank you very much.
Thank you all.
Thank you to our panel. And I just want to encourage everyone to get up as needed, stretch your legs, get something to drink, take a break. We'll continue with the witness panels throughout the afternoon, so we aren't planning to take a formal
Drill
break.
down. Yeah, I mean, I asked the question, but I didn't, you know, they give you these multiple
To Commissioner Castile to introduce our next panel.
Hi, everyone. Nobody's listening, you know that. Ooh, she's doing that. Hello, I'm Dr. Matilde Castillo. I'm losing my voice. And I'm also known as Maddie. I am an immigrant from Cuba that came on Peter Pan expeditions to the United States. I had the privilege to go to medical school in San Francisco and became a primary care. I've been in primary care now for almost 35 years. During that time, I have been able to work with mostly underserved, marginalized communities. 15 years ago, opened a treatment facility for Latino men with substance use, which is a huge problem in our community. And most recently, over the last 8 years, I've been Commissioner of Health and Human Services for the city of Worcester and work on such issues as mental health, addiction, reentry from jail, among a lot of topics, and also looking at how we do data in our community to be able to look at what are the inequities that exist in our community itself. This panel in particular is, the purpose of this panel is to convene leaders from a range of healthcare provider organizations to discuss the impact of recent significant changes to the provider market, including the consolidation and closures of provider organizations and hospitals, disruptions in essential service lines such as pediatric and maternity care, and for-profit investment, including the expansion of for-profit primary care. I'd like to just introduce quickly, and you can tell us a little bit more, but first, Chris Andrioli, who's president of Atrius Health, Amy Brewer, who's president and chief executive officer of Sturdy Health, Doug Brown, who is my colleague, president of Community Hospitals and chief administrative officer for UMass Memorial Health, and Dr., I think Shri is how I say it, Shaguteria. Close enough. Yeah. Vice President and Chief Medical Officer of CVS Health. And as I ask your questions, you can say a little bit more if you'd like about yourself. So Massachusetts has undergone a series of transformation in the provider market, including consolidation and closures of provider organizations and hospitals and disruption in essential services, like I talked about it, such as in pediatric and maternity care. What is your perspective on the impact of these changes on the state's broader affordability and, most important, equity goals? How have these changes impacted your organization and communities of color who suffer from inequities in healthcare? And I'm just going to add one more, and I know I wasn't supposed to do this, but when you make these decisions, how are you documenting what the impacts will be on these populations, and how do you remedy these situations? Doug, would you like to start?
That's the privilege of knowing you well, I guess, Maddie. I'd be delighted to. Good afternoon, everyone. It's really an honor to be here. I don't want to say too much about myself, except I do want to say, by way of background, that I have spent about 25 years in the Massachusetts healthcare ecosystem on the public and the private side. And over the last 3 years, I've had the privilege of serving on the American Hospital Association board. And that's given me some insight into how other states do this healthcare thing. I was mentioning it to David earlier, and it has caused to reinforce for me this notion that we have something really good in Massachusetts. And, you know, I've always believed and have seen now starkly that we have enlightened leaders in this state. We have enlightened organizations that largely have a nonprofit ethic, but I think are able to time and again put their interest and their challenges, and we have many, aside for the broader good. And that makes me really proud, and I hope it does you as well, because you've been a key part of that. You know, I think from a hospital perspective, we are in the midst of massive change, and it's a really, really difficult time for hospitals right now, as I'm sure you're aware, and you'll hear from the next panel. But there's a structural reorganization that is taking place, and I don't think we are fully mindful of exactly the changes that are going on, and we're still reeling from what happened in COVID. Technology may be a helpful way out of this. I think that could be a lifeline for us and in our organization. AI, as we speak, is helping our physicians deliver safer, better care. But there's one thing about technology that I worry about and want to raise to your attention, because it really hasn't been addressed today, and that is that if we're not careful, we could be creating a system of haves and have-nots in our healthcare system. And I worry a lot about that because all these disruptors that are coming into our space, and we should encourage it because there's great innovation that's happening, they are all focused on the commercial market and the commercial market share. And they get to come in and have all the benefits without the burdens, without having 24/7 operations that have to stay open, without having incredibly difficult licensing and regulatory requirements to keep up. And if we don't think about how they can share in that burden, what's going to happen is the rest of us, the traditional players who serve most of the low-income communities, when that commercial revenue gets taken, they're going to further get destabilized. And so commercially insured patients are always going to find the way to those innovations, but the rest of the population are going to have real difficulty. And I think it's something that I would urge you to think about. I think we have to be much more nimble, and that includes government. And I just want to mention one final thing in my opening, and that is how we've thought about partnerships to help try to solve this problem. So in central Massachusetts, as you all know, there have been a lot of activity with different things happening. I just want to mention one in particular, and that is our deepening partnership with Harrington Healthcare 2 years ago, because I do think the regulatory environment has a jaundiced view of hospital mergers, right? Certainly the antitrust authorities look very carefully, as they should. But I think in light of what we're going through, we have to, again, think very differently about how we facilitate that. In our case, Harrington was having financial problems. And by the way, if hospitals are having problems, community hospitals are, it's an extraordinarily difficult future. I don't think there's, with all due respect, Amy's doing an incredible job. It's really, really tough. Harrington recognized that ahead of time. They came in to talk to us. The model that we've employed with Harrington is that it's what we call a member substitution. So one of our entities becomes a sole member of their organization. We have certain reserve powers, but we largely keep the organization in place. The board remains the same. They're a fiduciary board. They're from the community. The president is the same. There's virtually no changes in the system, except that we're able to bring to them many of our best practices and investments that we can do. One of those is quality. We have a state-of-the-art quality team that already in the last year has been able to improve their observed to expected mortality by 25% because of our practices. We've brought phenomenal technology. We just implemented the Epic electronic health record a month ago in their system. They never could have done that without us, $40 million system. It's transformed their care and resulted in all sorts of efficiencies. We've brought them access to capital and investment in an ICU. And most importantly, we have allowed care to stay in the community. As you probably know, our academic medical center is completely backed up. We turn away hundreds of patients and transfers because we don't have room. So it's in our strong interest to keep as much care in the community as possible. Since Harrington has come in 2 years ago, their occupancy has gone way up because of the merger. So we think that it is a good model. It is a successful model. Unfortunately, Haywood hasn't quite had the great experience. We're all going to be part of that solution if we can with Haywood, but it creates a much bigger problem for all of us when they get to that point. So I'll stop there. Thank you.
I was just going to say, can you, if you can just tell us the impact of these changes on the states? Well, actually, I take it back. How have these changes impacted your organization and communities of color in particular when you're having these mergers?
So in the case of Harrington, it has one of the lowest median incomes in central Massachusetts, right? So the fact that we were willing to partner with them and invest in them is actually an investment in communities of color, because Southbridge has very low income, has a significant population of communities of color. The other thing we did, Dr. Castile, is in one of the first times that we know of in the country, we built into that partnership agreement anchor commitments. So we are an anchor mission organization. As you know, we about 6 years ago, we reimagined the role that we play in our community, and it forced us to really focus on getting outside our walls to address social disadvantage and pervasive inequality. And so Anchor Mission is about leveraging all of our tools to address the social drivers of health outside of our walls. One of the ways we do so is by using our investment portfolio in a different way. we redirect our investments from stocks and bonds to community investments. And in the past several years, we've now committed $10 million of our investment portfolio. We've made 10 investments across central Massachusetts in affordable housing, in chronic homelessness, in the arts and other things like it. We're organizations that wouldn't otherwise get investment money. In the Southbridge community, as part of the Harrington deal, we've now made 3 such investments that we think are making a big difference in addressing pervasive inequality, building wealth in non-traditional communities, and we'll continue to do that.
Hi, thank you. Amy Brewer from Sturdy Health. Thank you so much for having me here today. I feel like I should start by saying Sturdy is not closing or consolidating. However, let me just make sure anyone from Sturdy. However, we have been impacted in Region 5 by many of the different health systems. We have a hospital in Taunton that stopped delivering babies several years ago. We have the closure of a hospital in Norwood and Brockton. We have, with the Compass transition, several, 100 patients that didn't have primary care. And so what we're seeing is, and actually some of the community stories from this morning, I think we're seeing in our health system every single day. So an overburdened emergency department. We were not ever built to have 50,000 plus visits a year, but we do behavioral health. But I think because the theme today talked about maternity, again, what we're seeing is a huge influx of demand for maternal health. And so the way we've continued to respond, and most recently with the migrant population, who a large influx of pregnant women arrived in Taunton, in a town that does not have labor and delivery. And so we were able to partner very closely with Manat Community Health System that is now in Attleboro, and really make sure that these patients had culturally competent and appropriate care from the beginning. And the first few days were very rocky. The first weekend was very difficult, but really proud of our teams for responding to say, we have to meet the needs of this ever-growing population. We talked about ambulances earlier today. On any given day, we are having ambulances now from Taunton, from Norwood, from Foxborough, from Easton, from Brockton. We're seeing our catchment area grow very quickly because of the changing. And again, the closures in this case were not consolidations, but rather sort of extraordinary circumstances. But regardless, they're really impacting our community health system. And so we've, again, just continued to really focus on, I'm sure we're going to get to the affordability and the financial impact later, but we continue to really focus on how can we keep recruiting primary care? How can we keep growing our maternal and women's health services and our pediatric services to ensure that we keep caring for these patients, that if we don't do it in the outpatient setting, they are going to arrive in our ER. They are arriving in our ER. And, again, that's not the right side of care for many of these.
Thank you. And to just start with an introduction, thank you. I'm Chris Andrioli. I have the privilege and honor to lead as CEO and practice at Atrius Health. We are a primary care-based, multi-specialty, ambulatory provider practice that both our mission and our business model is based on value-based care and delivering the highest quality outcomes, and quality doesn't exist without equity in our model, while simultaneously working on affordability and cost. So we applaud all the work of the Health Policy Commission and CHIA and are honored to be here today. So thank you. To the question around consolidation and closures, I'd say consolidation on its own as an isolated entity is not always bad, similar to some of Doug's comments earlier. In our particular case, we are just passing our 1-year anniversary of joining Optum, and that has allowed us to stabilize, invest in long-term plan around our mission of value-based care. It's helped us double and triple down our investments in people and resources and technology, and focus on the goals that we think are important, serving the Commonwealth of Massachusetts. What we do see as concerning in the Massachusetts marketplace now is the combination of the consolidation that's been described to the largest, most expensive healthcare hospital-based systems simultaneously with all the community-based closures that are happening, hospitals, provider groups, programmatic closures. The combination of the two is driving up care and is threatening the ability to deliver on equitable care. and provide access to all of our communities, and that does concern us.
And I think that is part of my question is just how does that, we talk about equity and then we're consolidating and leaves all the outskirts of the people that can't access the hospitals that they were going to. Now, how do they get there? And one is definitely taking ambulances, but they're no longer feeling comfortable. They're going to wait longer for whatever treatment it is because it's much further down the line. And so on one end, we talk about equity, and on the other end, we're harming that piece.
Yeah, I mean, from our end, we're on the ambulatory side, so I'll leave the hospital comments to some of my colleagues here. We're trying to expand into those communities that have been affected. We're trying to bring our model of population health to them. We believe that our model, we believe passionately that primary care is the way to help with the burden that the community hospitals and all hospitals are facing by keeping people out of the hospital. So the more that we can collectively, and whether it's our model or other models in primary care in those communities, is something we're certainly committed to.
Hello, my name is Shri Jagaturu. It's really a pleasure to be here. I come here as a representative of CVS Health, as the Chief Medical Officer for the enterprise, but also as a practicing internal medicine physician here in the Commonwealth for nearly 20 years. And so I wanted to just briefly start with explaining CVS Health and who we are. You can think of us as a number of different companies: health benefits with Aetna, pharmacy benefits with Caremark, pharmacy services with CVS Pharmacy. We are now continuing to deliver healthcare services through Minute Clinic, which we'll talk a little bit about, as well as our recent acquisitions of Oak Street Health, which is a senior-focused primary care group, as well as Signify Health, which provides in-home health services. We have 15,000 employees here in the Commonwealth, 1,500 pharmacists, 200 nurse practitioners here in the Commonwealth. We have 400 retail locations here, 55 Minute Clinic locations, and 100% of the Commonwealth lives within a few miles of a CVS pharmacy. And so when we think about these issues of closures and equity, we really do think that this infrastructure is uniquely positioned to help support and transition during these. And so I just want to bring that a little bit to life. When we think about the quintuple aim of cost, quality, access, well-being, and equity, underlying that is just our fundamental desire to improve health outcomes. And if we want to improve health outcomes, I'd put forth that that's a pretty simple formula of engagement and trust. We need to be able to engage with the healthcare system. We need to trust those providers and institutions, but that's a very hard thing to actually execute on. But through CVS Health, we've continued to do that. I would put forth examples of that are the fact that our locations are conveniently located, so that engagement is very easy to do. In addition, our providers, our pharmacists, that pharmacy is one of the most frequent interactions we have in healthcare. It's a community-based interaction, and that multiple interactions creates trust in being able to provide healthcare services in the community. I think that's no more evident in what we did during the pandemic. We had 6 million vaccines that were delivered here in the Commonwealth. 30% of all vaccines were delivered by CVS Pharmacy in the community. When it comes to equity, and we've published this in New England Journal Catalyst and as well as Health Affairs, peer-reviewed literature, where we demonstrated that we used social vulnerability index and analytics to make sure that we were driving vaccine uptake in communities of need. And we were indexing nearly 10% higher than benchmark in terms of delivering vaccines to communities of color. And that's a demonstration of the fact that having community access points of pharmacy can help drive equity and improve equity. I would also put forth that Paxlovid prescribing, having pharmacists in the community being able to provide Paxlovid prescribing, was able to create that community access point instead of having to go into a downtown facility to be able to have that access in the community. Minute Clinic has also evolved substantially in terms of the number of services that we provide. We initially were acute services, but we've now expanded to over 125 clinical services that range acute, primary care services such as acute care, prevention, and chronic disease management. And why does this matter is when we've been approached by health plans when there have been closures of can Minute Clinic provide a stopgap until we can place those patients into other institutions, into other health systems. And so we've been able to be at the ready because our complement of services mirror primary care. We're not there to own a primary care relationship, but to support primary care. And that comes to life in a patient story where we had a patient who was discharged from a hospital for a cardiac event for heart failure 4 weeks before they could come in to be able to see their primary care physician. But they came into the Minute Clinic, were able to get their medications reconciled, to get their titration of their diuretics, and to continue to manage their weight until they were able to get back in to see their PCP. We have a similar example that I recently heard of a patient, a diabetic patient, who had an 8-month wait to see their endocrinologist, didn't understand how to use their continuous glucose monitor, was seeing a virtual care provider at Minute Clinic who said, we need to see you in clinic. We transitioned them into the clinic and we're able to then help with just a brief intervention, teach them about how to use that CGM, and then make sure that they could manage their diabetes until they could finally get in to see that endocrinologist. And so hopefully I brought to life to you both with an explanation of CVS Health, but these examples of how we're in the community helping to support equity and can also help support in these closure moments.
I just want to ask if any of the commissioners have any questions.
I do. I have a couple of questions. Thank you so much for your remarks. My first question is for Dr. Shri from CVS Health. So I live in the neighborhood of Hyde Park, which is a part of Boston, a majority Black and Latinx community in Boston. And just about a year ago, I went to my neighborhood Walgreens. I know you're not Walgreens, but just for an example of a storefront pharmacy, I went to my neighborhood Walgreens and it was closed. It was permanently closed. I had no idea, no warning. And so naturally, I opened up my phone and Googled what happened to Walgreens, and I learned that the Walgreens in Hyde Park, Mattapan, and Roxbury had closed last year. And city councilors were responding, demanding that Walgreens, reopen or at least promise not to open up new stores in wealthier communities, right? So my question for you is, how is CVS putting strategies in place to prevent the closure of storefront pharmacies in communities across the country, especially given the importance of their role in providing vaccinations for COVID-19, and especially given the evidence that urgent care clinics are more likely to locate in sort of wealthier suburbs or areas with more generously insured populations?
As you can imagine, I can't comment on other pharmacy chain strategies, but what I can do is talk to you about sort of what we see from a health policy perspective, and then specifically CVS Health strategy. Fundamentally, in this country, we have too many pharmacies. There's many corners that you go to that you can see multiple pharmacies on the same corner. However, we also know that there's pharmacy deserts. There are places in America, many places, unfortunately, those that are hardest hit with social vulnerability that do not have access to pharmacy. So we have a problem of both too many and not enough in the locations that are needed. Mm-hmm. And so when we look at store closures at CVS Health, we look at first and foremost the social vulnerability of that community and take that into account. So even if we would never want to create a pharmacy desert in the way that you're describing, and when we make those decisions of closures. Unfortunately, there are times where we do make those closures. We recently announced that we were going to be closing 900 pharmacies across the country, but the first and foremost analytic is social vulnerability, and will this create a pharmacy desert? And if that's the case, then we really will not close that pharmacy. I think the other thing is that in addition to closure is the hours that they're open, and we are committed to opening nights and weekends. We know that pharmacy, if you're discharged from an emergency room, you need those acute care medications to prevent a rehospitalization. And we continue to invest in labor and hours and technology. And I know we'll get into that later, so I won't go through all those investments on workforce, but the importance of having pharmacies open at nights and weekends as well as during the daytime is really important. So we're not just going to be open during convenient hours. We want to make sure that this is a convenient access point for communities at all hours of need.
Great.
I just want to add that I agree with what you're saying, Dr. McGregor, that for us in Worcester, one of the main location of a CVS that I can tell you there are numerous people who are marginalized, who that was their one access to be able to get their meds filled, closed. And so when we talk about equity, for us in our community, we just lost that. I can't tell you how many complaints come to the city that they aren't able to do that. I have patients who are on Suboxone, for example, and not a whole lot of pharmacies will give you Suboxone. So you have to form that relationship before they do that, and they had formed that relationship there. And then they're gonna go to someplace else, and it's a process, and the doc has to verify, yes, every single time. And so it's been a harm to the community just from that. So just something to look at the neighborhoods that are impacted when you close.
So I'm going to pile on Sri because it's too much fun to avoid doing. So the issue of pharmaceuticals has come up several times today and in past sessions, and about the only industry hated more than the pharmaceutical companies is the PBM industry. And so CVS has Caremark. So I want to ask you about that. There's, as you know, a general lack of transparency associated with the PBM industry. There was an article that came out recently in which you said there's a need for more transparency in the way PBMs operate. So I want to ask you two questions about that. The first is, would CVS Caremark share with, for example, CHIA, information on its operations, including the CVS part, the Caremark part, and Zinc, the GPO part? And second is, would you support legislation in Massachusetts that would require PBMs to open up their books to, let's say, CHIA, to so that we know and we can tell everyone what's across all parts, not just the Caremark part, but everything involved with with CVS that's related to the PBM part.
Yep. No, thank you for the question. So I would, when we think about pharmacy benefit managers, they're the only part of the pharmaceutical distribution chain that's focused on lowering drug pricing. There's no other counterparty to pharma, which continues to raise their prices year on year. And therefore, as we heard in the previous testimony, we have that accelerated growth in pharmaceutical costs. That said, we are very supportive. There are many legislative proposals in Massachusetts that we're supportive of, all of them in terms of transparency, in terms of PBM and submission of that data to the Health Policy Commission and CHIA. And so we're very much supportive of that in terms of helping to support the management of drug costs in the Commonwealth.
Doug, I was very interested in the $10 million in grants that you issued. And I was wondering, were they in a small enough geographic area where you could start measuring results from a health equity standpoint?
It's a great question. Thank you for it. First of all, let me just make clear, these aren't grants. So grants have always been a traditional part of hospitals' community benefit programs. They're important. They'll continue. These aren't to replace grants. These are in addition to grants. These are investments, because our belief is that grants alone will not change the world. What we need is to invest in those areas that have been historically discriminated against, and there's been redlining that hasn't received investment in the past as it should. And so we go into the most vulnerable areas and find opportunities. Typically, they are low interest loans for short periods of time where community development corporations are working with partners and trying to line up, their long-term financing, but they can't get commercial banks to give them money because it's too speculative. We come in and really help the project get going. So that's just a background. It's a great question about, is it concentrated? In our case, we really had to balance how we look at the needs of central Massachusetts, which is really the area we cover, with this desire to want to try to pick a concentrated area. To your point, it is hard to measure. These aren't short-term measurements. It's going to take a while before these things make a difference. So right now they are spread out, but we've thought a lot within Worcester, as Dr. Castile knows, because she's been helpful in us thinking about it, is there a particular zone where we can try to bring a whole bunch of resources? And in the area we're thinking about, it's between Main South and downtown. Again, an area that traditionally has not had investment, and we've been doing some things there to try to prove it. But the ultimate nirvana will be when we can move the dot. The ultimate dot in our view is the disparity between life expectancy in different neighborhoods. In Worcester, 2 miles is 11 years, and that plays out all across the country. And so if we can bring more resources to that area that has a 73-year life expectancy instead of a 74, we think over time, particularly if we can get other like-minded organizations to join us, we'll close that gap. And that's really, in the end, what we're after. Sure.
I have a question for Chris, and it's a workforce question. And the workforce that I'm worried about is primary care. The organization that I work for just did a community health needs assessment. We do them every 3 years. And for the first time, the lack of primary care came up as a major health need. People telling us that large practices are closed to new patients. Community health center telling us that they're closed to adult patients, and that's the safety net. And we know that primary care residencies are falling short in terms of filling slots. What's the solution here? Because if that primary care physician is the place where care starts and where a lot of preventable care starts, I'm worried that we have a population that really has no access to basic care. And I appreciate nurse practitioners and physician assistants, but where's primary care going? And what's the solution? And what's Atrius' plan?
Simple question, the solution to primary care. So it's my primary concern too. It's what keeps us all up at night. It's what we spend our time focusing on. Our biggest risk, threat, issue to our company, but I think more broadly to healthcare across the Commonwealth, is the lack of enough primary care. There are not enough primary care doctors, providers. Coupled with the amount of work and volume coming in to all physicians, but in particular primary care, has exponentially increased. The number of messages coming in through the portal just during the period of the pandemic went up 300%. The number we talked earlier today at other panels, the number of prior authorizations, the number of labs, the amount of data coming in, the work for the same number of patients and the same number of primary care doctors have exploded. And the ability to support the doctor with a team has eroded. The workforce crisis that we're in Massachusetts right now, to be able to hire and retain medical assistants and nurses in the team is an equal problem. And the two together have created this spiral that's leading to sort of unmatched levels of burnout in our primary care workforce across the country. That leads to early retirements, people leaving clinical medicine. So we're hiring primary care doctors, primary care providers as fast as we can, and have just come out of a period of 5 years of attriting down, not on purpose, but just because we couldn't keep up with the number of people leaving, and there wasn't enough people to hire in to replace them. So we've turned that tide a little bit at Atrius. We've started to grow for the first time. And we've made many, many investments around it. So I think part of the answer is what you hinted at. It's a team-based approach to care. I don't think there are enough MDs in primary care in the country to do the old model of one doctor, one patient. So we're investing in a model of one-to-one APC to MD teaming or to PCP teaming. We're surrounding that team with a local team of nurses and medical assistants and medical secretaries. As a system, we surround them with remote case managers and population health workers and clinical pharmacists and data analytics and investments in technology. We're investing heavily in behavioral health, integrated, embedded behavioral health in the primary care team. We think we could really only handle this explosion of work through an investment in the team. And it's hard to hire the team. We have many, many open jobs. We heard again in an earlier panel the number of open positions across BILH. It's the same at Atrius. We're hiring and investing in salaries and in supports to make these jobs desirable for the future. I think that team-based approach is the only way, using technologies, using partnerships, that we're going to be able to handle primary care going forward. So that's what we're committed to.
If I may add, Vice Chair. So when we look at, again, from a health policy perspective, the workforce levels, what we see is, as you point out, primary care shortages for primary care MDs. Yet we see a real opportunity with nurse practitioners with actually hundreds of thousands of what from supply demand might be oversupply of nurse practitioners. So there's a real opportunity when we think about allied health professionals in advancing their role and being able to provide primary care services and primary care. Just in terms of history, when we entered with Minute Clinic into Massachusetts in, I think it was 2006, we weren't allowed to have exam tables because there was an assumption that nurse practitioners could not provide these services. And it wasn't until 2009. There was a separate phone line that was set up that was for patients to call in if they had any complaints on the services. And to my understanding, the calls that were coming in were, why couldn't we get more services? And therefore, we did not get full scope of practice in this state until in 2021, I believe, for nurse practitioners. So I think, we have a real opportunity knowing that there's this vibrant nurse practitioner workforce to support and value them and put them in control of or supporting primary care, not only in team-based care, but also in providing that individualized scope of practice. So at CVS Health, with pharmacists as a large employer, pharmacists in their expanded role, nurse practitioners expanding their role, we really think that there is an opportunity for us to be able to solve the primary care crisis, but we need to make sure that scope of practice is continued to be pushed and supported.
I would echo that. We were very supportive and very happy when finally nurse practitioners got full scope of care. We would advocate as policy measures, extending that to physician assistants. We work with them in many of our practices as well, but up and down the whole chain of team-based care, expanding the scope of practice and recognizing as billing providers, clinical pharmacists, removing any barriers to scope of practice, keeping people at top of scope of practice in nursing, engaging in the nursing compact so that those folks can do their work across state lines. I think there are policy interventions that can support what Shri is discussing.
So I want to ask one specific question to Chris and then one question to Amy and Doug. The specific question to Chris is about the Optum merger. Optum is known nationally for a lot of upcoding, for finding additional complications of patients so you can get paid more. So the question is, in a year or two, when we get the data from the APCD, are we going to find an increase in coding severity for Atrius patients? So, and then I'll give the question and let you think about it. Well, I'll give the other question. And then for Amy and Doug, so maybe they can think about it. We of course have received a notice of material change for the Beth Israel Dana-Farber. And so my question is, from where you sit at your institutions, do you sense any impact either on your patients or on your institutions should that go through? Either good or bad. I'm not trying to presage anything, but what does that impact you in any way?
Yeah, so the first question on coding risk adjustment, I think is likely the type of coding you're referring to. Atrius is fortunate to have most of our revenue tied to value-based care models that are global payments. We prefer that style of care. We're able to take the global payments and reinvest them in our practice, and we have, and we will continue to. we believe it's a better style of care than E&M, fee-for-service billing. Both sets of coding have their own challenges, potentials for abuses or difficulties. I think as you look at the data, what you'll likely find for Atrius is that we were dramatically behind in our average level of risk adjustment coding compared to any network that we were in. It's an area that we focused on, and we were getting underpaid for the work we're doing. Our population appeared significantly healthier than every other cohort in Massachusetts, which is likely not true. And so I think you will likely find us regress to the mean or improve to the mean, or however you want to describe it, to get adequately paid for the complexity of the patients that we care for, so that we're able to take that money and invest it in our patients. I don't think you will ever find anything inappropriate or upcoding or overcoding. And all the work we do is tying our revenue directly to the investments we make back in the practice. On the question of Dana-Farber, we're partners with both. A lot of our both BILH, parts of MGB, parts of BILH. So I'm sure the answer will be yes. It'll impact us in some way, shape, or form. We're interested in what will happen and how. We're system-wide partners with many of the hospitals in the BILH network. Dana-Farber joining that network can provide positives in many ways around coordination of care for our patients. And all the systems that we're talking about are at a very expensive price point, and we work together with our practice, our oncology offerings that we have, and our partners at BILH and MGB to try and keep cancer care in local community hospitals in our practices when we can, in our infusion centers when we can, and then partner with the world's greatest hospitals when our patients need them.
So I think we're not fully sure the impact yet, but we do partner. We have a joint venture with Brigham and Women's for our Radiation Oncology Center in Mansfield. And we also have partnerships with many of the academic medical centers for some subspecialty and quaternary level service lines. And so we anticipate continuing to do that. Sturdy also has a wonderful cancer center where we really focus on keeping the majority of a patient's care local. We hear from our patients all the time. I drove up this morning. It is difficult and it is not fun to have to drive into Boston. And if you are getting, chemotherapy, or if you're getting, radiation, we have to go in daily, or chemotherapy, we're going in weekly. We want to be able to keep that care local. And so what we're going to continue to work on is partnering with Beth Israel and Dana-Farber and MGB on what are the services that need to be done in Boston or at an academic medical center, and what are all the ones that can be kept at Sturdy and at the community. So that will continue to be our focus. And I think, one of the things that I worry about that the panelists talked about is, all of this begins with workforce. And I think it just can't be underscored enough, in case we run out of time, that, whatever we can keep doing collectively to focus on attracting more people to healthcare. You just talked about, primary care. What can we do for additional loan forgiveness? How can we get more people into primary care? How do we reduce the administrative burdens? All of those things. It's the same, 5,000 nursing positions of the 20,000 openings. I mean, these are real numbers. I would also support the nurse license compact participation. And so I think for me, as you have more entrants into the healthcare, how do we make sure we're not just creating more issues of beds unstaffed and all of that?
Very similar answer from me. We have a very strong relationship with Dana-Farber. We value it greatly. We don't expect it will change in any negative way as a result of this. We hope there might be opportunities for further strengthening it. As you know, Commissioner Cutler, that we are in negotiations with Milford Hospital. They have a relationship with Brigham, and Dana has a facility across the street. We've made very clear to them. We honor that. To Amy's point, it's really been a very valuable relationship to keep care local. We are agnostic as to which partner they'll be there. Brigham and BI are both great institutions, so we don't see any material change at this point.
Hi. Dr. McGregor.
Oh, sure. Hi, I have another question about closure, but this is a question for Doug Brown from UMass Memorial. So you spoke a bit about some of the merger relationships and investments that UMass is making, but the closure of the maternity ward at the Leominster Hospital was really big news this fall. You know, that closure was completed at the end of September. And it also occurred around the same time that, you know, the announcements of your merger with Milford was also made news. So I just wonder two questions. First, how is UMass Memorial evaluating the impacts of this maternity ward closure on the local population in terms of access, outcomes, and equity? And two, what were the factors that went into the decision-making process to close one maternity ward in one area while also seeking to merge with another hospital in another area? What factors go into that?
Great. Thank you for the question. I should mention that we were also in conversations with Haywood Healthcare. We all know about their financial issues, as I mentioned earlier. Closing the maternity ward at Health Alliance was one of the most difficult decisions we've made. And as I'm sure you can imagine, anyone in a hospital never approaches closing any service lightly or easily, especially a service like obstetrics. Just to give you a little bit of background, 5 years ago, we had a serious patient safety event in that unit. We had a maternal death, which is something you never want to have, as you can imagine. And we asked our chair of OBGYN at our academic medical center to get deeply involved in helping us assess whether we could keep the unit going or whether we'd have to close it at the time. We made a determination on her good advice that we wanted to sustain the unit. And so over the past 5 years under her leadership, we did a number of changes. We made substantial investments in the facility. We brought in new equipment. She installed team-based training in the unit to really bring the teams together, among a number of other initiatives. We actually were making some progress, and we started to stabilize the volume. There's been a steady decline in volume. We were delivering over 1,000 patients 6 or 7 years ago, and when we closed, it was well under 500. Then COVID hit, and it changed everything. And like everybody else in healthcare, we focused on saving lives. It really sucked all the resources of our system. Coming out of COVID, as you've heard today, we had extraordinary workforce challenges. It began with nursing. We had significant problems staffing the unit. We approached the M&A to see if some of the labor nurses would be willing to cover in delivery and vice versa. They were not willing to do that. We approached the Department of Public Health and we said, we cannot sufficiently staff the unit. Can we get some flexibility in some of your requirements and maybe go on diversion from time to time if we need to? They said, absolutely not. You either have to completely meet our criteria or you have to close. We then had a problem with physicians. We've gone from 10 OBGYNs to 2 when we closed. And we ultimately made a decision that we could no longer safely keep that unit open. And that's really what the decision was. It was not a financial decision. It was a clinical decision. And just to focus on equity, because it appropriately is, the theme of the day, we believe it was the right decision from an equity standpoint as well, because why should communities of color in that community not have access to what we consider to be a world-class OB center 30 minutes away at the medical center? Already the high-risk patients were going to the medical center. A third of the community was already voting with their feet and choosing to deliver in the medical center. We kept all of the prenatal care in that community. We kept all of the postpartum care in that community by the providers. The only thing that was changing was the deliveries, and we believed it was safer and more appropriate for birthing patients to do their deliveries at our academic medical center. Much higher volume, much more resources. And the last thing we'd say is transportation was a great concern to us for the reasons that you've mentioned. So we have put in the first of its kind that we know in the state. We have guaranteed non-emergent transportation to all birthing patients in the community through a service called GoGo. It is kind of like Uber. It's an on-demand service. We actually went into the family medicine and OBGYN practices to work with them and their patients, identify those who would have the greatest needs. We sign them up for this service. And so anytime they have the ability to make a phone call and get delivered to the medical center or someone else if they need to. Now, in the month and a half or so since we've closed, 3 people have used the service. I think it's gone well for those people who have used it. We've tried to make it widely available, but there doesn't appear to be a compelling need at this point for non-emergent transportation. And of course, as you alluded to earlier, anyone in an emergency should continue to call 911. And that's what happens at all of our other hospitals that don't have OB. Our ED docs are fully trained, and they're prepared to deal with situations in the unusual event that something like that happens. So sorry for going on so long, but obviously we've been thinking a lot about this. I don't want to understate how significant this is to the community. It's a very big deal, but we tried our best to accommodate as much as we can, and we were convinced from a clinical situation it was the absolute right thing to do.
And at this point, are you tracking, say, admissions through the ED for folks who are in labor? Are you tracking things like complexity of patients and how the patient mix is changing?
Yes. In fact, it's all publicly available because the Department of Public Health, in their monitoring efforts, has asked to track it. So we're submitting weekly information to them at their request on, who's showing up and all the questions that you've asked about. So we're trying to track that closely. And of course, we're very mindful of Haywood, right? Because they have an OB unit and they are in bankruptcy, and that would truly be devastating to the region. So we hope to be part of a larger solution. I know the governor has initiated a task force to look at care in the whole region, and there really has to be, I think, a larger planning effort in that region, and we're eager to help out in thinking that through. It's a big issue, as you know. You've studied it, better than anyone. It's an issue across the country. We read daily about units that are closing, but we have to figure it out. And in this situation, we've done what we think is the best balancing of the interests.
Before we turn to some of our final questions on this panel, we started a little bit late, so we can go a few minutes long. But I do want to ask a question of Amy. In 2016, the Health Policy Commission issued a report called Community Hospitals at a Crossroads, and it documented the real value that community hospitals play in their communities, high value care at a lower price, often treating a greater proportion of high public payer patients. But the report also talked about some of the market dynamics that inherently disadvantage community hospitals, and especially independent community hospitals. That report was 7 years ago. I don't know what words I would use to say where community hospitals are today, but I want to give you an opportunity to just share a little bit about what it is running an independent community hospital. What are those operational challenges? And then you mentioned workforce, but I wonder if there are any other policy solutions that you would recommend that the state consider in being able to support the continued provision of community care.
Sure. Well, I think I can start more globally that we're not alone. The financial pressures on the healthcare systems cannot be understated. We've not recovered from the pandemic, and Sturdy is part of that group that is not recovered yet. We will post an operating loss. We will be lucky to climb out of it as a system to a positive one next year. We still see, we've talked pharmaceuticals. I think it's important to give context, like why is our cost up or why is our expenses up? Pharmaceuticals are up 19%. We spent 400% more on contract labor and travelers in 2022. That's down in 2023, but not anywhere near what it was pre-pandemic. Our malpractice is up 20%, and that's across the board. So I think the workforce constraints, the open positions that we all have, the inflation concerns, the capacity issues are all major headwinds that sturdy independent health system, community-based, but I think many others are still facing. And so, I guess it's like, we have to focus on workforce. I've already mentioned that. I think nurse licensing compact, I think continue to I very much focus on the administrative burdens and the prior authorization. I mean, those are real, and again, to put numbers to that. And actually, I appreciate that Blue Cross is starting to at least eliminate the prior auth for the home care. I think because when patients stuck in our hospital, I just had somebody I was rounding on last week, and this woman was ready to go to acute rehab, and it took us 4 days to get the proper approvals to get her out, and then the bed was gone. And she wanted to get back to the Cape, again, back to this, we have quite the reach now. She wanted to get back to the Cape. We wanted her to go back to the Cape in her home because we have patients in our ED that need that bed. And so I think, again, it's all of these things that really create expense and waste, and it is not patient-centric as well. So for me, it is, again, let's chip away at workforce, right? We're doing all of the things to recruit and retain. We're doing all the things to partner with schools to encourage at the elementary and high school level, and certainly at the college level to continue to grow the workforce. But I think, to also answer your question about where are community health centers or community health systems 7 years later, I don't know that we're actually categorically any worse than other health systems when you look at data. Dr. Cutler could probably correct me on that, but I think we're all about in line. It's a matter of how do we make sure we can keep investing in our health system. So where I think some health systems get into trouble is when they can't make the capital investments, when they can't access capital in different ways to ensure that their facilities stay where they need to stay open, so that you don't have a catastrophic failure and then you are having to close a hospital or a service line. And at this point for Sturdy, we're very fortunate to be able to keep making that capital investment and continue to be really committed to our community. Oh, does that mean we're
Right
done?
on time. That was amazing. Right on cue. My name is Tim Foley. I'm the healthcare workforce representative, so I definitely appreciate the little final comments about the need to focus on the workforce issues, and hopefully we can get in that to the next panel as well. But in closing, I just think one of the things that I took away from this conversation about the impact of consolidation and changes and mergers and acquisitions and all the like is that we're a system. Everything's connected to everyone else. So there's a business decision made or a healthcare decision made by folks in this panel or people not represented in this panel impacts everybody, not just the individual folks involved in that transaction. It impacts consumers, the workforce, the hospital employees, everyone involved. And that if we don't, when we're looking at these things, if we don't do it properly and effectively, we're going to perpetuate the inequities in our system now, and that we have to keep that front and center as we're thinking about these impacts, that we're a system and we can either use these changes to improve that system for outcomes through a health equity lens, or we're going to bake in the inequities that currently exist. And so I think that's why as a health policy commission, we came up with the recommendation that I don't have much time for you to speak to it all, but just if this is something that you would support, is that we are recommended that the state needs to update the oversight of the healthcare market, including focus assessments of need and supply, and greater scrutiny of for-profit and private equity investments in healthcare in the Commonwealth. And so I guess I would ask in your final thoughts, because we're over time, is this a recommendation that you would support?
Yes, I said earlier about private equity and for-profit. So with all due respect to my colleagues in that space, absolutely. And, we've always been subject to scrutiny. We should be. Absolutely. My only final comment is, in addition to the scrutiny and looking at things from a traditional regulatory lens, which you are required to do, you have to be nimble and you have to be innovative. Government has to change like we do, and you have to start thinking about how you can enable and empower the dramatic changes that are going to happen in healthcare. We're changing faster than the regulations can keep up. And I just urge you to think about innovating yourself, as you've done, but we all need to do more. Thanks.
Thank you.
So I believe that the Health Policy Commission's focus currently is correct, a focus on transactions and activities with the lens of market size, market power, with a focus on cost of care, affordability is the right place to focus. I don't believe that adding additional triggers for corporate structure or tax structure are necessary. I think understanding who the players are, what their history is, what they're proposing doing, what their future goals and commitments are the important features rather than corporate structure or tax structure. Thank you.
Yeah, I would agree with Dr. Andreoli. For-profit versus not-for-profit's a tax status, to state the obvious. But I think the intentions of the acquisition are the key points to be overseen. And so if you look at a private equity firm that is buying to create out of network or to drive fee-for-service revenue, that's a concern. If you're looking at a for-profit entity that's looking to invest deeper into value-based care to help support and invest in primary care, that's a completely different intention. And if we see a health system that's acquiring providers to drive downstream referrals, but not to invest in that primary care group, that's an issue. And so I think it's more about the intent of the acquisition as opposed to doing it just on tax status.
I would also support the oversight. I think it's important that there's sort of the same playing fields and same scrutiny and oversight to all different public, nonprofit, public, and profit.
Thank you all for your time and testimony today. Appreciate it.
Thank you.
Thank you. Thank you so much. And I'd like to welcome our next panel and the participants and ask you to come forward. Hi, Chris.
Hey, how are you? Good to see you.
Welcome to our panelists, and we'll get started in a moment after our general counsel has sworn them in.
This 10 times, so, yeah.
Give us X amount of service.
Yeah.
He's
coming.
Yeah.
Great.
I mean, because they're doing tuition reimbursement after that, but if they get somebody when they're younger, they can sort of also recruit more from a diversity.
Yes.
Welcome. Welcome to each of our panelists, and I will serve as moderator for our session. Appreciate your time and your leadership in providing input to the Health Policy Commission. And we have with us Michael Curry, who's the president and CEO of the Mass League of Community Health Centers, and also is the co-founder of the Health Equity Compact. Michael Dandorf, who is the president and CEO of Tufts Medicine. Christine Schuster, who's the president and CEO of Emerson Health, and who also chairs the Massachusetts Health and Hospital Association Board of Trustees, and Dr. Kevin Tabb, who's the president and CEO of Beth Israel Lahey Health. We appreciate your attendance at this panel because it's important for us to have key leaders in the healthcare system who are making decisions and managing both current and future provisions of care in the Commonwealth. We've heard a great deal today and previously about the challenges that you're facing around workforce, access, general inflationary pressures. We could not be more respectful or aware of those challenges while also trying to advance health equity. So we enter this discussion with that as our context. Our view, and I know that you share this, is that doesn't mean we can give up on affordability, both because it does create access and equity challenges, and also because of the toll that it's taking on the employers and patients in the Commonwealth. So our focus for this panel, really, I'll ask you to focus in two ways on cost control, affordability, and equity. The first is, what can you do? What do you see as the future focus in your leadership position? And secondly, what can we do? So what can the Health Policy Commission and the Commonwealth do to complement and promote the necessary focus around affordability and equity? So let me start by asking each panelist to provide testimony concerning what you feel your organization, both, speaking on behalf of the organization you lead and the organizations that you're part of, Chris and Michael, and your roles at MHA and at the Health Equity Compact. What do you see as ways that you can address affordability and equity going forward? And Michael, can I ask to start with you?
Thank you, Deb. It is good to see you as always, and thank you to the other commissioners. I want to say thank you also to David Seltz, my friend, and his phenomenal staff, and particularly say thank you for centering equity. This goes back to a conversation David and I had during the pandemic about the role of HPC and the role of the Commonwealth in addressing equity issues. So I am excited to see the progress that's been made there. I want to echo what Amy said, Amy Rosenthal said today, as I look at across the increased diversity in this commission, and say it's great to see that diversity here today. And then maybe one other additional point before I chime in on your question is I want to say thank you to the 83 members of the Health Equity Compact, an amazing group of leaders across healthcare, health, philanthropy, business that have come together to really push the state and push ourselves forward to address health equity. We have a mantra that we live by in this work so far, which is if not us, then who? And if not now, then when? We have an opportunity in this moment to really address some of these key issues. From a community health center perspective, I think we've been very fortunate to be born out of a mission to address these issues. This was always about affordability. Those who know Jack Geiger, Count Gibson, Dr. Hatch, it was never just about care. It was always about how do we get you a job? How do we get you housing? How do we get you an education? How do we make sure you have a seat at the table? And then how do we address the disparities that we're seeing play out, whether it was Mount Bayou, Mississippi, where the second health center was born, or Columbia Point in Dorchester. So we've been on the front lines of doing that work without the resources, as you've heard from the health center testimony today. We do often that work without reimbursement. Some of that work around language access and cooking classes and nutrition classes, and much of that other work that we do beyond the core care has been under reimbursed or not reimbursed at all. We had a historic win under the Baker administration to renegotiate our rates, which we call our PPS rates, federally mandated. Under the Baker administration, it boosted our opportunity to really lean in with the communities that we have. They are the ones who are dealing with these financial concerns that we talk about, the affordability issues. They're the ones that have the higher rates of morbidity and mortality. They're the ones who have the transportation issues and all these other issues that have been coming up, especially on the first panel today. But that's come many years too late. And the reality is we're still trying to catch up with the deficit that created within health centers. The commercial side, I think this was Dr. Castille's point earlier to the earlier panel. Commercial reimbursement has been under reimbursed. So therefore, health centers still are not getting paid for the cost of care that we provide. So I love hearing in the testimony, more investment in primary care, more investment in BH, more focus on social determinants of health. We want to see that play out in terms of reimbursement. The work that we health centers do, we're continuing to do, but we need the support to do it.
Thank you.
Thank you, and thanks for the invitation to testify today and participate in a discussion around really advancing healthcare in and across Massachusetts. I'm proud to represent Tufts Medicine, especially given our position in the market and really being known for being a high-quality, low-cost provider. And I think the data, sort of proves that out in terms of our historic ability to think about how do we keep care local. How do we think about utilization, and how do we keep costs down? Some of that because of disparities in the way that we get paid, and others because of the way that we've positioned our physicians to really think about important utilization issues. I do want to applaud you all for holding this session, applaud the legislature, and for all the things that they've done. And I think we're at a really important moment in healthcare. We went through probably the most challenging time in any of our careers, and certainly in any provider's career, in COVID. And then that followed quickly with a staffing shortage and the great resignation that maybe happened around the country, but in healthcare was seismic. And we had a burnout issue before COVID, and that just exacerbated those issues. And we know that for a fact, and all the data is out there in terms of those issues. But I think it's also an important moment for us as leaders overall across the system, across the entire ecosystem. Leaders from a legislature perspective, from an executive perspective, your role as leaders, as commissioners of the Health Policy Commission, our role as leaders as providers, leaders as insurers, leaders in pharma, leaders at PBMs, you name it. Look, think about the whole ecosystem, that it's an important moment for us to come together around these two issues, affordability and equity. They're intertwined for sure, and they're incredibly, incredibly important to the future of the healthcare system and the sustainability of the healthcare system for us to survive and serve the communities that we're serving in a way that would allow us to get the great quality outcomes that Massachusetts is known for, but those communities really need and deserve. I'd say in terms of the things that we can do is to make sure that we're at the table and make sure that we're positioning, particularly our primary care physicians, and we can talk about this more, as the discussion goes on, but positioning our primary care physicians to think about how can they better manage the total costs of care. An incredibly important point, not just can we operate under a fixed fee-for-service environment, but really lean into value-based care. And it's certainly something that we're committed to from a Tufts Medicine point of view. We don't think fee-for-service is sustainable. We think we're going to need to think about global payments, fixed budgets in a way that allow us to think about how do we make the best use of that premium dollar. That's going to require a partnership with the insurance companies. And I think the other part of your question, what could you do? I think you need to compel all of us as leaders across every segment of the ecosystem to work together differently, not to point solve one by one issues. We have seismic workforce issues, right? They're not going to be solved by us alone. We have a role in redesigning work and thinking about innovation and using technology and changing roles, but there are regulatory issues that stand in our way of doing that in terms of TAPA license and the things that were talked about earlier. There are insurers that need to change the administrative burdens that are placed on providers and add to the burnout issues that exist. So it is multifaceted and very complex. I think this falls into the category that's defined as a wicked problem. It's beyond complex. And if we just try to solve one piece of that, we're just going to create other problems across the ecosystem. And it's not only from an affordability perspective, we can say the same thing from a health equity point of view, right? We have a deep responsibility to make sure that we're serving the diverse communities that we're serving. And we're very proud of that in terms of the work that we've been doing across Tufts Medicine to meet the very diverse needs of those communities and partnering with local institutions, including our healthcare centers, our health centers. But we need to make sure that we're working together to solve these social determinant health issues, which we can get into greater detail later. Thank you.
Thank you.
So thank you for having me here today. I'm probably the only one that was excited to be here because as a longtime member
I'm excited to be here.
I'm so glad. We're so excited to have you leading us.
Next year.
Excitement is contagious. But as a longtime member of the Healthcare Policy Commission Advisory Committee, I've worked with Dave and the team, and I've had a chance to see the evolution. I've been a CEO in Massachusetts now for 24 years. In a disproportionate share hospital at Athol, in a hospital that closed. Athol was rural, Quincy was disproportionate share, and now an independent community hospital. So I feel like in some sense I've seen it all. That coupled with my background, which was turnarounds, at PricewaterhouseCoopers, the healthcare system is in a state here in Massachusetts and across the country where it's a structural issue, and it's very clear that something has got to give if we're gonna move forward. In my role at Mass Hospital Association, one of the things that during COVID I saw was when we come together, we can do amazing things, and that was played out over and over. As I sat many a times with Mary Lou as we problem solve something together. So I'm confident that we can get through this. And also there's a collective eagerness on the part of our hospitals to work together now, because no one likes where we are and knows that we have to get through this and get to a better place. So, you know, with that in mind, at Emerson Health, it's been a tough year, and we've traditionally done very well, both from a quality perspective and from a financial perspective. But we reached a tipping point this year. And so it all starts with workforce, as you've heard all day. And some of the things that we're doing is not waiting for anyone else to come for solutions. We've reached out and to technical schools, to associate degree programs, and to colleges. We have multiple relationships for everything from how do we train IV techs to how do we have training programs for nurses, how do we become clinical sites to places we haven't been, how do we become training sites for CRNAs since anesthesia is a huge problem. You know, in addition to that, we developed a couple of years ago a make your own program for RNs in our OR, our ED, and our ICUs because we had a really difficult time recruiting. And we're up against the big guys when it comes to salaries. And so it really makes it very tough. We have to work really hard on our culture to make it an environment that you will work at for a little less. And, you know, we think to some extent we've achieved that. Currently, we have an 85% offer acceptance rate for the offers that we put out, but it's really been a full court press in the HR department. We've also worked at maintaining services. So we're surrounded by hospitals that are for-profit, that don't offer all the services that we do. And very often they don't have those services available. So I've got Metro West on one side and I have Neshoba Valley on another. And very often everything comes to Emerson. And for example, we have a deep clinical affiliation with Mass General Brigham, and Neshoba recently lost their oncologist. So we have a huge infusion now of cancer patients who are coming to us. Maternity. So we definitely are impacted by the Health Alliance closure, which for all the right reasons, I believe they closed. When you can't provide a quality service and there is a number, and when I was in consulting, it was 800. If you got below 800 births, you automatically would recommend to the client that that service should close. And so, you know, we have an office in Leominster that we've had for over 5 years, and we've welcomed with open arms. We have a very busy and robust maternity service, those patients to come to our hospital. And we've already seen an influx. It's a baby boom right now over at Emerson. And we were happy to be able to help out UMass, which we have multiple times during the pandemic. And that's the collaborative nature of what I see out there. In addition, women's health. So I see this now through the migrant population. We have 4 hotels that we currently support for OB, for women's health, and for a whole bunch of other things in collaboration with the town of Bedford and the town of Concord. And so that's been our lens into health equity. You know, we don't have very much diversity in the 25 towns that we serve, but this is our chance to show and to make an impact, and we're doing that. Our ED staff, our OB staff have been trained in Haitian Creole and also in what are their practices around healthcare. So when they come in, all the staff knows what's going to make them comfortable. How do they like to deliver their babies? What's the involvement of family? You know, and do we have to bend some of those because it's more a family affair than maybe in other cases? So, you know, we've tried to step up as it relates to that. With our clinical affiliation with Mass General Brigham, we have an amazing partnership where they don't have enough physicians to do colonoscopies. So together, we've sent a letter to many of their patients and said, Emerson has availability, we have a clinical affiliation with them, how can we help? Because we know that if you don't get your colonoscopy, it could lead to a not desirable outcome. So, prevention is much better than having to treat a disease. Also, there's a backlog there in cardiology visits. And so we've worked collaboratively to bring patients who don't necessarily have to go downtown, but let's be honest with you, they drive right by us sometimes, lots of times. And, but we can give the same care in the community because 85% of the care that you'll need in your lifetime, you can get at a community hospital safely, efficiently, and of high quality. So, and then also with our Mass General Brigham Cancer Center, we've definitely stepped up in the region as other places, Metro West included, have had issues there. So, I think that's what we're trying to do. We're trying to be part of the solution, not to contribute to the problem. And how can you help? Well, first of all, I really think we need to engage in a regional planning session. We'll deep sea many sessions. Look at the West, look at Central Mass, look at Boston, and look south of us. Region 5 has got huge challenges, as Amy talked about. And how do we sort of rationalize care across that? Because I truly believe we don't need to be all things to all people. And if we work together, can we parse it out? Also, the consideration of a DISH network, which maybe has separate funding or separate support, because those hospitals having run one, their own set of challenges with that. I won't belittle it, but administrative burden would help everything we've talked about, our physicians, our staff, as well as the insurers' staff as well. And, we know that that's a very high number, like in the 90s, 95% or something of all these things get approved anyway. So do we need fancy systems or whatever? Why don't we give it a go and see if we can just, do away with that? I also think if you could help us with telehealth parity, as you've heard a few times today, that for mental health, for chronic disease follow-up, for our elderly that can't get out, anyone that's trying to drive into Boston, if we can put in the telehealth and get paid for it as a regular visit, that would really help us tremendously, because if we do away with that, there will be an even larger population of folks that aren't going to get the care that they need. And finally, in my market, we do have the introduction of private equity. And one of the things that many hospitals that have private equity in their market is that they tend to bring, and this is for colonoscopies, all the Medicaid to the hospital, and all the commercial payers stay in their center. And that's just not right or equitable. It contributes to our financial challenges. They don't pay into the organizational structures that support healthcare, like the HPC and the pool and things like that. So I think having equity in that across the board would level the playing field for all of this. That's it.
Thank you, Chris. Dr. Tab?
Well, I think everybody's already said everything. So the advantage of going last is I'd echo much of what people have said. I'm not sure I'd echo about the excitement, but it's great to be here.
That's okay. That's okay.
I think this is my 8th or 9th time that I've testified. And I actually bring that up because I want to say two things about that. One is, I think there actually has been a fair amount of change that I have seen in this state, and some real positive change. And I'm also aware that we're still sitting here talking about many of the issues that we were talking about 8 or 9 years ago. And there are a lot of areas where we still haven't made the kind of progress that we need to make. And so I think we can hold both of those thoughts at the same time. So I'd compliment you in many ways for holding at least some of our feet to the fire. And I think that has an effect. We came together 4.5 years ago, and we made some very specific commitments. And I know that we have more than lived up to those commitments, both as it relates to cost and as it relates to equitable access. And we're measured on that. It isn't enough for me just to say that we do it. We're measured on that, and we have exceeded, and we will continue to exceed what we have done. The issues of equity, cost containment, affordability. We tend to talk about those things separately, but they're inextricably linked. You can't talk about equity if you don't talk about cost. You can't talk about cost if you don't talk about equity, and those things all come together. The other thing that I want to say, really to echo what others have said and what Tim Foley said in the previous panel, is that we talk about systems in this state, and frequently when we talk about systems, we mean Beth Israel Lahey Health or MGB, but actually the entire state needs to behave as a system. And we are part of that. We need to be there and be part of the solution, but we're not the entirety of the solution. And too frequently, what I see is that we still work in silos, and we need to break those silos down to really be effective to get the kind of change that we've struggled to get over the 8, 9, 10 years that I've been here testifying. I can turn to what you can do. I think people have brought up a variety of different good things. I want to add at least one additional thing. One of the things that we have struggled with is being able to determine where we have services that absolutely need to be provided and where there are services that are simply duplicative and more expensive. And at the moment, any conversation about moving a service from one place to another, even when services are available within 15 minutes of somewhere else within our system, is almost completely shut down or very difficult to have. And I would actually turn to you and say, we need help if we are ever going to get to a place where we truly are going to address cost. Then we need to have some level of flexibility around not providing every single service in every single place. It shouldn't be willy-nilly. I'm not suggesting that that systems should cherry pick and only provide services in communities that maybe don't need them. But we do need help in figuring out together how we're going to bring costs down and how we're not going to duplicate every service in every area.
Thank you. Other questions before we move on to a deeper understanding of your, well, we're interested in your views on our recommendations and specifically on your view of an affordability index and equity index in the Commonwealth. But before we move to that, other questions on the topic of affordability, equity, and cost control for either the health system leaders or for follow-up on us? Dr. Paul?
Dr. Tabb, in the Boston Globe on October 10th of this year, just last month, you said, our analysis sees that over the next decade, we will see hundreds of millions of dollars in reduction in cost. Could you talk about that?
You're talking specifically about the Dana-Farber Beth Israel, because that's what that was referring to.
Yeah.
Is that your? Yeah.
That's the question.
Yeah. I think it's a pretty simple equation from my perspective. At the moment, and it always has been true, and I believe it'll be true well into the future, Beth Israel Lahey Health, as per CHIA data, not mine, as per CHIA data, is, depending on who you're comparing to, our most expensive competitor is 23 to 28% less expensive. Actually, Dana-Farber for inpatient oncology care, which is what will be provided in this partnership, as per CHIA data on a slide that I don't have in front of me, but I know well, produced by the HPC and CHIA, is less expensive in provision of that inpatient oncology care than MGB, or even than Beth Israel Deaconess Medical Center. So when you bring those two together in this new partnership, first of all, Beth Israel Deaconess Medical Center won't be providing inpatient medical oncology anymore. We're not going to be doing internal competition. Just back to what I said a moment ago about we don't need to be doing everything in every part of our system. We'll be providing all of those things that we are less expensive at, and Dana-Farber will be providing for that inpatient medical oncology piece a piece that they are very good at and less expensive. The math simply pencils out that as compared to the present state, it will be significantly less expensive.
Thank you.
Can I just, I don't want to get into a discussion of it now because we're going to have plenty of time. One thing for you to think about as we go through the discussion is those beds at the Brigham are unlikely to sit empty.
Yeah.
So they're going to come from, say, Emerson Hospital.
Yeah.
And so the net impact is
Yeah.
likely to be higher spending
Yeah.
because we're going to shift more people in net to expensive hospitals.
I suspected that that would come up at some point. I don't know how far we want to go into it, but since you asked, I'm happy to. I think that that's a possibility. I guess my question to this commission is, if you're concerned about a more expensive, high-cost system backfilling those beds, why are you addressing that with me? My position is we are the ones who have consistently been responsible for providing lower cost care, high quality, and we commit to continuing to do that. I don't, I can't speak to somebody else, and I think you need to address that directly with them.
Understood. Other questions from commissioners? So if I could turn to asking you, in addition to the other guidance that you've given us about what we can do you have any guidance for us, responses to our recommendations? We've made 9 recommendations. Certainly feel free to comment on any of them, but we're particularly interested in getting feedback on whether you feel that an affordability index, an equity index would be of value in the Commonwealth, and how you would advise that we proceed on that. If I could start with you, Michael.
Yeah, thank you, Deb. Chiming in first. So maybe I think about a few things as I answer that question. One is I think about we understand so much more than we did, say, before the pandemic. I teach a class upstairs, a health policy course with Suffolk. And one of the first things I do around the equity issue is I overwhelm them with the data. So I tell them 2 and 3 times more likely to die if you're African American of COVID, of breast cancer, of diabetes, to be shot, of trauma, of mental health, of homelessness, of poverty. I spend that first day or 2 overwhelming them with the data. And I think we need to be overwhelmed with the data because the equity dilemma that we have in this country and in this state is one we've yet to address. And of course, to the point that everyone's made, is inextricably linked to affordability, to quality, and we've not even talked about choice, right? The other aspects of this system that we have. So I think what I was very pleased to see in the recommendations is that we're looking at equity and affordability and benchmarking that. One of the key parts, and this comes from a health center perspective, that we have to look at is access within that. I can tell you now, it's a phrase in the African American community I'm gonna share with you, but I'm gonna use it in a different context. We say in advocacy around racial justice that when white America catches the cold, we catch the flu, right? That speaks to the data. That's true for health centers. That the reality is that you heard from other systems when they talk about they can't keep staff, that their finances are in low days cash on hand, operating margins, when they talk about the dilemma they have with inflation. Imagine that the health center is at the bottom of that rung dealing with all those circumstances, and we were before the pandemic. And therefore, our providers are leaving to go upstream to take more money to others in other systems because we can't keep pace with those salaries. Imagine what that means in terms of access. When a health center here, Western Mass, North Shore, South Shore, Springfield, Worcester, doesn't have the core of providers they need to meet the demand of the patient. I'm gonna give you an example of that as we talk about some of what you heard today. If you walk into a health center right now and you're a new patient, you've heard a little bit of this today, 3/4 of the health centers report right now you'd have to wait 80 days to see somebody. Now, again, remember the populations we serve. 70% of them, almost 70% of our patients are people of color. A majority of our patients are low income. They are the comorbidity communities that we talked about during the pandemic that are more likely to be infected, more likely to be hospitals, and more likely to die, and then take all those other statistics around health disparities. And as a result of that, we're facing a unique challenge, and the system hasn't responded to that yet. So I'm excited that the work of the Health Policy Commission is how do we dig in and look at that from an affordability and an equity standpoint. But I'm going to challenge you, Commission, and I'll challenge our legislature. When we started the Health Equity Compact, I called Jeffrey Sanchez, and we were both frustrated after we submitted the Health Equity Report to the legislature. And we quite frankly said, all of this will probably sit on a shelf. No, at least much of it will sit on a shelf, because it was so much that people said, oh, it's boiling the ocean, right? But we felt a sense of urgency. So we reached out, Juan, LaPera, and others, and of course, people started to come. And as we started to have these conversations, we realized that we needed a sense of urgency in the Commonwealth around equity issues, because it is our communities, the places that we come from, that are dying at higher rates, living sicker longer. And the whole notion was that how do we push the state to make equity the next iteration of health reform, which is why I love the title of today's, the next phase of Massachusetts health reform. It should be health equity. So as we talk about DON, spoke to on the House side of DON or community hospitals, as we talk on the Senate side around prescription and addressing pharmacy issues, we need to bundle this all together and do this again, like we did in 58, 305, 224, and finally address this health equity issue. And I would urge us to do what we do here. Although I know we're incorporating health equity into the conversation around cost trends, we need to have a health equity trends hearing. You can consume the conversation just on the issue of health equity. We modeled that in the spring. The Health Equity Compact held a health equity trends hearing where many folks that are here today participated. We need to have that sort of concerted, intentional focus on the issue of health equity. I'd be remiss if I left here today and didn't say this. Rebecca Lee Crumpler, the first African-American physician in this country, she had advice for all of us. She said, they seem to forget there's a cause for every ailment, and it may be in their power to remove it. There's a reason why Roxbury's sick and dying. There's a reason why Springfield, Lowell, Lynn, Lawrence, Chelsea is sick and dying. And we need people to have the same kind of passion that these 80+ leaders do to do something about it now. If the Health Policy Commission incorporates this, and if you can move the legislature to prioritize these same issues, we can lead again from Massachusetts like we did in other iterations of health reform.
Thank you, Michael.
I'm glad the audience applauded that, because I was going to do it myself. And Michael, thank you for your leadership in the Health Equity Compact and the work that you've really done to elevate the importance of this across the Commonwealth.
The only thing that didn't quite ring true to me was this idea that he and others would go away. I'm having a hard time accepting that you believe that, but that's okay. That's okay.
Not going to happen. I think
Not gonna happen.
it's on the agenda, and it needs to continue to be high on the agenda for sure. I would support the recommendations of the Health Policy Commission out of the gate, right? We support all of them. I think we have to think of a couple of things as we specifically get to affordability index indices and health equity indices, is think through how do we make this simpler and focused. And not just continuously add more and more reporting requirements, not just on providers, right, but on society in general. But it certainly does fall on providers to do more quality reporting, more reporting on these issues, and figuring out ways that we can simplify this. Because if we can simplify and focus, we're going to have a better opportunity to actually get to where we want to get to and get there quicker. When we're measuring 1,000 things, we're diluting the energy and the focus. So I really think we need to get together and say, what are the most important things? Elevate those, both from an affordability and an equity point of view, so that we can have the impact that we all are looking for. And we all have employees and staff and private practices that work in our institutions and with us that want to make a difference. And sometimes we create those barriers. So if there's an ask, it's that. It's how do we get really hyper-focused on the things that are most important?
Yeah, very wise. I think that is really part of what led us to propose this, is we understand that providers, plans, everyone running the healthcare system in Massachusetts is trying to focus on moving the dial. But how do we understand where we've started and progress without a common index or measurement of some sort? And I agree with you, keeping it as simple as possible while capturing the realities of what we're trying to accomplish is going to be key, so that it
And
doesn't.
not just
create-
additive, that it actually replaces some of these other things that we exhaust the things that aren't working from a measurement system so that we get more attention on the things that you're developing. Kevin, I know you want to elevate something here. So go ahead.
So I very much agree. I want to add to the plea not to make this more complicated for two reasons. One, the last thing we need is to duplicate now 15 different ways to say the same thing. In the quality arena, that's exactly what happened. I mean, I think we can learn from our mistakes in the past. The second reason that it's important, beyond simply not adding to our burden, which is what it is too frequently we get paralysis by analysis. I don't know how much more analysis we need to say that there are huge inequities in this state and in this country. We have the data already. Maybe what we need to focus on is outcomes and action more than just measurement. So I'm not suggesting we don't measure, but I don't want to spend too much more time proving what we already know, which is that there are inequities. And I want to spend more time not hiding behind the data, but actually making change.
Thank you. Christine?
So I support the 9 recommendations and really have enjoyed the dialogue over the last few years. We kept going all through the pandemic that really, I think, helped inform some of those. But what I would ask is that, go slowly and go gently, and to really recognize that the system is fragile. When you're on the inside of it right now, it's pretty ugly. I'm not going to lie. And I do think, don't forget community hospitals in this. We really are the solution to your cost reduction problem. And so we, in partnership with our academic colleagues, want to work together on this. So I think there's enough room in the state for us to have the tertiary and the quaternary care where it needs to be, and the primary and the secondary care in the communities. And if we continue to suck the lifeblood out of the communities in terms of services, then we're going to continue to see the costs go up. And it's just common sense. And so the community hospitals really represent a big opportunity for us to lower our costs. We are high quality for the most part and much lower cost structure. And then just help us. We really ask, we'll work with you on these 9 things. Don't forget about us in terms of how you can support us, again, on the workforce, the admin simplification. We really need regional planning. It has to be attacked, because if everyone can't be all things to all people, but if we do develop centers of excellence and figure out a way to get people to them, then we're going to lower the cost, because the volume will be there, the quality will be there, and we'll also be able to address the health equity issues. And continue as you're currently on the path of leveling the playing field so that we all have an equal chance of not just surviving. Nobody wants to do this job and survive. We want to thrive, because we're all here because we care about our communities. And I think that was demonstrated, to the nth degree during COVID, how we just did everything we could to make sure that the community was taken care of. And each of us here, and also back at the ranch, really want to be a part of the solution in that. And we want the insurers to be in the plans to be involved with this as well. They weren't very much a part of the work that we did during COVID, but if we're going to succeed, we have to all do it together, as well as government. And I do think that there's a real interest in doing that with us.
Thank you. I feel that. Yes, please.
Christine, I agree with you that what we did in COVID was pretty impressive, how we all got together. I bring up Worcester because I think every hospital, every health center was part of the process. And as soon as we sort of said COVID is over, I mean, we had task force, we worked together, the community was involved. The outcomes were tremendous when we worked together. I'm trying to do the same thing again. And nobody wants to collaborate now. Nobody wants to sit together and figure out how we do that. We talk about how we bring data, all the different entities, how we put our data into a system so we know local community data, so we can work on it, so we can go out into the community, work on the inequities that exist, that there are community health workers that can go out into the community and do some of that work. But we can't get people to sit together and collaborate. They become silos again. And so how do we sit down, our community, for example, how do we all sit together and say, this is what we need to do to work together? Because I think you will save a lot. You will get the entire community involved in this process, and your outcomes are going to be much greater.
So, Worcester's near and dear to my heart. I spent 5 years of my professional career there at St. Vincent's and then Orinda for 6 weeks and then Tennant for the rest of it. So, having really had that experience, there isn't a more wonderful group of people and community that could really come together. You have Eric Dixon, who we work very closely with, who has a lot of amazing, innovative ideas. I think you have to bring the other parties to the table to help to shoulder the burden of the healthcare needs in that community. And I think that goes along with what we talked about with private equity and for-profits. You have to step up. That's part of the mission of a community. I know sometimes the for-profit mission perhaps is a little different, but, and I know it's a tax status, but I think we have demonstrable data in that region where if more beds were open, we wouldn't have the equity issues we have, the overcrowding we have in Worcester at UMass. And so, again, I think working with them, trying to bring those folks to the table would really help. It's such a great community. It deserves to have everyone involved and everyone doing their part. And that's perhaps where government and HPC can help us.
And
They deserve it.
And just one add to that, Dr. Castillo. So when we envisioned the Health Equity Compact, it was never just about filing a bill. We talked about the fact that if you have all these diverse organizations, leaders, C-suite leaders who actually can make the decisions at the table, what can we do together? I agree with you, and I agree with Christine. What I saw during the pandemic was phenomenal. We did it better than much of the rest of the country, right? We got access in churches and in parking lots. We worked across school systems, and community health workers were empowered and engaged. We did phone calling like we do campaigns to get people to come in and get a vaccine. So we learn the lesson, but then we do what we do so well. We go back into our corners. The whole notion behind the compact was really, how do I keep us, what is the table that we can all come together with this passion around this work and do that? So it's not the solution, but it's a solution that the compact envisioned. The other thing is the bill. If people haven't read it, they need to read it. The reality is it's talking about data. How do you collect data? Epidemiology, John Snow 101. We didn't have the data to even respond to where the disease was. So how do we make sure we have the data? How can we invest and go after disease by community? So now we're very intentional about diabetes or heart disease or cancer, like we were about COVID, where we said, no, wait a minute, Chelsea, Worcester, some communities have higher rates of hospitalization. Let's target those communities with the resources to get them what they need. We need to employ that again. And I'm going to encourage people in the Health Policy Commission, chief among them, we need to advocate that the legislature move a health equity omnibus bill to make this that next iteration. I do think we can also work together, but it's going to take having a table where people can come together. And Juan Lapera often quotes Chapter 58 about shared responsibility. You're going to lose some things and you'll gain some things, but we all gain together. Is this notion that we're willing to come to the table. I was working at a health plan at the time. I remember sitting at the table at that time, and we said, well, there's a lot of opposition to this Chapter 58, but we're going to sit at the table and be a part of the conversation anyway. And we'll make the commitment, even though it may hurt our business in some ways. We're going to have that kind of courage again to address these issues.
I'd like to maybe add one other thing, and I know we tend to look at the big cities for leadership here, perhaps. I'd ask us to look up at Lowell. and look at what the Lowell Community Health Alliance has been able to do, the importance of the Lowell Community Health Center, the work that we've done together to start to advance these issues of well-being as a community, not as a hospital, right? It's actually not hospital-led in any way, shape, or form. We're actually trying to figure out ways that we can further support the health center in that way, but that it brings community leaders around the community, as Michael just spoke about, but the community is leading that work. And we have to enable our communities to actually do that work and support that work. And I'll use as an example, just recently, we've kicked off the planning work and the intent to develop a health justice residency program together between Tufts Medicine, the Lowell Community Health Center, to create the workforce of the future that's focused on health justice and health equity. And we're housed at the Community Health Center, but we're working together to support them in that work. And they're leading us as a system in terms of the things that we can be thinking of across the system, participating in our Medicaid ACO and the work that we're doing together. So I think there's expertise that sits in the communities. We can't overwhelm them. We actually have to support them.
Thank you. Tim?
Thank you. I just thought it was really important to reflect back to the earlier panel we had about 3 weeks ago. No, that was a joke. Feels like we've been here for a while.
But we're excited.
Pastor Kiki started out today talking about the impact of the individuals he works with in the Haitian community, working 2, 3, 4 jobs, still not having enough to access the healthcare system, not even access the healthcare system. And he said asked us a question, which was, what will you do every single day to reduce the costs for working families and people of color in this state? Demarius talked about waking up every day and talking to people she works with that said, what do you think it's like to wake up every day and not know which bill to pay? And you're never going to, healthcare is third on that list between rent, paying for supply, food, taking care of their family, and getting to healthcare as a decision point. What do I want to spend money on? Sheila had an amazing presentation. I thought said something that I've been thinking about this whole time, which is, and it was just a statement, and I think it's more of a question that I have. She said, we need to let go of the historical way we're financing healthcare and invest a little bit differently. And so when I think about health equity and affordability, it's intricately linked to financing, and how our healthcare system is currently financed is set up to produce the outcomes it's producing. And until all of us, and many of us in this panel, are willing to lose a little bit in the healthcare financing to make up in outcomes for a population that we have not taken care of, we're just going to keep repeating the same cycle. And so I guess the question is how do we think about a new way of financing healthcare in our Commonwealth if we're going to get the outcomes that we all say we want to get, which is address the issues of health equity? Because in my opinion, change is only going to come but based upon what we pay for. And until we do, we're going to get the same results every single time. And I think that's a really important question for us to grapple with, and not to take away the issue of financing and how we're financing healthcare in this Commonwealth. It's going to drive equity and change if we change how we finance healthcare. And I think it's a really important thing for us to think about, and for all of us, the panelists, to reflect on, is what do we need to do to change how we're financing healthcare to produce better outcomes for the residents of the Commonwealth who've been neglected by our systems.
With all due respect, we can't lose anymore. We're already, I don't think I know of one system that's really not losing. So other things have to be put into place to help us get out of the hole that we're in. It's a pretty dark hole for some worse than others, but quite frankly, just about every system is impacted. So some of those structural things have to change in order for us to have the resources to be able to continue to invest. And so we're all willing to do that, but honestly, that's when I said, go gently, we're fragile. Help us to get to a more stable place so we can then do that work. Because if you layer it all on right now, it's not going to work.
Maybe, and I think about Tim. So first, to the comments earlier to the first panel, that was my family, right? When I think about, Kane Hayes mentioned today that 20% or so cost that is healthcare, that 50+% of that income that goes to housing, right? As we think about the governor's proposal in addressing the housing crisis, when you have to make that tough choice about whether you can pay for that asthma medicine or get that care, those are real choices that families are making, and they're making them at community health center patients across this Commonwealth are making those difficult choices. And I often say, as we think about, and I'll use the frame again of racial justice, that in order to fix something that was intentionally made that way, you got to be disruptive. That means people aren't going to feel good about it. But if the goal is to actually change it and improve it for all the folks in the Commonwealth, then you're going to have to force that conversation. I don't think that we're there yet. I think that there's a resistance to hold on to the system the way we know it to be. But I will tell you, as we then go back to the equity issues, and I wanted to share this because I share this to the class when I say this around equity. I said equity is always competing with something else. It's too much bureaucracy. It costs too much, takes too much time. It's akin to boiling the ocean, or it's disruptive and uncomfortable. So I think this is true about our entire dilemma that we have here. Are we willing to do something disruptive and change the system? And then again, to the Health Equity Compact theme, and do it with a sense of urgency. Because I want you to think about this as you deliberate and have these conversations around cost, affordability, and equity. There are people dying unnecessarily right now, living less years in Roxbury than the South End. You've heard Ayanna Pressley and other people quote that. For us to accept that is disturbing as a Commonwealth. We're not Mississippi, right? We're not Alabama. We're Massachusetts. We can actually do something about it. So to your point, Tim, I look forward to us thinking more about how do we disrupt the system to really address those issues.
The only thing I would add to that is it's not just the healthcare system, right? I mean, if you really look at the drivers of this, we have a responsibility to make sure we're delivering culturally competent care, and we're really thinking about those inequities from an access point of view. But the real drivers here, right, to your point, are poverty and structural racism. And those aren't things that a hospital system or a health system are going to solve on their own. These are societal issues that we need to come together across the Commonwealth and say, we're really going to make investments to start to address the poverty and the structural racism issues and put those on the table. And I think the Health Compact has put those on the table for us. Now the question is, how do we respond to that as a society, not as a healthcare system solely?
Thank you. I'm going to ask you to stay with us, panel, for two more questions, because as you can see, this dialogue has been very helpful to the commission. So we have a question from Dr. Cutler, and then I'll turn to Dr. McGregor.
So actually, I loved Michael's intro to this question because the sense of urgency sort of pervades where my thinking is on this, which is many of you have been here multiple times, and every time we talk about how we do poorly on a number of dimensions. I don't want to think about the cost dimension here because we've spoken about the equity one. So pharma is an issue, and so we get that, and admin costs are an issue, and so we get that. I want to talk about the care delivery part because that's what you're all in charge of. So we lead the nation in hospitalizations. We lead the nation in emergency department admissions to a hospital. We're 14th in the nation in imaging. All of these are, despite a decade of payment changes and work and pushing and so on. So the question is, why are we failing? And should we conclude that that has run its course and what we ought to do is just say, here's a budget, go deal with your budget, we don't care about it, just deal with it, fine? Or is there something that we're missing that would be able to help bring that stuff out of the system? And if so, what is it?
Well, I'm not sure I know the full reason why we're failing, and I agree. I mean, I started by saying I've been testifying here a long time, and it does feel sometimes like we're asking and answering the same questions. But I want to also acknowledge that there has been movement, not to the degree that we want or need, but there has been movement. And I want to give, again, credit partially to to the commission here on holding some of our feet to the fire around that. I think that changing the financing system may well have an effect. I trained and practiced in a different country, in a different system. The truth is, when I'm asked what the difference is between, say, healthcare systems in Europe and the United States is, the biggest difference is we don't have a cohesive, coherent system of care in this country. And that is a differentiator between this country and almost any other that I know of. At the heart of it, what that means is we're behaving rationally in silos. And so there's got to be a way to break down that silos. The financing and moving to global payment is not going to be a panacea. That is a part of it, but it isn't going to be a panacea to an answer to all of the problems. We're going to have to structure ourselves differently. And so in the absence of the state or the federal government telling us to do that, some of us are trying to do that within our systems and making progress, although not enough. An example would be, just as an example, most health systems around the country, certainly those health systems that are anchored by major academic medical centers, provide most of their care at the academic medical centers. And that's where most of the cost is. In my system, at the moment, we provide 55% of the care out in the community, not at the academic medical center. And we have committed to our own board, to our own community, to moving that to 70% of the care. I would wager that that will have as much of an effect on cost and equity and other things as gradual movement around global payment systems. And we need to look at additional things beyond simply talking about when are we going to have 100% global payment, because we're not there, and we'll be talking about that in 10 years' time too. So we have to come up with additional things beyond simply talking about the payment mechanism. I'm not suggesting we shouldn't address that also, but we have to come up with additional things.
Maybe one quick answer to that. So my predecessor, Jim Hunt, when he hired me, he used to always say a phrase, smart money and smart growth. And the reality is to that question, we don't spend money in the right place, right? It is the places where we draw our attention to and patients are ending up is our emergency room and inpatient days. But we know that getting them preventive care, primary care saves costs, saves dollars. 24% lower cost for health center Medicaid patients, $1.1 billion in annual savings in Medicaid that health centers provide. So I use that as an example that if we can get you the services you need on the front end, we won't see you on the most expensive part of our system, but we don't invest in that. I mean, the last governor talked about it a lot, right? The last administration focused on that. We still haven't done it yet. So we're not investing in BH. We're not investing in primary care. We're not investing in home health services. We're not investing in what we know actually works and costs less and saves us money. And I always say the phrase, and Juan repeated it earlier, pay now or pay greater later. So we can invest in it now and pay now, or we'll pay greater later if we don't.
Thank you. Dr. McGregor? Yes.
Can I just add one thing? Because I agree in part with what Kevin said, that global payment alone isn't going to solve these issues. And it goes to the interdependencies Commissioner Foley, you talked about as well, we've talked about already just on our panel. So I think we need to step back and think about what are driving some of those issues. Are we so overregulated in terms of the things that should be done in the home that we can't do in the home, that wind up being admitted? So, right now, I don't know what the number is, but I'm sure that I have cellulitis patients that are sitting in some of our community hospitals that should be cared for in the home, but we're not being paid for it. And we've actually experimented with this under a global arrangement where we have deployed paramedics to keep them in the home and make sure that we have home care set up for them to be safely cared for in the home. It's an expense to the system that we don't get reimbursed for. So when you're struggling financially, right, it's tough to continue to make those investments that we know are innovative, that will change practice over time. And we have physicians that are interested in those things, but the system doesn't pay for it right now. So we have to figure out ways that those investments can actually avoid the use of inpatient hospital beds. But it's not just the hospital's problem, right? It's how do the payers play in that? Where's the accountability there, right? Where's the innovation accountability from administrative cost perspective? These are dollars. The MHA did an assessment. It was about $1.752 billion in administrative costs that we could reallocate to different care models that would allow the avoidance of using inpatient beds. By the way, we're all full. We don't have any capacity on the inpatient. So the incentives are already there. Let's figure out how do we actually find ways to fund these alternative care models.
Right. Thank you so much, everyone, for your comments throughout the day. And a special thanks to the Health Equity Compact, the founders, the members who have been here and have spoken to these issues so poignantly and so incisively and helped to push this discussion where it needs to be. So thank you so much. I want to comment on the topic of the need for regional planning around healthcare resources. Now, this is something that has come up, and it's something that the Health Policy Commission is working to better understand in some of our current analyses. But I just want to comment that I also think that this is a crucial area where equity can be centered in an important way. And I say that because, for example, Dr. Tabb mentioned the desire to be able to kind of determine which services are duplicative and, get rid of them when they're not needed. I think all too often health systems sort of point to the services that are in communities of color and low-income communities and places where the payer mix is not as desirable, and sort of point to those maternity wards as the duplicative wards. And here we see kind of a worsening kind of geographic distribution of inequities. So we see that play out too often. So any kind of regional planning discussion needs to have safeguards in place to prevent that. And I also want to comment on the point that Christine Schuster mentioned regarding, I think this was when you were working at PricewaterhouseCoopers, where the 800 births per year was considered sort of the minimal point. I worry about that number because I think there are so many rural hospitals that wouldn't be able to make that mark. And what do we do with those hospitals? Do we decide that those services aren't needed? We know that childbirth is the #1 reason for hospitalization for people under 65. So this is a critical service, and it should absolutely be treated differently than any other elective procedure. So just a few comments on that note.
Go ahead.
So the challenge with the maternity and having run Athol Memorial for a year is the ability to get physicians to come. And, when you have 2 physicians, no one wants to be on a call every other night. And we haven't really addressed it today, but the workforce has changed. So no one comes in now and says, I want to work like the doctors 10 or 15 years ago. They definitely have work-life balance. And we have some people that don't want to work weekends or evenings or nights. And there are now many more options for them available. So it's actually really hard sometimes to staff the 24/7, 365. And I think that's a real issue. I can speak to, we recently, 2 years ago, opened an urgent care center in Maynard. And we have a facility in Hudson. Those aren't the best payers in my market, but when we did our analysis, there's limited transportation in Maynard, and it was just far enough away from the hospital that we chose to open an urgent care there, and it got busy really fast. So I don't think everyone always chooses that. I do think, though, that if we come together and look at the data, that we can make thoughtful decisions so that places aren't always put in where there's the best payer mix. And also, I just want you to know, in the town of Sudbury, which is a somewhat affluent town, the CVS isn't open there either on the pharmacy on Saturdays and Sundays. So I feel like the labor issue drives a lot of this as well. But I do think with using the data, have it be useful information. Together, we can figure out where things should be, because everything can't be in the W's, the best, zip codes. But I think if we're being equitable across the state, then we can say, you're going to open here, you're going to open here, and then the burden will be shared by all, not just by a few. In Hudson, we opened a center because there was transportation issues there between Worcester and that particular market. So, it's a lost leader for us, but it's busy and it really meets a need. So, not every system functions that way as well. And I just want to share that.
Right, absolutely. And I'm not pointing fingers or making accusations today, but, just something to consider.
So let me start by saying you're absolutely right. There are systems that make those decisions partially or maybe even entirely based on the financial impact that it will have to the system. But I can think of many cases in affluent communities that have duplicative services where it just is impossible, even in an affluent community, to say, you know what, we're not going to provide that there, we're going to provide it 15 minutes away. I think the answer is let's do this in partnership. I'm not suggesting that we should just on our own be able to decide whoever and whatever we want to do. The good news is that's not the way that healthcare works in this state anyway. Let's do it in partnership. And let's make sure that the concerns that we all have about making sure that we don't decrease, but we increase care in communities that have traditionally been underserved are not made worse. But at the same time, that we make sure that we have hospitals and health systems that thrive so that we can make the investments that we need to make.
Thank you. Thank you so much to our panelists. I want to take a moment before we end this session to just play back a few of the themes we've heard. This is not a complete list, both for lack of time, but also we'll debrief afterwards as a commission. So, and correct me if I'm playing these back inaccurately. So first, we're hearing loud and clear that the issues of equity, affordability, and access are inextricably linked, that we together need to consider those as one, and that our recommendations, and we particularly asked you to focus on the affordability index and the equity index, make sense as a way to enable a coherent conversation and measurement of progress, understanding Dr. Tabb's advice, don't let us get paralyzed by that, or both Michael Curry and Michael Dandros' advice, don't get, keep it simple, keep it focused as much on data that we have as a way of getting started and not creating, a new reporting mechanism that is burdensome. We also hear the shared input among, I think, each panelist, that our Commonwealth could benefit from a different type of, an add to our planning process, both regionally and statewide, as a way of understanding our current situation, our need for services, and also more flexibility around, as Dr. Tabb raised, the ability for organizations to work with the regulators to make changes with that state planning information as a background input. We also heard many other suggestions for how there could be a shared responsibility between providers, health plans, and government to take us forward, and a real bias towards action. And starting with the data, as Michael Curry said, and starting with our shared outrage around the situation that we find ourselves in, some of it based on workforce circumstances that are very troubling, some of it based on the equity and affordability issues that we know are challenging us, but to move on from there with a shared responsibility for action, which we're also hearing the energy from the panel and the commitment to that. Am I stating anything? Okay, good. And know that we will also debrief more fully on the issues that you've raised. Your testimony and your participation has been very useful to us. Thank you.
Thank you.
Thank you. Now, I'll take a moment. I do promise to end by 5 o'clock. I know how this is unusual for everyone to need to sit for the full day, and we appreciate it. But for those of you who are interested, I will just offer an opportunity for any of my fellow commissioners to provide their closing thoughts or takeaways on the hearing on any aspect of the day. If people would like to reflect on that.
I'll help you out, Deb. This has been my 9th cost trends hearing, and I have to say I found this to be probably one of the best conversations that we've had in that time. And I think, we started with voices of the community, and those voices were in our ear throughout the day. And beyond the data, it provided a real voice about what's wrong with our current health system. I think also the sort of problems that we're seeing in our health system, as expressed by both the health plans and the providers, have brought us to a new point in terms of honesty, in recognizing that we have some significant problems out there that need to be addressed. I was heartened by the points about planning. Some of us a couple of weeks ago visited a major healthcare provider here, and I think as we walked through the emergency room, we looked at each other and said, everything we do is reactive, and we're not doing the kind of planning that's really necessary to make the health system work in the Commonwealth. So I was happy to also hear that echoed throughout the day. The last point I want to make is that everybody was asked about our recommendations, and I don't think I heard anyone say anything that was contrary to what is in our current set of recommendations. I think the challenge now is how do we turn those recommendations into action? And I just want to make one suggestion, David, is that maybe for our future agendas, we include where are we with the implementation of those recommendations, holding ourselves accountable for moving the needle and getting some real change moving in the system. So my thoughts.
Absolutely.
Thank you. There's any other comments, takeaways? I feel similarly to Commissioner Cohen in that I feel today that we are at a turning point in terms of the next stage of healthcare reform for our state. I feel like there was tremendous common diagnosis in the room around what the current issues are and the priorities, and also on where we go from here. So I think what we take away from this as the commission is that we need to move forward to see how we can take those recommendations forward. And as Commissioner Cohen said, to be very clear about reporting on progress. So I really want to thank all of you who have attended in person today. Having you here, I think, really adds to the energy in the room and to understanding what's happening as we debrief during the sessions. And I also want to thank every one of the participants who has given us both their testimony and also served as a panelist today. And of course, thank you to my fellow commissioners and to Chia and to the Attorney General's office. Much, much appreciated.
And the staff.
And of course, our best. Thank you all. And with that, we will adjourn. Good, really.